Low. Low. Go.
Get up in the morning feeling tired. Sometimes we feel good. Sometimes we feel bad. We go to work, we feel it.
the world is waiting. Move along to the song, singing in your soul. Feel the beat, clap your hands, let's take control. All you need, all you want, are you ready to find your way? Well, every day is a new day, and everything's going your way. And you wanna make it last forever, just keep it together, 'cause it keeps getting better.
Be the presenter, the lecturer as well. Professor Leong from Malaysia
Dr. Shanikan, Professor Wang, and Professor Ponte from Chulalongkorn. Please welcome to the stage, please. The cat lab is ready, so please.
Yeah, okay. So welcome everyone. Good morning. We're gonna have the session on ASD. I think we're gonna start with a live case from the cath lab. Is the cath lab ready?
Walk through life. Every day is a new beginning. Shine your light. It's a day and the world is waiting. Move along to the song singing in your soul. Feel the beat, clap your hands, let's take control. All you need, all you want, are you ready to find your way? Well, every day is a new day. And everything's going your way. And you wanna make it last forever. Just keep it together, 'cause it keeps getting better. Hey, it keeps getting better.
Morning, Dr. Tin and Dr. Man. Can you
Oh,
hear us?
good morning, Dr. Support. We cannot see
Yeah.
you yet.
Okay. Cannot?
Not yet.
Not yet.
We
But
hear
you
you
can
very
hear
well,
me.
though. Yeah, very well.
Yeah. So today we have our team. I'm not sure that you can see us or not. With me, Dr. Borarit from Chulalongkorn, Dr. Cha from Srinakarin Heart Center, and Dr. Wan from Khon Kaen Hospital. And with me, we have Ajahn Cam, imaging echocardiographer. And we have anesthesiologist and our scrub nurse is Kun Jin.
Okay, we can see you
start
now.
the
Yep.
case first. Yeah.
Yes, today we have Dr. Nishanan to present the case. Dr. Nishanan, please.
Good morning, everybody. So today we're gonna start the first case with 76 years old females. She has body weight of 47 kilograms and height is 147 meters. She presented with progressive dyspnea for 1 week and she had underlying disease as asthma, type 2 DM, DLP, and hypertension. Her current medication is as shown. Her physical examination shows normal vital signs and her cardiovascular examination shows systolic ejection murmur grade 2 at left upper parasternal border and wine split S2. Her chest X-ray shows cardiomegaly, prominent pulmonary trunk, and increased pulmonary blood flow. Her EKG shows right axis deviation and incomplete right bundle branch block. The TTE in 4-chamber views show ASD secondum type. So we did the TEE after that. The TE shows secondum ASD with left to right flow in 0 degree and 30 degrees. The ASD diameter is around 10 millimeters. The posterior rim is around 15 to 20 millimeters, and the AS rim is 8 millimeters. In bicameral view show ASD diameter of 10 millimeters. The IVC rim diameter is 19 millimeters, and the SVC rim diameter is 15 millimeters. So in this case, we plan to use the cocoon septal occluder. Thank you very much.
So before we start the case, I think I will ask Dr. Pam to show the echo. We did it before the case, please, Dr. Pam.
So we have the transesophageal echoes. Can you see it now?
Not yet.
Not yet. Can you project the transesophageal echo?
จันแมนได้ยินไหมครับ
Yeah, we can hear very well.
แป๊บนึงนะคะ
We only see
เอา
you,
echo
but
ขึ้นจอหน่
not
อยครับ
the
เอ็กโค
echo.
Wait a minute please
Echo Live
So can you see it now?
No echo yet.
ขอ Echo Live นะครับ
อาจารย์จ๋า could you please tell us about the hemodynamic first and then we will fix the problem with echo
yeah
Okay, today we have a elderly patient. Before we start the case, we would like to know LVEDP first. In this patient, we have LVEDP 11. Yeah, that is a good enough to decide to close in this patient. And we put the catheter to the PA. We have PA pressure is less than 50% of systemic pressure. I think this one is decide our team to close in this patient.
the mean peri pressure is about 23 yeah and QPQS by the echo is about 2.1
2.1. Okay, maybe
and
I'll ask the
LVDP is-
panel if you're okay. I think the anatomy is not an issue here. I think it's the ASD in the elderly. And let's have some discussion from our panelists whether what's your
Can I
practice been? Yeah, okay,
Yeah.
Dr. Liang, go
Yeah,
ahead.
can I start the ball rolling? I've got two questions. Number one, have we checked the coronaries? Because this is an elderly patient with comorbidities. Whether you check the coronaries, if the patient has severe coronary disease, perhaps we should subject the patient for surgery rather than occlusion. That's number one. Number two is the LVEDP. Was it measured with the balloon occlusion of the ASD or without balloon occlusion of the ASD? Your comments, please.
So you ask me or you ask the
Yes,
panelist, Dr. Tin?
Yeah, maybe we could ask the team, the one, the team, yeah, Dr. Supports and team. What, so the first question is about coronary arteries. With the 70 years old come in with dyspnea, whether should we bother checking it or would it change our management?
In my routine practice, normally we don't perform the coronary angiogram as a routine. Yeah. Except that in case we suspected coronary disease. Yeah. So we try to close first, and then if the patient still have dyspnea or ST segment change, suspected coronary disease, so we work up later. Or in another hand, if we highly suspected, we perform the coronary angiogram at the same time of operation for the closure ASD.
I think we kind of believe that
But
we
routinely,
can
we
stent it
don't
anyway if we
perform
have to. But
angiogram.
yeah. And second question is about the LV end diastolic pressure. Is it just one measurement enough, or whether you need to do balloon occluded and remeasure it to see augmentation?
Normally,
of the...
if LV function is normal, so I go ahead, go for the closure with the ASD device. Yeah. Not scared for the heart failure.
Okay. What's your thought about from the panelists? I think just for discussion.
I'm not sure that how high of the LVEDP you do not proceed for the closure.
We usually look at the echo also and believe if there's diastolic dysfunction. That's one thing. And then just to be sure, we try to do an LVEDP measurement. It's easy to do. You just cross the aortic valve and get an LV pressure with the balloon if you want. I mean, I think if the LVEDP is quite low, you probably don't even have to do a test occlusion. But in a lot of the textbooks and some of the people who have done more adult ASD, they usually would like to measure the LVEDP at least baseline.
I think Garrett has something to comment.
Yeah, I would agree with that. I think people with a big adult congenital practice would normally say that, first of all, the diastolic assessment in the setting of an open ASD is difficult. And the practice that we would have would be, in this age of patient, we would check the coronaries, maybe on the table at the time of ASD closure. But what I don't think you don't want to happen is the EDP go up after you've closed the ASD and then not be sure whether that's related to chronic coronary disease or something else. So I think our practice would be to shoot the coronaries and then occlude the ASD either with the balloon or with the device and check a wedge pressure at the same time. And I think your point about what level of EDP is too high, I think it's the increase and the behavior of the EDP after you close the ASD. So if you occlude the ASD, the EDP will probably raise, but then over 10 or 15 minutes, does it dip back down towards normal? So I think looking at the pattern of the EDP on occlusion is important to make sure you don't need the patient to be treated in intensive care and have milrinone and have their LV supported for a couple of days afterwards. And it would take probably 10 or 15 minutes more in the procedure, and in some cases could keep you out of a lot of trouble.
I think back in my center, if you look at the echo, it shows that the LA and RA are dilated. So obviously there's element of this left ventricular dysfunction here. So I would routinely occlude the occlude the ASD, and then check the LV EDP. And then prior to the procedure, I would also do a 2 weeks halter just to make sure there's no paroxysmal atrial fibrillation. If there is any, I will occlude the LA appendage before I occlude the ASD.
Okay, Dr. Pontep, what's...
Okay, after you
Okay, now
occlude
can you
the
see the echo? But we
ASD,
have
how high of
to-
the LVEDP you will not close that ASD?
I would close the ASD, but I would leave a fenestration. I would poke a hole through the device, create a fenestration, just to keep the LVEDP less than 20, so that I can extubate the patient on table.
My practice would looking for augmentation more than 10, after 10 to 15 minutes. I know we can always increase diuretics afterwards, but physiologic-wise, I just want to make sure we don't harm anything, and diuretic is not necessary. If it's avoidable, would be better, yeah.
So in this case, we going to close the ASD anyway, right?
We most likely will close it, I think, yeah. No, but I think it's important in the elderly. In my viewpoint, I think it's easy to close the ASD anatomically wise, but I just want to make sure that we don't do any harm and worsening the athletic dysfunction for this patient or this group of patients, because there are going to be some patients that they're going to get worse symptoms if you close it without clear investigation.
So just a quick chat. Where this ASD is very small. It's 9 to 11 millimeter. Even you want to close the ASD, you want to make a fenestration also, it's going to be, your device is going to be very, very small. You're unlikely to create a significant fenestration. So this is just a ASD, a small ASD. Probably you can leave it. Is there a thought of leaving this ASD at a 76-year-old? This is something to think about, especially your EDP is already very high with the diastolic dysfunction or HFpEF. Is this patient going to be better off with this ASD? Thank you.
In our practice, the patient routinely doing the coronary angiography when the patient older than 60, and we do the balloon occlusion test routinely for the patient more than 70 years old, and always keep the balloon occlusion test with the LVEDP. If it's less than 10, it's okay. From 10 to 20, maybe borderline. We think about the fenestratic, or we use some medication, so-called the pre-treatment. And more than 20, we maybe we don't touch, and we treat by medication. And after 1 month, 3 months, we check again.
That case, you will leave. How long will you leave the fenestration, or you will close it later, or it will close it simultaneously?
We find that the fenestration that we create ourselves on the device actually don't last long. They last for 3 to 6 months, and eventually it will close off. It actually buys time for the body to get used to the defect closure.
Yeah.
So it's good enough, 3 to 6 months, good enough time.
I think that's true. The other thing I think is fair to say that a natural ASD of 10 or 11 millimeters will have a very different shunt profile to a fenestrated ASD device with a 4 or 6 millimeter fenestration. I think the left to right shunt through a 4 to 6 millimeter fenestrated Occlutech device will likely be significantly less than this, and pretty significantly less than a 6 millimeter ASD. the length of the fenestration and the nature of the fenestration means your left to right shunt's going to be less than it would if it was the ASD. So I do think that if the EDP response was bad here, it would be worth considering your approach, which is either a natural, a created fenestration that'll go away, or considering getting a custom-made or an Oclatech fenestrated ASD device and putting that in, because I think it gives you the safety of a pop-off, but also not a big left to right shunt, so you'll help to try and decrease the physiological negative of having a big left to right shunt.
I think this case is a good case for so-called biodegradable ASD device. If we put the device there without aggravated the pulmonary hypertension, maybe the device degraded, and if the patient need intervention in the left side, such as ablation for atrial fibrillation, something like that, then we can leave it. If the patient needs a fenestration, we can create without any difficulty. It's very easy.
Okay. All right. Okay.
I'm not sure that you can see the echo.
Yeah, we can
already
see
or not?
the TEE now. Maybe Dr. Pam can share us. Yeah. Go ahead.
So I'll give you a quick look of the 3D echo. So this is the view of the ASD secundum. It is elliptical shape, and the largest dimension is 14 millimeter by 10 millimeter, as you can see here. And the total flow is left to right shunt with a total septal length of 45 millimeter. And then I'll give you a quick look of the four chamber view. So that's right heart dilation, as you can see here.
The maximum diameter is 15.4.
And then trivial tricuspid regurgitation, trivial mitral regurgitation.
So, okay, I think in terms of device sizing, maybe we could ask the panelists, what's your thought? If we're gonna close it, what size would you pick? Or would you need anybody still do balloon sizing, or we just close it? Okay. All right.
I think the hole is not a big problem. The small hole and the rim is long enough, and for the technical issue, it's not a big problem. But we always ask you about the diastolic LV function. Did you do anything to check any dysfunction of the dysfunction of the LV?
ODP is 11.
I'm not sure that if the patient have diastolic dysfunction grade 2, do you have to close it or not?
Yeah, probably not a severe degree of diastolic dysfunction. Do you have the E to E prime from echo, at least? E to E
I'm
prime.
not sure that we
Maybe
measure or
Dr.
not.
Pam can check it.
But E by E prime.
I would have to
Anyhow,
caution.
LVDP is only 11.
I have to caution because having a diastolic dysfunctional LV with the ASD is like a Luton-Barker syndrome. A lot of times when you check the E and over E prime or check the LVDP, it's falsely low because it's offloading through the ASD.
Yeah.
So it's always prudent to just occlude it before we assess the E to E prime or you check the LVDP. That's my take.
Did I hear you right that the LVEDP now is 11? You measured it just now?
Yeah, it was
11?
on the table 11. Yeah.
So, I mean, you don't even need a second catheter. You could just put a balloon catheter in and take the wire out and then measure the pressure in the LA through that. So from the point of view of adding to the procedure, there's multiple ways of doing this that don't create a lot of hassle. It takes 5 minutes and it would give you a lot of reassurance from the point of view of how the patient would recover. So I agree with what the panel's saying completely. I think that the additional step of checking the EDP after occlusion is, in a patient of this age, really important and gets to the crux of why the patient's on the table in the first place.
But can we at least get the direct left atrial pressure measurement?
I myself, I will cross it.
Yeah, you already crossed it, right?
With the device, and no need
with the
for
device.
the balloon sizing or occluded test.
Okay.
Yeah.
Now, why don't if we
You can
cross
put
the
a
device, we can
a
close it,
pigtail.
and
Yeah,
then we can
we
measure the
cross the
LVDP
wire
before
already.
you unscrew it. Shall we do that?
Maybe you can cross the aortic valve, put the pigtail in the LV when the
Yeah,
device is
we
there, so
put the
it's nice.
pigtail inside the LV
Okay.
and
Yeah, let's do that. And
simultaneous
then,
measurement of the left ventricle
yeah,
pressure.
we close it. You don't unscrew it. Measure the LVDP
Yeah.
for 10 minutes.
Yeah.
If it doesn't increase, we deployed it.
Okay.
And the video is okay. Come back. Okay, go. So, what device have you guys choose? Maybe you could tell us about.
We plan to use 20
mm device?
device.
Large one.
Yes, 20 mm.
Okay.
Yeah, 20 mm.
Okay, maybe the panelists can make few comments.
I saw a 3D measurements about 13, almost close to 14 by 9. I will probably use a 16. The rims are firm and they're not flimsy at all. So 16 is probably, and I will not balloon size.
Could you tell us a bit about the sizing criteria for this device for some of us who don't use it? Because how is this device sized compared to an Occlutech or an Amplatzer device? Because some of us aren't familiar with it.
It's the same. Cocoon is like the same as the Amplatzer.
Dr. Support.
Yeah,
Dr. Support.
อาจารย์พรเทพ
Why you use 20? Because the largest diameter is 13.6 something, right?
That measured by the 3D imaging. But in my experience, the 3D usually less than 2D measurement. The maximum from the 2D is 15.4 millimeter.
Okay.
So we decide to use 20 in this case.
So you have the 2D diameter
Yeah,
of
2D diameter is
15.
yeah,
16.
15. This is
But it's oval.
This picture is 1.49, but some measurement we measure at the 15.4 millimeter, the maximum.
Okay, thank you.
The ASD is ellipsoid or oval, yeah? And so usually you tend to add just a few millimeters, 1 to 2 millimeters at the widest diameter in an oval ASD. You become more generous in a circular.
How big you choose, Jonas? 16.
Yeah, that's why 14 was the biggest they showed me, so I would just add about 2 millimeters, so a 16.
Too cool.
I guess you want 18, right?
For
me,
I would go for 18 as well.
18.5.
You like that number, 18?
In my experience for the cocoon, yeah, I would add for 4 to 6 millimeter for the maximum diameter we measure.
So this is a small, relatively small ASD. Are you going to do it with or without fluorone?
They already have fluoro, I guess.
They already used the fluoro, so it's not counted.
Yeah.
Such case, in my practice, I would have 2 venous access. One is in pulmonary wedge, and another for occluder. Yeah, will be safer. LV.
Yeah, Joku, I think that's either a wedge pressure or the LV, one of the two, because then you can monitor it at every stage. I am interested in the comment about 3D underestimating the size. I would say the opposite. I think 3D tells you what the maximum elliptoid size is, and I think if this is sized the same way as an Amplatzer or an Occlutech, then I'd be looking at a 15, 16 millimeter type device for this. I'm interested that the team have gone for a 20. I don't quite understand the logic.
In my practice, I have a lot of aging patients. I use the same method as Dr. Man said. I just use device but not deploy until I observe the patient LVDP. Normally, I wait for 10 minutes, 15 minutes. But in the normal case, I just
Yeah, but as Garrett mentioned, our experience with 3D, usually I think it's get a little bigger even and give us more comfort zone. So I don't oversize as much with the 3D compared to 2D, and we don't use balloon sizing anymore, but we would do balloon occlusion in this case.
What about, again, the last comment's interesting. If this is a small defect, therefore the balloon is fine, but for a bigger defect, putting a big balloon in the left atrium, I think sometimes can mess up the hemodynamics. So although it seems expensive, what you're suggesting of putting the device in place, which then doesn't interfere with pulmonary vein drainage and mitral valve inflow, etc., I find a bit more reassuring to measure the EDP or the wedge pressure with the device rather than a huge balloon sitting in the left atrium. So I live in America, so we're allowed to waste lots of money, but we will put the device in place, like you said, and measure the wedge pressure at that point rather than using a big balloon in the left atrium, which I think can affect the left heart hemodynamics, although it may seem wasteful.
Yeah, you risk if it's...
So sometimes we change from the balloon occlusion test to device occlusion test.
It's just quite a bit more expensive, I think.
Well, I think the big balloon shouldn't cause a problem because usually this patient would have had a big, very big atrium. So even if the big balloon, 34 millimeters balloon sitting there in the atrium, it should be fine. Usually we'll block it off and then you just wait for a while, 5 to 10 minutes. So it doesn't do anything with the hemodynamics. It's fine.
All right, so you guys deploying the device?
We lost the signal from your side.
Freeze.
Yeah. Okay. Yeah.
The video is freeze.
You can see the fluoroscopy?
No, everything
Unmanned.
is freeze. Maybe they will...
With Cine Live. Okay.
Everything stopped.
We deploy the SD device. Yeah. Okay. I'm not sure you see the angle or not.
We are on the image is almost frozen, and I just hear your voice. I cannot see live.
Okay. ขอ angel live หน่อยครับ
No, we cannot see.
ขอ angel live นะ
There is some technical problem with the video live.
Yeah.
Maybe we switch to the lecture first or something. Up to the panelist. There is some problem with
that was the most exciting part of the movie.
At the critical moment.
All right. Dr. Support, can you hear us? Oh, the video, the movie freeze. So we can hear you, but we cannot.
Freeze. Okay.
Yeah, maybe.
Can you see the echo?
No, we see nothing.
Not yet.
So can you? Maybe we'll deploy it and we'll monitor the LVEDP and we'll come back to you. Why don't we have one first lecture, if that's all right?
Okay.
Okay.
ACT เท่าไหร่194นะขอเพิ่ม1,000นะเพิ่มไปแล้ว
And I would like to invite Dr. Jonas, our friend from Philippines. She wants to talk about the special consideration in ISD closure for small children. Now, Jonas, please.
Hello, good morning. I would like to thank the organizers for inviting me, especially Supa. Yesterday, Shaq said that you don't turn down the invitation of your friends, so that's why I'm here. The other thing I wanted to tell you was about 5 or 6 years ago, we were here in this hall, and this used to be the cath lab. Dr. Tin and I were changing there at the end of the hall. I remember those paneled glass where we looked outside while we're changing into scrubs. Anyway, I was tasked to give a short talk on device closure of ASD, special considerations in small children. These are my disclosure. I would say I tend to be conservative in dealing with small children. In our center, we have used different ASD occluders. The Amplatzer was the first one. Then we have Cocoon, Hyperion, Memopart. We also had a chance to use Seraflex and Occlutech. And this talk is partly from inputs from my colleagues whom I actually asked. It is a fact that transcatheter closure of ASD is feasible and effective and relatively safe in adults and children. Elective transcatheter closure of large ASD in small children remains controversial. And there are two types of interventionalists dealing with large ASDs in small kids. Either you're more on the conservative side or you might be the more aggressive type. So to begin, what is considered small children? If you look at the literature, some papers will use the cutoff of 15 kilos, so anything less than 15 kilos is considered a small child. Some will even go further, those less than 10 kilograms. Some papers will not be very exact, and they would just label it infants and toddlers, and I've seen ages between less than 2 to as old as less than 4. Now, what is the current attitude or practice of most pediatric cardiologists? And I asked some of my friends who are practicing, and most of the time they say that because there is spontaneous closure in ASDs less than 8, much so less than 6 millimeters, they will usually advise parents just to wait, especially if this ASD was discovered early in life. They will recommend closure for asymptomatic children at age 4 years or older. Asymptomatic infants, therefore, with significant ASD shunt are typically followed until they have grown to an acceptable age and size. Recent guidelines recommend transcatheter closure after the age of 2 at least, although commonly practice suggests a weight of over 15 kilograms. Some interventionalists will use a cutoff of 10 kilograms, and so I have asked some of my friends, and I asked them what will be your minimum weight, and they usually will say at least 10 kilograms. Symptoms have to be present to consider early closure in these infants and toddlers. And I guess I told you that there's still controversy in closing large ASD. I think more so on how big or how large an occluder are you willing to put, how bulky an occluder will you accept in a small kid. And therefore, we usually recommend early well, other interventionists will say they would like to recommend early closure, especially in moderate-sized ASDs, because they fear that it might get larger to a point that it is less feasible to close this in the cath lab in the future. There is an increasing trend of closing ASD percutaneously earlier than 4 years of age, even when asymptomatic. This is brought about by improvement in technique. I mean, we have learned so many ways now on how to deal with the problem. Of course, refinement aside from refinement of skills is the improvement of the material itself. And more interventionalists are pursuing closing large ASDs in small children with acceptable rims. So what is considered large in children? Large ASD? Some literature will say an ASD diameter in millimeters, which is at least 1.5 times or more the body weight. So that means if you're a 10 kilogram, if you have an ASD of 15 millimeters, that can be considered large. 20 millimeter or more in children less than 15 kilos. And the number 25 usually comes up in a lot of interventionalists. Anything 25 and above in a kid is considered large. By body surface area, large ASD in children is 20 millimeters per square meter. Right now, the indications for ASD closure in children, you have to divide them. Either they are asymptomatic or symptomatic. So they're asymptomatic at least 2 years old or above. The weight should be 15 kilograms. There has to be signs of right ventricular volume overload, and the QPQS is at least 1.5. A symptom, however, if the infant or small kid is symptomatic, then you can be more aggressive, and you can even accept children less than 10 kilograms. But symptoms mean these babies or infants or toddlers have to have heart failure uncontrolled by medications, frequent respiratory tract infections, at least about 6 times a year. A lot of them are NICU graduates or ex-premature infants with bronchopulmonary dysplasia and ASD, although they have other medical problems. ASD puts some hemodynamic load, and extubation sometimes might be difficult, which forces you to actually intervene earlier. Babies who have failure to thrive. And in some patients with pulmonary atresia intact septum with borderline RV, closing the ASD early on to eliminate right to left shunting can be done. Now, what are the anatomical issues in small children that may affect ASD cath closure? Of course, the smallness of the femoral vessel, specifically the femoral vein, that may limit the use of bigger delivery sheets, the small heart itself to accommodate large occluders,
Of note is the small left atrium, which leaves us a less wiggle room to manipulate a relatively large LA disc. The atrial septal length, which used to be measured in the early recommendation, may not be long enough to accommodate the disc without touching the atrial roof or the AV valve. Of course, in smaller kids, you have thinner walls, which can easily be perforated, which can cause erosion, which can be catastrophic. So the atrial wall and even the pulmonary vein vessels are quite thin. The rims in some of these babies or infants are flimsy. They're not thick enough to support heavy devices. There's also of note, sometimes when you are using a relatively large device and this cable puts a lot of tension in this atrial septum that distorts the picture and sometimes can actually put some doubt to you if you're ready to release the device or not. And of course, if something happens and the device embolizes in the small kids, you need to put a bigger delivery sheet sometimes to be able to retrieve it. That even become a more difficult problem. And so in general, small children have a higher risk for complications. This is pretty much the standard cardiac cath protocol. In small children, transthoracic echo can be used because their windows are quite good. Some can still use TEE, those with the neonatal probe. Most will do under fluoroscopic, but I know some friends who are doing non-fluoroscopic ASD closure, especially some friends in Indonesia. You measure the rims and the defect in different views and take the maximum diameter. You also take note of the flimsy rims. You use the smallest delivery sheet possible. You heparinize during the case. You use the smallest occluder possible that can close the defect. Balloon sizing is usually optional and it's not necessary. Modification of the technique may be needed, either balloon-assisted technique or using the right upper or left upper pulmonary vein. And aspirin is usually 3 to 5 is used about 6 months post-implantation. A couple of 3 or 4 articles that I found in the literature looking at small children weight less than 15 kilograms, and the recurrent theme of these papers is just to give some caution that we have to be careful in these kids because they seem to have more complications compared to children more than 15 kilos. In this publication in Pediatric Cardiology in 2017, they say that percutaneous ASD closure can be performed safely in low-weight infants, although the risk of procedural complications is slightly higher compared to larger children. And so therefore, careful considerations have to be taken and then try to really see if there's an indication to intervene in these kids. Another paper which looked at the retrospective, the experience of 9 tertiary institutions in France, wherein they concluded that peri-procedural and delayed complications were significantly higher in children less than 15 kilos and those with large ASD. Another paper by Bartakian and al., this was published in Denver, Colorado. They identify 128 patients meeting the criteria for closure, less than 15 kilograms, and their conclusion was it is highly successful to do this in small children, but there was, again, an increased rate in complication for these kids compared to those more than 15 kilos. And so there is, in a way, a recommendation that if closure can be delayed, it is more advisable to delay it when they are about 4 years of age. And lastly, a paper by Frank Ng and al., a friend in California in 2012. They looked at predictors of success, and they identified that an ASD size to patient weight ratio of less than 1.2 was associated with a successful ASD closure, and the reverse is true. If it's the ratio is more than 1.2, it is associated with more failure. So, having said that, more and more interventionalists take the aggressive approach. They close ASD even in less than 10 kilograms as long as they are symptomatic. The septal length now is not an important measurement that they take into consider based on their experience, and to them, the most important determining factor is the adequacy of the rims. Occluders more than 1.5 to even 3 times of the ASD, of the body weight are now being placed. A good friend of ours, Dr. Bharat Dalvi, had this paper published in 2019 in the Annals, and looking at transcatheter closure of atrial septal defect in symptomatic children weighing less than or equal to 10 kilograms, and he said he would like to address unanswered issues from a decade of experience. So the issues he addressed were how large is too large, how to choose the device size, does the length of the interatrial septum matter, what are some technical modifications needed for successful deployment. And this was his experience on 45 patients from 2010 to 2018 using an Amplatzer septal occluder with a 2-year follow-up. 43 out of 45 had successful closure. The mean weight was about 9 kilograms and mean age of about 2 years. The largest defect close was 27 millimeters, and the largest device that they placed was 28. More than half of the patients had to have modified technique. So they do first the conventional approach, but a lot of them, more than 50%, will have to have the balloon-assisted technique or the upper pulmonary vein technique. They did not have any mortality, no embolization, thromboembolism, or erosion, although they had 1 patient with a moderate mitral regurgitation and 2 patients had a transient AV plaque. Their conclusion was defect size as large as 3 times the weight can be closed in small children, and devices as large as 28 millimeters can be deployed in these hearts, provided that the surrounding rims are adequate. And in majority of the cases, one of the modified techniques is essential for successful deployment. Another aggressive group, this time the group of Dr. Alain Fraisse, and this time it also a multi-center experience, in France and in UK, 6 European centers. They looked at this time a device weight ratio of more than 1.5. I told you that ratio is being used whether to say if the ASD is large or not. And these are symptomatic patients, 40 patients with a median age of 30 months and 11 kilograms. The median device size ratio was, median device size over weight ratio was 1.7. They had successful implantation in 39 out of 40. And they had minor complications of 10% cases, whereas severe complications was 5%. Of note was when I was reading the paper, I was struck that 1 patient, a complete AV block happened, and it didn't go away in spite of medical treatment, that they have to surgically extract the device. And there was 1 patient, one of their younger, a smaller kid of about 5 kilograms who had thrombosis of the inferior vena cava. So the conclusion was percutaneous closure of large ASD in small asymptomatic children is feasible with acceptable rate of complication. I mentioned the complete heart block because I was looking at what complications can happen in these small children, and these are pretty much the complications we see also in adults: embolization, erosion, thrombosis, and vascular injuries, much so in the smaller kids. But it left me an impression that heart block, which is something that you usually think of when we do percutaneous VSD closure, is something also that have to be considered when we are doing ASD closure in large ASDs in small kids. A lot of these articles mention that transcatheter closure with a very large device is considered a high-risk procedure, especially when ASD device weight ratio is more than 1.5. Looking at complete heart block, usually it happens in patients with a deficient rim in the atrioventricular valves and a small distance between the right atrial disc and the tricuspid valve, which will constitute risk factors to injure the AV node. Even soft devices like the GORE, the helix, may cause enough pressure on the AV node if they cover the Cox triangle, and decompressing the AV node by removing the pushing device in an early state may provide the best chance of complete recovery from complete heart block. Risk factors of AV block in ASD cath closure in small children with large ASD: the defect itself, the size, the device height ratio of more than 0.18, larger devices, short distance of the right atrial disc to the tricuspid valve, a deficient posterior inferior rim less than 5, and again, a weight of less than 15 kilograms. So I asked some friends, again, give us some tips on how we can stay out of trouble and ensure a higher chance of success when dealing with small kids with large ASDs. First order of the day is there really an indication to close the hole in these small kids. So the key thing is you have to justify that they have really symptoms, and in spite of medical treatment, you have no more time to wait for these kids to be bigger. So they have to be symptomatic. And if they are, the important measurements to consider will be the size of the defect, the septal rims or the margins. The usual posterior, inferior, superior vena cava rim should be at least 5 millimeters, and they have to be firm. The aortic rim can be deficient. The AV valve rim should be 7 millimeters so that they're always away from the mitral valve. This septal rim measurements, to me, is the most important. The length of the septum is something that I normally will measure, but now some people are saying it doesn't really matter. I measure it in the 4-chamber and bicaval views. I measure it not really to influence me if I'm going to close or not, but I think it's more of trying to make me be aware that the amount of material you want to place in this small child. The ASD diameter over weight ratio, the ASD diameter over body surface area, and the ASD occluder size and the height of the patients. These are some of the measurements that come to mind that you might want to consider. So when should you not attempt to close ASD with device in small children? Definitely those with deficient or absent IVC rim, those with deficient posterior rim, especially in a large ASD, those with deficient AV valve rim in a large ASD that will affect the mitral valve function, the ASD device and height ratio of less than 0.2, which is at risk of heart block, the LADs that is more than 20% of the septal length. This is something that I consider, and an acute AV block during implantation. And how do you size your ASD, or what type of size occluder will you be using? The general term is the smallest occluder possible that can close the hole. You want less metallic material in those small kids. For oval shape, you use the actual large diameter measured on echo and add 1 to 2 millimeters. For rounder shape, you might add 2 to 4 millimeters. And again, for our practice, an LAD should not be more than 1.2 times the size of the atrial septal length. Other catheter-related procedure tips, we have found out that Occlutech and Seraflex, wherein the occluder can actually tilt at its pivot, in its connection at the cable, is more user-friendly, especially in dealing with small kids. The reason is because of it can pivot freely. There's really not much jump. The position that you see when the cable is attached is pretty much the same position that you will see when you release the device. It's always nice to have that security when you are dealing with the larger ASDs in small kids. Always be aware of the LADs when deploying in the left atrium. I have seen one operator and did not mind that the LADs was so large and ended up like having a perforation. For balloon-assisted technique, we have used lower profile valvuloplasty balloon. And be careful in using pulmonary vein approach. Be mindful of the sharpness of the edges of these relatively stiff devices. Again, parting words, always remember in handling small children that this device, actually, as the children grow, the ratio of the device to atrial septal diameter decreases. So in some ways, you can actually put a relatively large device. And as they get older, the edges of this occluder will be farther from the roof. A new onset pericardial effusion in a deficient aortic rim should be closely monitored. And sometimes it's already like a red flag that there might be some form of erosion. Long-term follow-up is needed, or monitoring is needed in these patients. Attention to details. Operator experience is crucial. And if you feel like this patient might have complications and it's really a high risk, you can always go to your friendly surgeon. So in summary, transcatheter closure of ASD is feasible, effective, and relatively safe in smaller children. The adequacy of the rims is the most important parameter in determining suitability. They are more at risk to develop complications, so you need to be very careful. Occluders, as much as 2 to 3 times the body weight, has been shown to be implantable. Heart block, although rare, is a complication seen in large occluders in small children. Close follow-up is needed, and you should only consider doing small kids if they have significant symptoms. Thank you for your attention.
Thank you. Let's move back to the cath lab. I think you've been waiting. Thank you. Can we get the cath lab? Yeah.
จันแมนได้ยินไหมครับ
Yeah, we can hear you now. Could you
Okay.
tell us what
So I am not
happened?
sure that you can see the angio or not.
Yes, we do.
Okay. So this we deploy the SD device.
Cocoon number 20.
Cocoon number 20. Yeah. And after deployment, left ventricular end diastolic pressure is a little bit up from 11 to 16. Yeah. And we wait for 10 minutes. And then now it's 14. Yeah. And we check the echo. Ajahn Pem.
And then, so this is the echo. So here is before the deployment. And then now this is after deployment at 0 degrees. So the device is sitting at the like good position in every rims, as you can see here, which is 40 degrees. There's no leakage of the device and no residual ASD. And this is by cable view. So it's well seated.
And I think the 20 is a proper size for this case. Yeah. Not too big. Yeah.
And then we check the aortic rim. So it's not compressed any aorta. And the patient has like the same amount of the AI as before.
Yep.
And this is to show the function. There's no effusion.
So great.
And
I think
then
it looks good. Any comments from the panel? Any?
Dr. Sufot, on angiography, I saw that the first attempt is seemed to the device totally deployed in the left atrium, right?
Yes.
And
the first deployment, we most all this left and right atrium is in the left atrium.
Yeah, everybody
So
have the
we
same question.
go back.
Compare with other device. I asked Dr. Bontep, Cocoon device. It seems the clamping force or recoil force is higher than others. Is this right?
For the center waist or not? For what? You
When
mean the
you
recoil?
deploy the left side disc and
Yes.
deploy the right side disc,
Yes.
the device tends to move back to the left side a lot compared with other, right? It's a so-called the recoil.
I think because they push the cable forward to make sure that it can flatten.
I see.
Yeah, I think that. Yeah, but anyway, I think after you completely detach the cable, a little bit not flatten of the device, but most of these cases after 1 year it will flatten because the radial state, the radial force of the central waist will expand the ASD a little bit later.
Dr. Sufot, everybody mentioned about you use a device a little bit oversized. You can convince everybody by make the cine and measure the waist of the device. Is it really the oversized or not?
I'm not measure.
Yeah, now you can do.
Yeah. I'm not sure that it's accurate or not because we have
LAO view
calibrate with the
yeah.
pigtail, but it's not so much accurate. Yeah. But from the echo, อาจารย์ทำได้เท่าไหร่ฮะ Echo measurement is 15. 15 millimeter. Yeah. But you can see that the flattening of this is seem to be not oversized. Yeah. You can see that. Yeah.
Jonas, you happy?
You like I like 16, but you like 18. But no, it's always nice to see a flatter device to begin with when you released. But mention about the LVEDP from 11 it went to 16. what will be your next step if that happens? Obviously, it's not more than 20, so that's something that we can do medical management. What do you do usually in these patients once there's an elevation of the LVEDP?
Normally, we looking for sure. I think if the augmentation is more than 10, usually we don't deploy the device if we check it beforehand. I think it's increased less than that. I think we just depend on the symptoms and decide. I think it should be okay for this case. It's just for discussion, but and also for the youngster to cautiously look at this before they just close it, because it's relatively not an issue of closing, but whether should be closed.
Do you, the day before the procedure, give diuretics in these patients?
Normally, we don't give diuretic for the patient. Yeah.
This
But
case, we receive
some case we have
furosemide 20
1 or 2
milligram
cases,
per day.
the patients
before.
develop heart failure in the ward after 3 or 4 hours later, after we close the device. So maybe 10 to 15 minutes, not enough for waiting. So you have to observe, yeah, if you consider for the heart failure after device implantation. Yeah, I think that is the key message.
I think when I close this kind of ASDs, my concern is whether I can extubate the patient on table. When I extubate the patient, will the patient go into pulmonary edema? Do I need an ICU bed as backup? So I always look at the LVEDP. If the LVEDP is more than 20, I'll be very, very cautious in extubating patient on table. I would get a CCU bed, get the patient ICU, and then dry the patient up over the next few days before extubation. So that's
so this 16
I'm quite
now,
relaxed.
right?
Yeah, we just extubate on the table and go to the ward, and then you can treat the patients in the ward. That's fine.
Now it's 14 and 8. Finally, it's
All right.
8.
I think we'll be okay for this. Definitely will be fine. Okay. Okay, thank you. Thank you very much.
Okay.
Nice case.
Yeah. Thank you.
Okay. All right. Thank you.
I think Go want to ask a question with regards to the closure of small bed.
Yeah, Jonas.
Yeah,
sorry, Jonas. I saw in your slides that in the small children, you would like to use Seraflex and Occlutech device because of the device can move freely because of the attachment. Or should we err on the size of Unpluxer, because Unpluxer has a slightly 1 or 2 French size smaller French for the long sheet? So which one do you prefer now with the Treviso cable as well? So in the smaller children, which device type you will choose or brand you will choose now? Yeah.
That's a very good question. The advantage of, let's say, the Occlutech and the Seraflex is this pivot. It can move, right? And that aligns the septum quite well. But the disadvantage is you usually need one size, French size bigger, which sometimes can be a problem in smaller kids. So if size is not an issue, then we tend to use the one that is tilting. It's easier.
All right. Thanks, John.
I'd like to weigh in on this. I don't do a lot of ASDs in small children. I tend to do it if the patient has chronic lung disease and oxygen dependent, can't wean the patient off oxygen. But if I were to close this kind of ASDs, I would tend to go for the Unpluxer. Reason being, number one, they use a smaller sheath. Number two is that if you measure the thickness of the device, Unpluxer tend to be thinner. Yeah, it tends to be thinner compared to the Seraflex or Occlutech.
In our experience, we tend to use the Unpluxer in the smaller kids.
Yes.
Yeah, lower profile, I agree,
Yes.
and they need a smaller. And the cable, the Treviso cable is a game changer in a way, because now you're able to align the occluder more parallel to the septum.
Okay, thank you. Let's move on to the second live case. Supa, are you ready?
Yes, I'm Larry.
All right.
Can you hear me?
Very well, and see you too. Okay.
Okay, yes, I'm here with the Dr. Ratapon, from Thammasat University. Yes, and Vacharapon from Queen Sirikit Heart Center, Khon Kaen. And also Doctor support are also with us. Yeah.
Doctor support is
Because-
everywhere.
Yeah, doctor support is everywhere because this is a case of the ASD with severe pulmonary hypertension in adult. Yeah. So I will let my fellow introduce the case for you. Yes.
So this case the case
Okay,
of
Dana.
41 years
Ven
old
jongอะไรอะ
female.
อยากเห็นจอ
Her body weight is 50 kilograms and her height is 158 centimeters. She presented with progressive dyspnea for 2 years. Her functional class is class 2. She had no previous underlying disease. Her current medication is as shown. Her physical examination shows normal vital signs, and her cardiovascular examination shows systolic ejection murmur grade 2 at left upper parasternal border, wide and fixed split S2 with RV HIF. Her chest X-ray show no cardiomegaly, enlarged coronary trunk with rapid tapering. Her EKG shows right axis deviation with incomplete right bundle branch block. The echocardiograms in full chamber view shows right-sided chamber enlargement, no RV hypertrophies, and there's a CMTR with TRPG 140 millimeter mercury. In right and left heart cath before start sildenafil shows the QP-QS ratio of 1.8, the RPRS ratio of 0.5, the PVRI index of 10 Wood unit per square, the PVR is 7 Wood unit. After that, we giving the 100% oxygen, the PVR went down to 4 Wood unit. 2 months later, after start the sildenafil, the QP-QS is 1.8, the RPRS is 0.34, and the PVRI is 9 Wood unit per square. The PVR is approximately 6 Wood unit. After given 100% oxygen, the PVR went down to 4.8 Wood unit. Here's the TEE in 0 degree and 30 degree as shown. The second numb SD, the diameter is 50 millimeters, and the posterior rim is about 9 to 10 millimeters. The AV valve rim diameter is of 6.2 millimeters, and there is no AS rim. In bicameral view, the SCD diameter is 21.8 millimeters. The IVC rim diameter is 11 millimeters. The SVC rim diameter is 5 millimeters. In this case, we plan to use Octotec ASD fenestrated device. Thank you.
Yes. Can you show the echo today? Yeah.
Yeah, this is the transesophageal echocardiogram. The four chambers show right atrial and right ventricular enlargement. There is mitral regurgitation. From 0 degree, we can see the defects of ASD. Mild to moderate tricuspid regurgitation was observed. And this is the short exit view. We will show the defects of ASD. We measure the defect of ASD from this view is around 20 millimeters. The superior rim is around 10 millimeters. This is the pulmonary veins is okay. And
16 ค่ะ 19 16
this is the bicameral view. The IVC rim is around 14. The defects from this view is around 14 too. The superior rim is around 12. And the total septum from this view is around 35.
Okay, great. So maybe before we proceed with the closing, I can ask the panel. So this is another good scenario case for ASD with pulmonary hypertension. With I just summarize it quickly that after testing and some medications, the still significant left to right shunt. Pulmonary pressure is still high, but the PVR is kind of in the borderline zone, just below 5. What do you guys do for this case? Would you close it with fenestration, leave it, or what do you do?
Could we put the hemodynamic slide back up just while we have this discussion?
Okay, sure.
Is that
Can
possible?
we do that? Can we show the hemodynamic pressure, the one from the PowerPoint
Garrett,
presentation?
we will not show yet. Yeah, we want you to discuss first. Yeah. If you see the data like that, yeah.
Oh.
What is your management? Yeah.
Well, the data confused me a little bit. That's why I wanted you to put it back up again, because I was trying to make sense of it and I couldn't. So.
Okay.
Okay.
Shall we go back then?
Okay.
With the PowerPoint.
Okay, PowerPoint, please
Hemodynamic
show hemodynamic with, to Garrett. Yeah. Cha, show the PowerPoint, please. Not to.
Okay.
Oh, yeah.
Okay. Yeah.
Yeah, that's the one. Is this the one, Garrett?
Yeah.
Yes. So, okay. So the QPQS didn't increase with oxygen. The PVR didn't. The indexed PVR didn't really change. It's within sort of, inter-observer variability, but it's a little bit. Although the interest in the diastolic pressure in the pulmonary artery seems to have, or the separation of the pressure seems to have improved a little bit, but I'm slightly surprised that there was a drop in the QPQS. I don't know whether that's a reassuring reactivity test or whether it just means there's no reactivity, but the patient might be better off without the shunt.
Was this test was just giving what did you use to check?
oxygen.
Just oxygen, yeah? You didn't use anything else. Super. In your
Yes.
lab, you just use
Yes,
100% oxygen?
Yes. Yes, in my lab, I just use the oxygen saturation. Yes. Oxygen. Yeah.
I think this borderline response to oxygen inhalation, the PVR reduced about 20%. So I think still there is pulmonary artery activity, reactivity.
But wouldn't you expect, just like what Garrett said, that if that's the case, the QPQS should also increase a little bit on 100% oxygen? I mean, it's almost the same. I think that's what you were bringing up. The PVR dropped, but the QPQS actually pretty much was the same.
Because maybe bidirectional shunt, so that's why that QPQS didn't change.
Well, it's probably a good reason to use a fenestrated device, because if you had a very, very positive result to oxygen, you could have just closed the ASD. So maybe this, I suppose the point I'm making is, I don't think this is a really good result to a hyperoxia test, and therefore I would use a fenestrated device. I think this is borderline, like you said, the diastolic pressure in the pulmonary artery didn't change, which I think is often a worrying harbinger. So I think this is a good reason to use a fenestrated device, because the oxygen response wasn't that good.
Gareth, I tend to have a different take. If you look at the ECG shows RV strain, and this is a patient with ASD with severe pulmonary hypertension. I always have very high respect for ASDs with pulmonary hypertension. I think it's a real ASD. Usually the shunt will not be big. The patient won't go into pulmonary hypertension. Just look at the patients previously. The 70-plus-year-old lady with ASD, still the patient doesn't develop severe pulmonary hypertension. In this case, it's a young lady, severe pulmonary hypertension, near systemic PA pressure. Even if you point a gun at my head, I won't close this defect.
Even with the fenestration?
Even with the fenestration.
Okay,
I think...
Okay, we have Dr. Tomita, yeah.
Dr. Tomita from Japan. There are some comment. First, there is a lot of measurement and calculation error if you use the 100% oxygen reactivity test. So that in our practice, we use MRI, 100 oxygen loading test to calculate QPQS separately from cath lab. And in cath lab, we usually use nitrogen gas.
Nitric oxide?
Yeah, nitric oxide. to evaluate reactivity. But anyway, maybe diastolic pulmonary pressure is a good indicator of pulmonary vascular resistance. So the 30 millimeter mercury diastolic pressure, I think it is responsible pulmonary vascular bed.
You. Hello. I had totally agree with you because I have many patients and I think don't close the ASD in the young lady with pulmonary hypertension and not big hole. I have some patients like this. We close it after the patient have a pregnancy and it's terrible. Yeah, please don't close it.
Okay.
Just the other thing is the patient there's no evidence of a right to left shunt at any point. The patient is fully saturated at rest. Does the patient desaturate on exercise? Because I mean, if we're really worried about this, at the moment the patient's purely going left to right with no evidence of any reversal of the shunt. If on exercise the patient was blue, then I would be more with you. But I think here there's a progressive left to right shunt, and we should try and decrease it with a fenestrated device.
Okay, another comment?
Yeah, I think I asked this to Supa before this question. I still, to echo Dr. Hideshi before, to use 100% oxygen, I think all the times the calculation can be way far off and you get a spuriously good results. Because most of the time we didn't take into the diluted plasma oxygen in the calculation. If you put it there, that will be, your calculation will be way difficult and way off. So I find that the 100% oxygen usually give you a very good QPQS and a very good PVR or PVRI. So therefore, I find it we will give you a kind of false reassurance to close this ASD. I think I know Supa, you think you have taken into account the calculation, but I find it too overwhelming for me to calculate. Yeah.
Okay. Can you show us the cath results after sildenafil as well? Can we show us that? Another PowerPoint? Would that persuade the panelists one way to another? Can you show the PowerPoint again? Yeah, but with the sildenafil for 2 months, would that make anybody change your mind or? Okay, Dr. Ponte.
Pressure overload now, but after you cause the ASD, you can diminish the left to right shunt and you decrease the right ventricular volume overload. But anyway, you can you may not reduce the right ventricular pressure load, right? But if you have like a fenestration, say that if this case go advance into the pulmonary vascular obstructive disease and Eisenmenger, at that moment, the patient may need a right to left shunt. Anyway, you have a fenestration, and at that moment, if you think that fenestration is not big enough, you can dilate it later to make it bigger.
Is it easy to make it bigger?
With a stent, why not? You put a stent in,
Yeah.
right?
Yeah, so I agree with you. I think the other thing here, and I think you're alluding to it, is if you think this patient has got reversible pulmonary hypertension, then you want to treat her with pulmonary vasodilators. And if you treat her at the moment and are successful, you'll just drive the left to right shunt, which will probably have a negative impact on the pulmonary vascular resistance, which then you're trying to treat with sildenafil. So I think the idea of cutting down the shunt to a minimal left to right shunt, and then you can aggressively use vasodilators and try and get as much reversibility out of the pulmonary vasculature as you can. So, I go back to what I said. I think if the patient had right to left shunting at any point on exercise, I'd be a bit more worried. But here, if the patient's pink at all times, then I think it's reassuring from the point of view of decreasing the shunt.
Can I ask a question? Can you actually use also in a way a test occlusion when the device is already there? Measure the PA pressure. Is there anything there, let's say a further drop in the PA pressure, since you're saying you eliminated the left to right shunt, and see if there's a significant change in the PA pressure, which will make you move towards one direction or the other. I'm asking, because this is like an acute change, so is this something that is translatable to real life?
Got it. Maybe it's some different from developing countries. Inside the cath lab, we have no weapon, just only oxygen. How can you trust? And now also, yeah, we don't have a nitric oxide. We don't have many weapons.
Oh,
and John, that's also the good idea. Yeah, your idea is very good.
We could
Just put
start.
the-
I have attended some pulmonary hypertension meeting, and I felt so stupid when I said we were using oxygen as the only vasoreactive agent, and everybody was looking at me. It's like that's an agent that is fraught with a lot of errors. You cannot estimate the oxygen consumption really accurately, because you're giving oxygen different when they are on room air. So I had the impression that sometimes 100% oxygen, the conclusions that we made based on FiO2 of 100%, is not always correct.
I don't know whether I'd be so hard on yourself. I think you can use 100% oxygen as long as you're aware of the potential problems. And I think if the patient isn't very anemic, then the contribution of the dissolved oxygen in a patient like this is not going to be. If the patient's got a decent amount of hemoglobin, then the majority of their oxygen content is going to be bound to hemoglobin. If the patient's got a hemoglobin of 6, then it might be a different story. But I don't think. I think although, again, the calculations are fraught if you're using 100% oxygen, I think it does tell you something. And I hear what you say, Tim, but from my point of view, the key thing here is clinically, before the patient gets to the cath lab, if the patient is pink with a left or right shunt, then you're unlikely to get them into trouble by decreasing the left or right shunt and leaving a fenestration. So I actually would be pretty minimalist about what I would do in the cath lab here, and I'd look at the patient clinically, look at the patient's oxygen saturations on exercise, and use that to determine whether or not to put a fenestrated device in.
Robin.
Yes, I'd like to respond to Jonah's comment about assessing the PA pressure after occlusion. Because I think most of the time for these borderline cases, they will respond. Their PA pressure will drop. But I have quite a handful of cases, just as Leon has mentioned. After closure, say 6 months down the road, even if we treat the patient, the PA pressure just shoots up. They become very severe pulmonary hypertension, alpha dysfunction, alpha failure, and then the whole things just go down the road. So it's difficult, even if you have this so-called acute reaction from the cath. So the other thing is about the oxygen. Yes, there's a lot of fallacy, and when I was at Great Ormond Street, they actually did this hybrid MRI studies, Leon would know, and they have used this oxygen calculation, and it's all over the place. There is no rule at all when you use 100% O2. And finally, about repeating this reactivity study after starting sildenafil or other pulmonary hypertensive medication. Again, this adds to the variability. Nobody knows exactly what would happen with you're on oral medication and you give oxygen or even nitric oxide. So the so-called vascular reactivity after these sort of pulmonary hypertensive medication is again something else. There's no good data to suggest what is the best cutoff.
So you're saying it's not really predictive of what's going to happen in real life when this patient goes to a stressful situation?
Yes.
I was looking at the X-ray of the patient.
Let's, sorry, just for the sake of time, let's go back to the cath lab and let's see what Supa thinks.
Supa, a very interesting discussion about the close or not close. And if you close, how can you predict the pulmonary pressure increase or not? And but how about your decision?
Can we get back to the lab, please? Okay, so we cannot hear you. Okay, speak again, please. Still cannot hear. Okay, we see you now. Yeah, go ahead.
Okay, yeah, okay. May I share something? I think for the area of the severe pulmonary arterial hypertension, we change our strategy along the way. I think from the 10-year past, I also changed my strategy a lot. Yes, for this patient, first, I would share that to me, I have the nitric oxide, but I don't use in the cath lab because one is very expensive, and two is no parameter that tell us what is the response that will we have not enough data because most of the data that show the PVR or PVRI is come from the oxygen. So that's the reason that I did not use the nitric oxide in for the pulmonary vasoreactivity test. And for the trace occlusion, yes, I do in some case. I'm pretty sure that this case, if we put the device, it might not decrease of the PA patient not much because this patient from the chest X-ray and also the clinical is clearly show that the patient have two problems, the ASD and the pulmonary hypertension. They have two disease inside this patient. So we have to treat both of them. And for this patient, my strategy is because the mainly of the patient is the problem of pulmonary hypertension. So I treat the pulmonary hypertension first. Even look at the hemodynamic data, I'm quite sure that we can close even after we use the sildenafil just 2 months. The PVR is less than, is around 6. Even the ESC said that it's supposed to be 5, but from my experience, if the PVR is around 6, PVRI is not more than 8. The patient quite safe for, in the series that I follow up. So in this patient, I treat for 1 year, and after that, her clinical quite improved, and we will show you the data today after we give the sildenafil 1 year. Okay. And please show the hemodynamic
Thank
data
you.
today. Yeah.
Today hemodynamic in the room air.
Did you see the screen? Yeah.
Okay.
Yes.
So PA pressure is 75% of aortic pressure. PVR is 6.2, PVRI is 9.2, and QPQS 1.6. RP2RS is 0.3. And after we give 100% oxygen, the PA pressure decreased to 64% of aortic pressure, and PVR decreased to 5.8. PVR is decreased to 3.8. PVRI is 5.6, and RP2RS is 0.08.
Okay.
And QPQS is increased to 0.3.
Okay. I will show you a bit because there are a lot of hemodynamic. Please show the hemodynamic. Left hand side is in the room air condition. It's quietly see that the PA pressure is lower than the aortic pressure. Before we give the oxygen, it's around 75% of aortic pressure, and the mean PA pressure is less than 40. And your right hand side, after we give the 100% oxygen, it shows more reactivity of the patient. The PA pressure is around 64, and the mean PA pressure is to 34, and the diastolic pressure is a little bit lower than before we giving the oxygen saturation, and show the hemodynamic data on the screen.
Can you make it a bit bigger?
Yeah.
Zoom.
Because it's a lot of number, yeah. So, oops, sorry. So no hemodynamic data. Okay, yeah. This okay. Is this okay? Can you see the number? Yeah. Because we use the oxygen, and we know that many assumptions that will cause the data, the number error. So one thing, when we give the oxygen, we make sure that patient don't have the acidosis, and also all the data should be calibrated. Also the LV and diastolic pressure. And if you see this in the room air, as Dr. Ang
Oh,
said,
yeah, that's good.
yeah, okay.
So, Supha,
The-
maybe for that, let me ask the panelists earlier that
Yes.
they kind of prefer not to close it. Dr. Liang is one of them. Would you, once you see these changes, did you change your mind, or you still not, or what do you think?
The thing with hemodynamic data is that, you know, if you look at a lot of studies give you different numbers of closure. So it gives you different numbers of cutoff, which means that there's no actual number, there's no actual golden number. So we always look at the patient as a whole. We look at the ECG, whether there's RV strain pattern. We look at the brownish pulmonary artery size. We look at desaturation. We look at hemoglobin levels. If the hemoglobin level is 18, we know this patient has occasional left to right to left shunt. In this case, I will be very, very reluctant to close this. So I wouldn't make my decision based on this hemodynamic data. Your thoughts?
But like nobody's talking about closing it. We're talking about decreasing the left-right shunt by leaving a fenestrated device. Do you still think this patient needs this size of an ASD, which is giving them a chronic left-to-right shunt? Or would you not agree with closing it down to 6 millimeters to try and decrease the left-right shunt and allow them to have a pop-off?
I feel that eventually they will need ERAs, they will need prostacyclin without closure of ASDs. No? So we are looking at a resource-limited country. We are just subjecting the patient for additional resources without changing the outcome. That's my take.
But you will change your mind, close or not?
Reducing the size.
Reduce.
Changing the word to reducing the ASD size.
Can we have a look at the ECG? I noticed that from the echo, there's ECG tracing. Can we have a look at the ECG, please?
The QPQS here is 1.56.
CT.
Yeah, you look at the tracing, there's still RV strain. I'll be very reluctant to close this.
Already, I guess, Supha. So, what's to proceed? That's for the discussion. But at the end.
Okay, show the hemodynamic
I have
data
one question.
Oh, okay. Dr. Prantev had a question. Yeah.
Okay.
Yeah.
In this case, if this with this pressure finding, are you going to use a fenestate or regular device?
100% oxygen.
100% fenestrated device.
Sorry, I say in the cath lab. Show
Would
the
you think differently?
hemodynamic data of 100% oxygen. Yeah.
Okay, for the fenestate device, I think we smaller the SD size. In this case, we small is from 19 to 5, right? But if we can predict that in the future these finestates will be caused later, or even it will not cause, it still have a small left to right shunt. And in some case, it's at a window for, like in some case, not for like a pulmonary hypertension, but for the, like a PFO aspect, it may have the paradoxical emboli. So it still have the window between right and left heart, right? I have to ask some opinion about the PA pressure, that what level of PA pressure that we need fenestration or recommend for fenestration.
If I personally make a fenestration, if the mean PA pressure is above 30, yeah, I always make fenestration because depends on how high the PVR. If PVR very high, like this case, I will make 2 fenestration to ensure that, after 6 months, I will recast this patient. If the patient needs fenestration, I put a stent in to make it patent. Yeah,
and when you make it, how big is the fenestration?
8.
So 2 holes of 8?
Yes.
Oh, yes. Okay.
Joe, could you ever just to try and hold it open longer? Do you ever use a stent in the fenestration, or do you just guttle away at the PTFE and spread it apart?
Sometimes we make suture. Yeah, that suture that make ensure that the fenestration is pretty open.
And you do agree that's just from a financial constraint point of view? If you had access to a fenestrated ASD device from Oculotech, would you agree that's a better way to maintain a good fenestration? Yeah? Because here, I mean, Supa's going to put something in here. You can tell she's got the bit between her teeth. Nobody's going to stop her. Maybe the next question, the next question is going to be: are you going to put a 4mm or a 6mm fenestration in here? Because have you thought about that, Supa? What size of fenestration are you going to go for? Because you've obviously got the device open on the table behind us. You're just not showing us.
You'll make the fenestration about 1/4 of the waist. 1/4 of the waist. Then,
Super. I think it's a very interesting discussion. You cannot wait for the finish the discussion. You go ahead with your case and your decision.
So which device do you prepare? I know you are too ready, more than ready to close it.
I'm not a stubborn girl, yeah. Actually, because the PVR is less than 5, so I think it's reasonable to close this defect. And one reason that I will close the defect because in the treatment guideline of the pulmonary hypertension, if we can decrease the RA pressure to less than 8 and also the mean TA pressure less than 40, it can give the patient more survival. In Japanese published, if the mean TA pressure is less than 40, you can keep the patient 10 years survival. So that's the reason why I close this defect. So yeah, I will show you the device that I want to close. And of course, I will do the fenestration in this case. Yes.
Okay.
Because the size, yeah, the size is 19, 16, 16. So what the size if you want to close in this patient? For me, I select 24. And this is the this is the Finetes ASD. Yeah, lock, you have to lock. Yes, okay. This is the 24 fenestration device from the ASD. I use the custom-made fenestration because it keeps longer patency. Previously, the patient that I closed with this device is 6 years. Now, the whole still patent. So I think it's better than we do by ourselves because mostly after we put the hole in the device and just we grab for the sheet, the hole is disappear. So I think the reason that I use the custom made is better for the longer patency. And it is the same from the Oculotech device that this is a new delivery system of them. Yeah, it's a gunshot. So after you grab for the device, you need to lock. And when you want to deploy, you have to unlock by pushing this button, yeah, forward, and then you slowly release. Okay. Yes. Okay.
Super. This is Warren. Very interesting case. Just for teasing you, I'm not sure whether it will be more stubborn or not, but in case that Joku said that perhaps 2 fenestration may be a little more effective. Well, definitely this one has a very well patterned hole, one hole at least. But I'm not sure whether if you want to make sure that somehow the patient may need more relief initially, if you can just put another hole by yourself, to make it bigger. Not that one, but another one, and try to be like insurance kind of things for you and the patient.
For me, honestly, I want to say that the hole is not the big stuff in my mind. If I think the patient supposed to be not close, I will not quote anymore. Yeah, because I think even 6, even 8, or even maybe 25%, I think it might not help much. So if I'm not sure that this patient is very severe, I rather not close rather than close. However, I think for this patient, because they also have some flow and also the reactivity is still decline. That's the reason why I try to close, and we don't want to abruptly closing. That's why we put the fenestration. Yeah.
Super, this
How
is
about your
Jonas. What
opinion?
size fenestration is that? What is the size? Super, what's the size of the fenestration in that 24
6, yeah, 6. Can you show
Six.
the graph? Yeah. On the screen that you see that? Yeah. It is a 6, yeah. Because it's a custom made, so it's already at a 6 millimeter. So firstly, sometimes I want to use the 8 millimeter, and I select the large device. However, even you use the larger device for the aim of the bigger fenestration, the hole will squeeze the device. I mean, the atrial septum will squeeze the device and cause the fenestration in the device smaller. So I think 6 is okay. Yeah. Okay.
What size of device you use, 24 or 27?
24, then 24. Yes. Dr. Ratapon now introduce the device into the patient here. We have to check a little bit of the clot because we waiting too long during we do the right transmission. And Dr. Nakarin and Dr. Kaiwas, please tell me if you see the clot inside the sheet. Yeah. Okay, now Dr. Ratapon is deliver the device. Okay, more. Yeah. We will deliver the device until reaching the tip of the device, and then we're gonna slowly pull the system back while we open the left atrial disc. We will fully open the left atrial disc. More. Yeah. To open more. Okay. Now it's reached the atrial septum, and we will open the right atrial disc. Oh, it's deep. Grab. Okay. Yeah. Okay. More. Grab. ดึงหมด 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 แล้วดึงให้หมด no, no. ดึง 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 เดี๋ยวนะ เดี๋ยวนะ ใจเย็น 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 ดึงเข้าให้หมดจ้ะ ใจเย็น ใจมันอยู่ที่ไรเอเตียน ใจเย็น ดึงให้หมด ดึงให้หมด มัน ดึงให้หมด โอเค โอเค
Jonas, regarding to the technical issue, the defect is no aortic
The
rim.
aortic rim is deficient, so I would try to deploy the ASD more towards the right upper pulmonary vein.
Yeah.
Okay.
Supa, you don't have another
Yes.
catheter in the right side just to measure the PA pressure after occlusion, right?
Yes, yes, we do prepare for that. Yes. Big cable ถอยชีสจ้ะ
Just for while we're waiting for deployment, do you think the location of the fenestration make difference? For example, if you leave it at 12 o'clock, 6, would it be better? Because one thing we talk about paradoxical emboli, and we know that it usually comes from the leg, you know? Yeah, I'm not sure if we can...
So your question is more towards will it cause...
getting a little too complicated. Okay, that's okay. Yeah, I don't... Okay.
But I think technically it's very difficult to align your fenestration where you want it to
Yeah,
be.
I guess so. We
Do you think you've got any control over that? I've never thought that I would be able to actually,
I come from a TAVI world. Now, commission alignment is the key. And if you put a marker on where the fenestration is, you can.
Okay,
I'm
good to
sure
know.
we can.
I don't
Getting a
think
little
I'm that
crazy.
clever.
Yeah. If it make difference though, because
SVC เหรอคะ
Okay,
น้
all
อง
right. So
น้อง
we
ต้อมอยู่
deploy
SVC
from
หรือ
the
อยู่ที่
right upper
ไลท์
pulmonary.
pulmonary vein จ๊ะอยู่ที่ไลท์ SVC หรือไลท์ fully vein เอ่ยน่าจะไลท์ full น่าจะไลท์ fully
Yeah.
vein นะ
Looks better.
โอเคได้แล้ว
Okay.
โอเค stop to roll
Good.
yeah now the device is fully deployed yeah Dr. Gaiwat and Dr. Nakarin please check whether the position is okay or not.
Can you show the echo image bigger?
Yes.
Nice jet across that fenestration.
Yes. Now the echo show you the SVC rim is okay. Can you put it down to the IVC rim? Yeah, the device is grab the rim. Okay. Yes. Okay. Can you and yes. Can you go for the 30? Yes. I think it's well fitted. Yeah, in the aorta and also the posterior rim. Okay, can you go for the full chamber view? We will check the PA pressure for all you guys. Yeah, whether how the PA pressure was. Yeah. Any comment? Yeah. For the position, I think we are happy with the position of the device. We will show you the pressure of the patient.
Yeah, I think you did very well, but there are some young interventionists here, and you can you explain what can you change your practice? At first attempt is prolapse anterior, the device prolapse anteriorly, but what can you do? What did you do to avoid the prolapse?
Okay.
You can talk to everybody, a young generation, they can know.
Okay, yeah. If you see in the live, when we deploy from the left side, we open the left side of the disc. The device is tilt a little bit, and the good good thing that we use the LAO cranial. If we see the device in the circular shape, not the size of the device, it can tell you that you already sleep of the device inside the right atrium. So the second time we still do the same, but it still show the sleep. So I change the position of the guide wire and the sheet into the right upper pulmonary vein and slightly open for the left atrial disc first. Yeah, as you see here, we go to the right upper pulmonary vein and we slowly open for the left atrial disc until the left side and also the waist is already completely out. Yes, as you see here, if you see the alignment is like this, we see the side of the device, it shows that the alignment is okay. And then you fix the waist and open the right atrial disc and then rapidly close, the right atrial disc. Yes.
Jonas,
Yeah.
why you choose the right pulmonary vein technique? not the left or the balloon assist technique or some other techniques.
Again, in patients with aortic rim deficient, getting into the right upper pulmonary vein will prevent the LA disc from prolapsing into the RA. You get farther from the deficient aortic rim if you come from the right upper pulmonary vein. If it's the rim is more deficient in the posterior or inferior rim, you tend to do the left upper pulmonary vein technique. But sometimes even with that, it's not always a guarantee. And so sometimes a balloon assist technique also can be very helpful in deficient aortic rim. But you need another catheter for that. But right upper pulmonary vein seems to be the simplest way of first trying it in an aortic rim deficient ASD.
I think one of the advantage of the Ocutech device is when the open in the left side, it's like a bow-like, right? So it's easily aligned, with the atrial septum. So I think this is the advantage of Ocutech device.
In your experience, Doctor?
Okay, guys, may I interrupt a little bit because it's time constant. Yeah, I will show you a bit about the hemodynamics after we putting the device. The LVEDP is not much increased. It's from 9 to 12, and the PA patient now is around 63%. Yeah, the same as we give the 100% oxygen. Yes, I think I'm happy with this, and also I think we will not stop for the pulmonary vasoreactivity duct, of course, because we think this patient, even we close or not close, the PA patient will still progress. Yeah, because the patient have the pulmonary hypertension disease. Yeah, not just the ASD.
Okay.
Yeah. The last step, I will show you how to deploy this device, and we're gonna leave you and you can discuss more. Yeah, okay. Yeah, this is the, when you want to unlock, you push forward. Yeah, and we'll show you. Yeah, she unlocked the bottom, and yeah, now, okay, she be pushing. Yeah. Okay. Okay. The beautiful of the Ocutech delivery system is will not jump anymore because the balloon and the biotome is quite can move freely in everywhere. Yes.
Okay. All right. Thank you, Supar. That's a great
Thank
case.
you.
So I think for the interest of time, we are running late already. We still have to lecture. Okay. A big round of applause.
Thank you very much.
Yeah. See you soon. So let's go to the next talk by Dr. Tomita on special consideration ASD closure in deficient rims. Please.
Please show my slide, please. Thank you, Warren Spa, and organizing committee to have me such a lovely meeting. This is my great pleasure. My topic today is special consideration in ASD closure in deficient rim. This is my disclosure. This is a report from a Japanese group. Kijima reported location of rim deficiency and success rate of transcatheter ASD closure. No rim deficiency is only around 20%, where aortic rim deficiency accounts for approximately 70%. IVC rim and AV valve rim deficiency are relatively uncommon. Success rate of transcatheter closure of ASD is quite high in no rim deficiency, 100%. Aortic rim and IVC rim deficiency, while when complicated by two rim deficiency, success rate may be low, they reported 50%. This slide shows two major serious complications of ASD closure, that is, device erosion and embolization in Japan. Despite various efforts, these complications have not become zero. There has been 0.2% of erosion and 0.5% of embolization as reported in the literature. In the literature, following issues are reported in limb deficiency. Aortic limb, high risk of device erosion, deployment is occasionally difficult and needs some special maneuver. IVC limb, risk of device embolization, occasionally difficult to visualize by TEE. Limb deficiency extends to anteriorly to AV junction may be high risk of heart block. SBC, limb deficiency extends to aortic limb is again high risk of device erosion. Posterior limb deficiency extends to AV limb is high risk of again device embolization. AV valve limb encroachment onto AV valve and subsequent mitral or end or tracheal valve injury. Today I will touch on aortic and IVC limb deficiency. First, aortic limb deficiency. Takaya, again, Japanese group, it reported aortic limb deficiency in 72% of ASD, while completely absent limb 23%, and deficient or hypoplastic limb 49%. Success rate of device closure was 92%, while no difference between absent and deficient limb. McQueenie also reported, however, wide range of aortic limb deficiency is the most common findings in cases of erosion as reported by Amin. McQueenie also reported relatively large device size in aortic limb deficiency is common in cardiac erosion. However, Kitano reported a Japanese risk comparing to US study, erosion in Japan occurs relatively late. Early erosion is only 25%, and with smaller devices. This in A, we retrieve the device as both discs approximately while array disc looked impinging the aorta. In B and C, disc spraying around the aorta. However, still array disc looks impinging the aortic wall. These two cases were complicated by device erosion. After introduction of Figuraflex 2, which is much softer than Amplatzer, Kitano reported that Figuraflex 2, which is 4 to 6 millimeter larger than balloon sizing diameter to make flared and straddle shape at the aortic side disc in cases of wide range of aortic deficiency and septal malignment may avoid the risk of erosion. This is a 29-year-old lady of ASD with aortic limb deficiency. This HOT measurement, the largest diameter 17.9 millimeter, superior aortic limb was deficient in wide range. But there was some alignment of the septum primum. Stop probe measurement is 18.8 millimeter. We used 27 millimeter Figuraflex 2 to make a flared and studying over the aorta. She is doing well without any signs of erosion 3 years after this procedure. Guo Home ASD occluder became available in 2021 in Japan. In the assured clinical trial, there was a significant number of wireframe fracture. However, at this moment, no device erosion has been reported. This is a 8-year-old, 27.8 kg girl with bowed aorta and 2 holes. The maximum diameter of the main hole was 19.3 millimeter, while the accessory hole measuring the 7.3 millimeter. That move, but we used 44 millimeter Guo Home ASD occluder. The main hole was closed, nicely spraying over the aorta, while inferior accessory hole was closed as well with a single device. Next, inferior limb deficiency. Takaya et al. Reported posterior inferior limb deficiency in 14% of 869 ASDs, while complete deficiency in 44% and incomplete deficiency in 10%. When the maximum ASD diameter is smaller than 38 millimeter, which is largest unprocessed septal occluder available in our country, 100% success rate for incomplete limb deficiency, and if the complete deficient limb area smaller than 30 degrees, and defect diameter 38 millimeter, success rate was 96%. This is a 6-year-old boy of complete inferior limb deficiency with ASD diameter 20 millimeter. Unprocessed septal occluder 22 millimeter was successfully deployed. This is a 30-year-old boy of complete inferior limb deficiency with a maximum ASD diameter of 29 millimeter. Akinab also showed IVC limb deficiency. We intended to grow this ASD using 34 millimeter unprocessed septal occluder combined with Revisio delivery system to catch deficient inferior limb securely. Akinab also shows a device called the inferior portion of the limb securely. This is a 6-year-old girl of hypoplastic posterior inferior limb with an ASD diameter of 17.6 millimeter. Fibula flex 2, stop flow diameter 22 millimeter. Fibula flex 2 was successfully deployed. However, she complicated by complete AV block 10 hours after the procedure. We suppose a lighter arterial disc might have compressed AV node following the both discs had become compact in 10 hours. In conclusion, aortic limb deficiency is the most common finding in cases of device erosion complicated by transcatheter closure of ASD. In general, device oversize should be avoided to prevent impingement of the aorta by either LA or by aortic disc of the device. However, intentional oversizing of the figure flex 2, which is much softer than the other device, to make flared and straddled shape at the aortic side may potentially prevent impingement of the aorta. Guacardioform ASD occluder may be another solution. Incomplete inferior limb deficiency or complete in narrow area can be mostly closed by the device. Intracardiac echo may be helpful to evaluate the inferior limb as well as stability of the device after deployment. However, it may be a risk factor of the heart block. Thank you for your attention.
Thank you very much, Dr. Tomita. Due to the time, maybe we move to the next speaker. And any question or comments, we can talk to Tomita separately. I would like to invite Dr. Thanawat. He will mention about the special consideration in ASD in elderly patients.
Thank you. First of all, I would like to thank my mentor, Dr. Warakan and Dr. Supaporn, for inviting me to share my talk today. I'm an adult cardiologist, so my topic is ASD closure in elderly. I have no disclosure. What is elderly? United Nations agree that we cut off point at more than 60-year-olds is elderly patient. So I will start with the case. My case was 65 years old Thai woman with hypertension and atrial fibrillation, present with progressive arrhythmia for 6 months. Functional class dropped from class 2 to class 3. The patient has the minimal desaturation at the room air. Medication, she takes atenolol, losartan, and aspirin for her disease. The EKG shows atrial fibrillation with right button branch block. Right deviation. So change ratio, cardiomegaly, dilated pulmonary artery, and increased pulmonary blood flow. We send patient to cyclic walk test at the baseline oxygen saturation around 94%, and after test, patient developed desaturation around 88% after walk, and distance just around 224 meters. This is the echocardiography. We show dilatation of the right ventricular and right atrium. Vegetation fraction is preserved around 60%, no original wall motion abnormality. Patients have grade 2 diastolic dysfunction. We found ASD secondum around 30 millimeters and just left to right shunt. Estimate PA pressure around 60 millimeters mercury. We send patient to TE. We have shown the last ASD secondum maximum diameter 32 millimeters and adequate limb for device closure. We also send patient to left and right heart cath. The data shows oxygen step up at the right atrium, mean pulmonary pressure around 23, and LVDP around 10. QPQS was 1.8 and PVR 1.9. We also do the pre-angiogram for this patient. We found that patient have a single vessel disease around 70% with LAD stenosis. So for summarize, patients are elderly with ASD secondum with chronic atrial fibrillation. We have coronary disease with single vessels, and patient have the hypertension. What should I do for these patients? Close ASD or do the PCI? We have data that if we close ASD in patient more than 40%, we have the lower survival than the control, that's less than 40. However, we can improve symptomatic for the patients and reduce morbidity, but not mortality. Pathophysiologic for ASD in elderly patients because from long-standing left to right shunt and may cause to balloon load to the right side and may cause the pulmonary hypertension, stretching to the atrium and maybe cause atrial fibrillation and atrial flutter. And then if the patient have the left side disease, hypertension, ischemic heart disease, or AV sclerosis, may cause from the both RV and LV failure. So we, from review literature, we have data, many data to show that we have benefit from ASD closure in elderly from surgery to improve the symptom and functional class. And also with device closure, we have to safe and effective and improve functional class. But some patients have the LV restrictive and may cause heart failure in some patients. For the technical and clinical consideration for ASD closure in elderly, so we need to look the access size comorbidity. Atrial arrhythmia and pulmonary hypertension and LV dysfunction is a big issue for elderly patients. For access, in some patients in elderly have the obesity and obese abdomen, so it's very difficult to the puncture from arterial or venous side. For comorbidity, from review literature, patients to close ASD, we found that hypertension found around 40% in the patients, and we found pulmonary hypertension around 50%. Pulmonary hypertension 50%, AFib around 40%, and coronary artery disease around 15%. For coronary artery disease, we need to evaluation coronary artery anatomy before or during ASD closure, and maybe you can treat simultaneous intervention from CAD at the same time with ASD closure. For COPD and AV disease, we found around 20%. So we need to optimal treatment for AV disease before to ASD closure. Maybe consult to pulmonologist before closure. Pulmonary hypertension is a big issue. We found prevalent around 40% increase with age, female more than man, and related to the defect size. If we need to close ASD with pulmonary hypertension, we facing to the gray zone to closure. We will see the guideline. If we choose to close ASD in patient with pulmonary hypertension, PUR more than 3 to 5, that's a 2A recommendation. But if we choose to close PUR more than 5, it's a class T. But however, if you treat and you make PUR fall below 5 good unit, and left to left relation is the class 2B recommendation. 2020 ESC guideline recommend you to close ASD closure if the PUR less than 5. Okay, and even you treat PUR less than 5, the recommendation to use the penetrated for this group of the patient just to be recommendation. Also with the PSU CSHD guideline, if the cardiovascular resistance more than 1/3 of systemic pressure, you need to consult the expert adult congenital heart disease before closure. And we decide to close or not close in this group. Maybe sometimes we use to also reactive activity. For pulmonary hypertension, we use the nitric oxide, 100% oxygen, inhale air pulse, or maybe temporary balloon occlusion test. It is the device, penetrated device, maybe do it by yourselves or maybe sometime from the manufacturer produce. For pulmonary hypertension, the important you use to, you need to evaluate the pulmonary artery pressure as the baseline, assessment of QP, QS, and PER before and after closure. Even you decide to close, you need to close follow up the PA pressure after you close ASD, and maybe close follow up to fight to delay manifestation of pulmonary hypertension. Atrial arrhythmia. Atrial fibrillation is the major cause of morbidity in adults with ASD. The risk factor is the aging more than 40, atrial arrhythmia before treatment, and pulmonary hypertension is the risk factor of the new AF. And for treatment strategy for ASD closure with the atrial fibrillation, if the patient just only proximal AFib before closure, we usually maintain the standard system after closure. But if the patient has the persistent AFib before closure, so if you want to the rhythm control, you may need to do the cardioversion or maybe ablation to rhythm control. But some patients with the high risk for rhythm control, you just rate control only and if anticoagulant for stroke prevention. This is a case example ASD with the persistent AF. You do ablation and ASD closure at the same time by do the ablation first because the catheter is easily too close to the left atrium. And after successful ablation, could then close ASD with device. But some patients have the contraindication to anticoagulant. We do the left atrial appendage occlusion with the ASD closure at the same procedure. That's the dysfunction is a big issue today. Because of the ASD closure may be mass LV restriction. After we close the ASD, it increase LV filling defect and increase LV EDP, and maybe cause to the pressure to the left atrium and to the pulmonary vein, and may causing or leading to the pulmonary edema to the patient. The data from Dr. Choi from Korea is occur around 2 to 4% for developed heart failure after closure, but from literature review around 25%. So we need to do the balloon occlusion test. Have so many criteria for do the balloon occlusion test, but usually if you do the balloon occlusion test and air pressure more than 10, or maybe some literature more than 15 millimeter mercury and rising more than 5, is the high risk to cause the pulmonary edema. You can see after you do the balloon occlusion test, before patient just pseudo-normalization or breakthrough diastolic function, but after you balloon occlusion test, the diastolic function changes to restrictive physiology or class T, and the left atrium pressure and LVDP rising. So too many criteria to do the balloon occlusion test, but for summarize, if the balloon occlusion test negative, no rising of the LVDP pressure, you do the routine device closure. But if the test is positive, has the rising LVDP air pressure, the recommendation suggestion to the penetrated device to closure. For summary of recommendation, the important to check baseline LVDP and pulmonary pressure before closure, and you suggestion to do the balloon occlusion test for 10 to 15 minutes when LVDP more than 10 or more than 15 millimeters mercury. And if LVDP is the weight more than 5, penetration of the device is recommendation. Or maybe you treat the diuretic first and come back to close AC closure again. But for my experience, I think the rising of the LVDP after balloon occlusion test just a temporary effect in my experience. Even the test is positive, if I give some diuretic to the patient and after that around 50 minutes, the LVDP is decreasing or improve, then I try to close the device. It's just my experience. So the summary of the recommendation for AC closure in elderly, you see the mean pulmonary pressure first. If the pulmonary pressure below 25, you AC closure, you close it. If mean pulmonary pressure more than 25, you look to see weight pressure. If the weight pressure less than 15, you see the PVR. If the PVR less than 5, close the AC closure. But if more than 5, you treat pulmonary hypertension first and close AC later. But if the weight pressure more than 15, you do the balloon occlusion test. If the LVDP less than 20 after BOT, you close ASD. If the balloon occlusion test and LVDP more than 20, maybe treat heart failure first, or you close ASD with penetrated device. Come back to our case. For this case, even baseline LVDP around 10 and less than the recommendation, but I concerned about the heart failure after the closure. So I do the balloon occlusion test with 30 balloon for 15 minutes and check LVDP pre and post. No significant change of LVDP and pre-pressure. So in this patient, I closed with the cocoon septal occluder 36 millimeter And I deploy from the right upper pulmonary vein because it's easy for the big size of device. For hereditary disease, I check physiology test to make sure that the stenosis is significant to cause the patient have the symptom in the future. I do the IFR. If the IFR below 0.89, meaning that significant stenosis. So it's in the patient have the significant stenosis, I treat with dilating stent. And for atrial fibrillation, this patient have Chapman score 3, so have the high risk to stroke in the future. I treat the patient with your dipellet with the anticoagulant. I give the patient apixaban NOAX for 1 month. After 1 month, I give aspirin with apixaban, and after 1 year, apixaban only for NOAX for this patient. This is the follow-up 6 months after. This is the pre-closure and post-closure. The patient has a little bit dilatation to the right side, RV and IA. The device is well seized. However, the PA pressure decreased from 58 to 27 millimeters mercury. This is the shell X-ray. The heart size is smaller, and the flow to complete, but flow is improved. Now, patient has functional part 1. Room air oxygen saturation is good, and we do sigmoid walk test again, notice saturation and improve of the distance of the patients. In conclusion, aging brings to clinical and anatomy and physiology change related to ASD closure. So it's very important to systemic pre-closure assessment. And we have the protocol to approach closure in patients with a specialized condition, especially pulmonary hypertension and LV dysfunction. Thank you for your attention.
Dhanawat, thank you very much indeed. Very comprehensive review. Thank you. Unfortunately, we don't have time for discussion, so I would close the session, and then right away we're going to start the TAVI session. In the meantime, for those who have maybe need something to drink or eat, or just a little break, coffee break will be served outside, and please visit the booth. Thank you.
Thank you for lovely moderator and panelists. We have the morning break, go outside and turn left. And we are 30 minutes behind the schedule, so the TAVI session will be around 10:40, okay? TAVI session will be starting around 10:40. So have a quick morning break, please. Oh, sorry. We will proceed immediately, okay? You can bring something to eat in here, okay? So the TAVI session will start immediately, okay? If someone want to have a break, go and pick the break and come inside the hall, okay?
I think we behind the schedule for a while. I would like to start the session, and you can bring the coffee break into the room. Yeah. So I'm Dr. Support from King Chulalongkorn Memorial Hospital. With me, Dr. Kisda Mimuk from Ramathibodi Hospital. So today we have 1, 2, 3, 4, 5 panelists. I would like to invite the panelists to the stage. Dr. Nathavut from Sirat, please. And Dr. Tassarat from Chiang Mai University. And Dr. Kit from Thammasat University. And Dr. Narathip, I'm not sure that he's in the room or not. Oh, okay. From Sirat Hospital. And okay, another one from China is not coming. So we will start the first lecture. We will address by Dr. Arms Abba. Arms Abba. Yeah, I'm not sure that he's ready or not. Okay.
Oh, yeah.
Uh,
Good evening,
very-
Dr.
good
Abbas.
evening.
Thank you for being with
Yeah.
us
Okay.
today. Dr. Abbas going to address about the echo and CAT gradients discordant post-TAVR, what we have learned and how to apply. Please, Dr. Abbas.
Thank you very much, and thank you for the privilege and honor to present at your wonderful meeting. I've been listening in through your ASD lectures, and I'm very impressed with the cases and the knowledge and the lectures. So without further ado, I'm going to be talking about a controversial topic about how to assess hemodynamics post-TAVR, what we have learned with the echo versus the cath gradients. And the things that I'd like to highlight is that the echo velocity from which we derive the echocardiographic gradients is not synonymous with the gradients, and hence the development of the concept of discordance. I also want to point out the lack of evidence of any relationship between high echocardiographic gradients and poor outcomes, and the difference between a single point measurement of an elevated gradient versus an actual change in the hemodynamics in the echocardiography in TAVR versus AS, and what studies are ongoing to describe this phenomenon. So in the first concept, I'd like to highlight the difference between an echo velocity and a gradient. The concept of this issue was raised several years ago in the surgical literature when Dr. Stewart in his paper suggested that the mean gradients by the modified Bernoulli equations were always greater than those measured manometrically in cardiac catheterization, and he advised the clinicians or surgeon to be very wary about making any major diagnostic decisions based just on the echocardiographic measurements alone after surgical biprosthetic valves. This was the first case that actually got my attention to this. This is a patient we placed a 20 millimeter S3 valve in valve, and you can see that immediately on the table, after the valve was implanted, we had an echocardiographic gradient of 40 millimeters of mercury. At the same exact time, under the same hemodynamic conditions, the patient's cath gradient was 11 millimeters of mercury. And so what we decided to do is to present several cases on this phenomena to further elaborate on what exactly is the relationship between the echo and cath gradients. And so in our single center study, we published a set of almost 300 patients showing that there was a discrepancy between the echocardiographic gradients and the invasive gradients, both post-native TAVR and post-valve-in-valve. And you could see that this difference was greater than 10 millimeters of mercury, up to 25% post-valve-in-valve, meaning that the echo gradient was higher than the cath gradient in 1 out of every 4 patients by more than 10 millimeters of mercury. So we generated a multi-center registry with several patients, and we were able to collect over 800 patients. And in those patients, both echocardiographic gradients and invasive gradients were obtained simultaneously, concomitantly before the TAVR and immediately after. And what you could see in this graph on the left is that before the TAVR valve was placed in the setting of aortic stenosis, that the invasive and echocardiographic gradients had excellent correlation. However, the correlation was very poor once there was a normal functioning biprosthetic valve, where there was really no good relationship between echo and invasive catheterization. We finally performed under the leadership of Dr. Cabot from Montreal this prospective study of valve-in-valve randomizing balloon versus self-expanding valves in small failed surgical prosthesis. And this also demonstrated the same findings that we had, that the cath gradients were again lower than the echocardiographic gradients in patients with small ventricular valve. And even though that the balloon expanding valve had higher echocardiographic gradients than the self-expanding valve, they both generated similar invasive gradients. This was despite the fact that there was more higher echo gradients greater than 20 in the balloon expandable valve, saying that even though that the echo gradient was different, the invasive gradient was the same. And this we also demonstrated in our retrospective study. The problem is compounded by the fact that the following day, after sedation is over and the flow has improved, we see that there is a significant increase in the echocardiographic gradient before discharge compared to the immediately post-procedure under anesthesia. And you can clearly see this happens in all valves, but seems to happen to a larger extent in the small balloon expandable valve. Now, why does this phenomena occur? Why do we say that the velocity is not the same as the gradient? It's because in the very extensive Bernoulli equation, we realized that the actual Bernoulli equation is much more complex. but we simplify it into this equation of 4V squared. This equation only works in the setting of aortic stenosis accurately to reflect the gradient. However, in the setting of normal functioning bioprosthetic valves, whether surgically or transcatheter, this equation, this simplified equation, just doesn't work as well. And so what we're trying to say is that when the velocity of echo represents in aortic stenosis the gradient across the valve, however, in a normal functioning prosthesis, this velocity is a composite of the valvular hemodynamics, but also the flow and the ejection fraction, and isn't necessarily a reflection of the transvalvular gradient. We looked at the relationship between high echocardiographic gradients and outcome. This is a study that we did with Marvin Eng from the TVT registry, and you could see that there was no difference at 1 year between the high greater than 20 and the low less than 20 millimeter gradients. We did the same study with Dr. Kaneko in the valve-in-valve population. Again, no difference in outcome between the patients who had echocardiographic gradients immediately after TAVR on discharge, greater than 20 and less than 20, and even up to 8 years from the VIVID registry. Dr. Bleisefer shows that there is no difference in mortality between gradients on echocardiography greater than or less than 20. So we started to wonder, since echocardiographic gradients are highly dependent on flow, what the relationship would be between the transvalvular pressure gradients, both on echo and cath, post-TAVR. And we found a very interesting relationship. What we found is that the unadjusted death showed that actually people who had very low gradients actually had a higher mortality because these patients actually had lower flow and lower cardiac output and lower ejection fraction, while the intermediate range between 10 and 20 actually had improved outcomes because they had, again, improved flow and cardiac output. There wasn't enough patients in the gradients above 20 to really demonstrate any relationship to mortality, but you could see here after adjustment for flow and ejection fraction that the benefit of this intermediate gradient actually remained with no significance in the lower or the higher arms. So to really take this a step further, we tried to see the impact of flow not only on the echocardiographic gradients, but also on the echocardiographic areas. And we looked at the PARTNER 2 registry and divided the patients into immediately post-TAVR versus the post-SAVR in the PARTNER data. And what we divided the patients to was low flow and normal flow. And then we found the incidence of severe PPM in each arm. And what we found was very interesting is that if you had low flow, your incidence of severe PPM was 20% in the post-TAVR arm, while if you had normal flow, it was 5%. In the surgery, it was a similar story, when if you had low flow, your incidence of severe PPM was 42%, but if you had normal flow, your incidence of severe PPM was 8%. Now, mind you, the patients who had normal flow had higher echocardiographic gradients than those who had low flow, even though both patient categories had severe PPM. So who do you think did worse? Well, interestingly enough, this here is a spline curve showing the flow and the log hazard for the mortality. And you could see that even though the patients with normal flow, both post-TAVR and post-SAVR, had higher gradients, they actually had better mortality compared to the low flow. So even though that you have higher gradients, if you have normal flow, you have better outcomes compared to the low flow, lower gradient category. And so we believe that the low flow state causes both a lower effective orifice area and a lower gradient, and this is what really impacts your clinical outcome. There is a difference that I think is highlighted in the NOTION trial, showing that even though the TAVI and SAVI had different echocardiographic hemodynamics, and you can see clearly here that there was more structural valve deterioration in SAVR compared to TAVR, and there was difference in the gradients and the valve area, you can clearly see that there was no impact on mortality or New York heart class, despite this difference in the structural valve deterioration, meaning the hemodynamic benefit of TAVR didn't really translate into these outcomes. This is the data from SURTAVI. You can see again, even though that the SAVR had a higher gradient than the TAVR and had a lower area, the incidence of moderate severe PVL was higher in TAVR, as well as the pacemaker rate, but the reintervention rate, despite better hemodynamics, was higher with the TAVR. Now, recently, the analysis of the SURTAVI data looked at the change in the echocardiographic hemodynamics from baseline to follow-up. And there was a suggestion that in patients who had this change in their echocardiographic hemodynamics, whether in surgery or in TAVR, that this was associated with worse outcomes. There are a lot of studies and a lot of interest in this field. Currently, there's the ECHO-CATH study that is currently being run by Dr. Cabot, Dr. Piberon, and myself, looking at patients who have elevated echocardiographic gradients and randomized after invasive hemodynamics to either a cath-based approach or an echo-based approach. Depending on the patient's randomization, they will receive further adjustments to their valve, depending on the gradient. There is the DISCORD trial that is run by David Wood, Janar, Dr. Webb, and myself, looking at patients who have repeated elevated echocardiographic gradients on follow-up, getting a CT to rule out halt, and then getting invasive hemodynamics to see if there is concordance or discordance. And there's a couple of other studies, the SMART trial led by Dr. Herman, that is only an echocardiographic-based study that has finished enrollment, and the baseline study that is being generated by Dr. Van Meegen in Holland. So in summary, in aortic stenosis, increased velocity across the aortic valve primarily reflects the pressure gradient, but in normal valves, the velocity really reflects flow rather than valvular hemodynamics. All valves exhibit this discordance and generate higher discharge compared to immediate post-TAVR gradients. A single elevated echo gradient does not necessarily correlate with mortality, nor with symptoms. A delta change, however, may, and the low flow state is really the primary reason for low gradient, slow EOA, and is associated with greater mortality and worse outcomes despite being associated with low gradients. Thank you very much.
Thank you very much, Professor Abba. Is there any question? May I ask some question? If you have follow-up the patients with increased echo gradient, what do you recommend to do invasive monitoring or just follow the patients without need for the invasive measurement?
So that's a great question. So if you notice an echocardiographic gradient immediately after implanting the TAVR valve, I urge to do invasive gradients to really calibrate this echocardiographic gradient that you have and decide what you're going to do with it. On the other hand, if you have somebody who presents with a change in their echocardiographic gradient, the next step would be to do a CT scan to rule out any thrombus or halt. And then if there remains any discrepancy despite the absence of clot, we have the DISCORD trial where we take those patients back and we do again an invasive gradient and an echo gradient to demonstrate any difference. So it depends if those gradients are immediately post TAVR or are they there on follow-up.
Thank you. So because of we running off the time, so I would like to thank you very much for give us the excellent talk for tonight. Yeah.
Okay. Thank you so much.
Bye.
Thank you very much.
Yeah.
Have a great meeting. Thank you so much. Bye-bye.
Bye.
The next is going to be presented about it, SAPIEN 3 and small annuli, technical issue and clinical outcome by Dr. Nathawut Wongpaparas from Sirirat Hospital. Please, Dr. Nathawut.
Thank you, Dr. Krista, Dr. Support. Good morning, everyone. It's my pleasure to give a talk today, and thanks PSU for kind invitation. So I will give a talk on the S3 and the small annuli, what is technical issue and clinical outcome. So I think there are multiple challenging when you're dealing TAVI in the patient with the small annulus. One thing we have the concerns because when you put like a small valve in the patient, do we have like patient prosthetic mismatch? And this patient will be small, and so we have the small vascular access. In some group, when the anatomy is small, when you have like a low coronary height and small SOV, you may have risk of coronary obstruction, risk of annular rupture if you have calcium in LVOT. And then another important thing we think about the future TAVI and TAVI since now we do younger and younger patients. So I think this will be all the topic that I will cover on. So I think first, what is the definition of the small aortic annulus? In the surgical series, there is defined that annulus is accommodate the prosthetic size more than 21. And in general, on the echo and in CT measurement, if the aortic annulus less than 23, that we call the small annuli. And I think I want to point out the most important thing we have to evaluate on the patient is called patient prosthetic mismatch. When we think about putting the small valve in the patient, we have to see that its double size is accommodated or not. If not, we have the PPM. So what PPM, patient prosthetic mismatch, we calculate by use the index effective orifice area divided by the patient body surface area. And when you have less than 0.85 is a threshold for PPM. And then we have if less than 0.65 is called severe PPM. And we know from surgical data, when you have the severe PPM, you have impact on mortality. And in the TAVI era, you still have some patient, even though we have the CT measurement, we have some patient have 7 to 15% may have PPM, and that also impact on the mortality as well. And Dr. Abbas have been talking about using invasive measurement and echocardiographic measurement in the patient with small annuli. Sometimes you have pressure recovery. Echocardiographic is maybe not corrected. So I think immediate invasive pressure measurement is very important. And usually we, if we don't planning for very well and we don't have the PPM, you should not have any invasive elevate of the gradient. And if you do have, there may be technical issue that you might need to correct it before leaving the patient out of the cath lab. And the small annuli also have the impact on the future coronary access and future TAVI in TAVI. So I think this is a consideration that we might have to think about, because this patient will have like a very TAVI height, leaflet height, relative coronary ostium is higher. STJ may be smaller. So I think using the S3, I think we'll have advantage because of this group of patients. If you plan for, if you put in the young patient, you have to think about this future valve involved, and I think that will be accommodated too. So what is the, that is all the technical issue. What is the outcome? So I think they have the propensity match on the TVT registry. Looking at the patient with the small valve 20 compared to 23, you can see that the rate of severe PPM is higher. But when you look at the long term, at 1 year, there is no impact on the mortality. This is also, since majority of the patient with small annuli will be under women, so they have the WIN-TAVI registry, enroll the patient in United States and Europe, and you can see the efficacy endpoint and safety endpoint at 1 year compared between the small valve and the bigger valve is no difference. And recent published on the JAK intervention, looking at the cell expandable device compared balloon expandable device, you can see using the balloon expandable device, you will have like less parabola leakage, but you may have like more PPM, but there no impact on the 5-year outcome. So what is the Thailand data in our TAVI CSHD registry? We actually, when I look at retrospective, we see that we have put quite a few of the 20 valve and up to 30 case from overall 230. And we have some step approach that when we careful with this patient, I think first we will heart team will look at the EOA and make sure that we don't put the too small valve in the patient bigger size. So we calculate that before we planning for the procedure. We will careful evaluation for image potential complication and routine pre and post invasive gradient. And you can see compared between the smaller valve and the bigger valve is more female patient. Body surface area is smaller. So I think this valve is more appropriate to the patient. And when you look at this, when outcome at long term for 1 year, there is no significant difference between smaller valve or bigger valve. I would like to give some 2 examples of the case briefly. This is 86 years old female, have symptomatic CVAS, annulus is small, calcium is very high, close to 3,000. So you think this is will be a risk for annular rupture. So this patient annulus area, body surface area is 1.33. So this is the area of 340. So if we use 7.3 of 20, and if we plus 1 cc, will be 10% oversized. And the coronary height is okay. So I think on this case, before we putting the valve, we want to make sure we don't put the too small valve, but when we calculate EOA is way above, so I think it's no issue. Then we careful heart team evaluate for image potential complication. I think no risk for coronary obstruction because coronary height is high, SOV is big, but a lot of calcium, so we need to balance risk of annular rupture and paravalvular leak. And this is the step that we do. So we direct the valve deployment, and after the valve deployment, there's still some paravalvular leak, but we use the same balloon dilatation. We calculate have just 10 oversized, but not more than that, and you can see we left with no paravalvular leakage, and easy for access if we need the future TAVI. And again, it's very important of routine invasive pre and post-TAVI, because if you want to do something, you want to do it now. You want to let the patient out and bring them back. Another challenging case, my last case, is a 74 years old female, hypertension, dyslipid, bronchiectasis, and have bicuspid type 0 with asymmetrical calcium and small annulus, low coronary height, and long leaflet. And you can see the calcium is distribute only one leaflet, but not on the other. And a height actually coronary is not low, but the leaflet height is higher than the coronary leaflet. And we calculate from this area is 330, so it's going to be 20 valve, but because of the risk of a complication, so this one we plan for use nominal pressure, and if we need, we add 1 cc. Again, our step approach, we evaluate for EOA, we make sure that we don't put the small valve in the bigger patient, but this one still is no significant, should not be PPM. And then for careful evaluation of image, so we try for nominal pressure. And this is because of the bicuspid, we use the circle method to make sure that the valve is appropriate sizings and no left with no paravalvular leakage. And this is our step, is bicuspid type 0 with the asymmetrical calcification. So we, because of the long coronary leaflet, so we do balloon testing. We can see the flow to the right coronary artery, so no, we don't need to do a chimney on this case. And then we implant the 7.3 number 20, but you use only nominal. And you can see the big chunk of calcium on this side pushing into the right cusp. Immediate post-TAVI, you can see some big chunk of calcium, but there's still some paravalvular leakage. But we know from our calculation, if we add 1 cc, we will have like 7.6% oversize, so we can do a post-dilatation. So this is after post-dilatation, so we left with no paravalvular leakage and no risk of the coronary obstruction as we demonstrate by coronary angiogram here. And again, very important, before you left the cath lab, routine pre and post-TAVI invasive measurement is very important for this patient. In conclusion, I have talking about technical issue in the patient with small annuli. I think you have some risk for patient-prosthetic mismatch, but I think pre-procedure planning, heart team helping, I think will be help to balance risk of this. And again, I will want to stress on the pre and post-TAVI invasive measurement because of this patient may have pressure recovery from the echo, so you know what the baseline compare between the echo and invasive measurement. And if you do like this, I think you have the good outcome. It's no difference from larger annuli. Thank you very much.
Thank you, Ajahn Nathavut, for the great talk. I think this is maybe problem for the annular design TAVI valve for the small annulus. Yeah. I will ask the panel if you can choose in case of small annulus, you will select super annulus or annular design. Dr. Kit.
For me, another point to concern, one is longevity of the patient. If you think that this patient needs a second TAVI valve, maybe I prefer the intra-annular design, the Sapien. But if I think that this patient maybe only one TAVI valve is okay, maybe supra-annular is no calcification problem or another.
Dr. Taksarak.
I am the big fan of the silver expandable and should be super wow.
For me, as I mentioned, routinely we will use the balloon expandable. I think we have advantage coronary access. But if the patient have the likely prosthetic mismatch, we have the case that we calculate prosthetic mismatch, and then we use the supra-annular.
May I ask panelists about one question? In terms of the depth of the intra-annular device, is different between the depth of implantation? Like if you like high implantation or?
I think it depends. I think you nowadays I think we have to tailor-made. When you have like depth is a lot, you will have the high risk of heart block. So you try to go higher to reduce the pacemaker rate. But again, if you go higher, you may have the difficult access for coronary access or maybe future valve involved.
Okay. I'm not sure that the cath lab is ready or not. If ยังไม่พร้อมนะ Okay. So we go for lecture first. Okay.
The next talk is going to be the S3 optimal sizing, positioning, and possible repeating. The talk going to addressed by Dr. Naratip Chunhamaniwat from Sirirat Hospital. Please, Dr. Naratip.
So, thank you, PSU, for the invitation, and thank you, Dr. Kit, for the introduction of this lecture. Positioning is very important. I'll start with the case. This is an 88-year-old female presented with heart failure. 2 weeks before she came to see me in the clinic, she was admitted due to dyspnea, and she was found to have non-STEMI with heart failure and acute kidney injury. But she was she was discharged after aggressive diuresis. Her comorbids were type 2DM, hypertension, dyslipidemia. She's quite small. Her weight is 47 kilo, and she's 155 centimeters tall, and BSA is 1.4. It's like small, tiny lady. And echo from the outside hospital shows severe RV systolic dysfunction with severe AS. This is the EKG when she was admitted at that time, sinus tachycardia, LVH, and inverted T wave. This is the echo that was done by our ex-co expert, Dr. Sirichai, and he called it EF 27%. I would have called it like 20% with global hypoglycemia, and even low flow state, she still made the gradient, mean gradient of 55 with a calculated valve area of 0.64 square centimeter and mild aortic regurgitation. Try to lift that aortic valve, and I'll show you that the EF is pretty bad in this case. So the next step, we proceeded to get CTA TAVI protocol, and looks from the numbers, looks like she was a good candidate for TAVI. The annulus area was 449, and perimeter was 76.5 millimeter. Area derived diameter is 23.9, and I look at the coronary height briefly. It looks okay. The left side was 11.5, and the right side is 15.5. The root angle is okay. Heavily calcified aortic valve, but it was quite symmetric. So I proceeded to coronary angiogram, and she has a left dominant system. And I think she had some coronary component. The proximal dominant circumflex had subtotal occlusion. The LAD was pretty good. So in this patient, I think she's a good candidate for PCI, then TAVI later on. So I fixed proximal circumflex using true drug-eluting stent, and I think I got a beautiful result. So the next step after we fix the coronary artery, look at the area again. I think this is the area that quite fall in between two sides of S3. Look at the anatomy closely. That is not that straightforward because the sinus is not quite, it is not very wide. The annulus diameter is about 24 by the area, but the sinus is only 30 millimeter. And although the left coronary height was 11.5, the left leaflet is quite long, it's 13.7. So now, I think we have to make the decision. I didn't have much experience using evolute valve. Maybe Dr. Tasalak and Dr. Support can address this later on during discussion. But I think the sinus is it is not very wide, and that my concern was coronary obstruction. Looking at this S3 valve, we can use either 23 plus or 26 minus. But in this case, we use the circle method and use this virtual valve to look at the anatomy. The upper low is 23 overfill, that will make it 24 millimeter, and the bottom low is 26 underfill, that would be 25 millimeter. Look at the annulus level. I think either valve should be fine. But when we look at the coronary obstruction risk, I think looking at using the smaller valve should be better. If we use 26 valve, the valve would close until the SDJ level. But if you use a smaller valve and try to place it 80-30, we can access coronary artery from two ways, either from above the valve plane or through the large cells, the large cells of the valve. But so I think it might be the better option. And also the coronary artery, like I mentioned before, the left leaflet is quite long. If we use 26 underfill, I think the space between the valve and the left coronary ostium is only 2.3 millimeter. That will be too risky. And it is a patient with left dominant system. And also, although she's 88, I think that's the area that you can debate later on, because right now, my patient is like almost 100. Using the low frame height, give you an option to do repeat TAVR again, because when we use self-expandable valve like evolute, and you're concerned about coronary obstruction, the risk plane is, above the coronary ostium. So when we think about the valve choice, there are many factors to consider. Yes, this one, heavy calcification, the risk of annular rupture is there, and I'm very concerned about the risk of coronary obstruction in left dominant system. So, and again, we have to think about to get back to coronary artery again, because it is a patient with multiple CAD risk factor who had stents already. And also this is the patient with poor LV systolic dysfunction. We don't want to do ventricular pacing. And another thing is to look at the chance of the patient prosthetic mismatch, because if we use even 23 millimeter valve, the EOA is still fine. It is still fine because she's only BSA is only 1.4. We could have used 20 valve, without the PPM. So this is the lady with small size, but for some reason her annulus is big. So we decided to use S3 number 23 plus 2. That would give 0.9% oversizings, and we aim at 30-20 position. Look at the left picture. I think we got a good spot, and the right video clip, you see a chunk of calcium in the non-coronary class, that's moving towards the wall. So I think, it was a good decision because using the big valve, we take risk of perforation. So I think it was the right decision. We left it with a mild leak. And also, I think, we got the space, to engage the catheter, to engage left main, from the space above the valve plane. And in RAO projection, I think the left main ostium is coming up, is coming above the valve. And this is a TE, only mild leak. I think that is acceptable. So my conclusion, I think in my institution, I think the default is still balloon expandable valve. I think it has good radial force in heavily calcified leaflet. But be careful not to be too aggressive when you choose the valve size. And I think in this patient with dilated LV and had mild AR to begin with, I think has some leak is better than rupture. I prefer low frame height valve because I think, if we deploy too deep, you take risk of ventricular pacing, which is not good in the patients with poor EF. And also, I think coronary access is very important. If you use low frame valve, I think to do PCI later on is more, it is easier. And also she's 88, so last night I saw the patients who were like 95, 98, 99. So although she's 88 right now, she has no reason, not to live until 100. Thank you for your attention.
Thank you, Dr. Narathip. I think we go back to the cath lab first because of now the cath lab is ready. Can you hear us? Yeah. Okay.
ready แล้วครับอาจารย์
Okay. Okay. So Dr. Sirichai, you can introduce your team. Okay.
Okay. Welcome back to our hybrid cath labs. For right now, we are going to do the live case for TAVR with the Edward Sapien 3 valve, and is going to be a small annuli, as we heard about the topic in this morning. And let me introduce our team first. Actually, first I should introduce our important person for structural heart disease program in PSU. I think you all know Ajahn Man Chantavimon from Ramathipadi. He's always come to help us to do the case and never say no when we need help. Thank you, Ajahn Man. And on my left side is Ajahn Pongsane, cardiac surgeons, who is going to be implanter with us. And for my right is Ajahn Nung from Khon Kaen University, Khon Kaen Hospital, not university. And on the right, we have a lovely nurse, Jin and A, and on left side, Ajahn Liang, anesthesiologist. And on my back, Dr. Rungtip from Sirirat, but now she is in the PSU right now. She's gonna do echo for us. Okay, I think it's time for the case presentation. Dr. Panumet, can you tell us about the case?
สวัสดีครับ Hello, welcome to case presentation. My name is Panuwat Laksmi Vilai, Dean of Songkhla University, Fellow Interventions. Patient demographic, Thai female, 88 years old. BSA is quite low, 1.39 meter square. She has previous hospitalization due to syncope. Her comorbidity was hyperlipidemia, OCVA with full recovery. Her clinical presentation was dyspnea resertion, syncope, and functional class 2. Leak assessment by ATS score was 4.1%. Clinical ability scale was 6. Chest ratio mildly increased CT ratio. EKG show normal signal rhythm and narrow QoS complex. Lab investigation and show. This is echocardiogram. We will see concentric LV hypertrophy, good LV systolic function, trivial aortic regurgitation, and trivial mitral regurgitation. Paralateral short axis show calcified leaflet aortic valve. Normal LV wall motion and normal LVEF. LVEF was 80%. Okay. Trivial mitral regurgitation and trivial digastric regurgitation. Normal wall motion by apical axis. Aortic valve maximal velocity was 5.8 meters per second. Aortic valve mean pressure gradient was 87 millimeters of mercury. Aortic valve area was 0.5 centimeters square. Okay. Coronary angiogram show non-significant stenosis, both left coronary system and right coronary system. Okay, CT analysis, the left side is annular and the right side is VOT. Annular diameter was 16.4 and 23.8 millimeter. Perimeter was 63.1 millimeter and area was 299.3 millimeter square. Comparing LVOT to annular, you will see LVOT is a little smaller than annular. This is synod of Warsaw and SGJ. Okay. Left coronary height is 9.3 millimeter and right coronary height is 13.7 millimeter. Okay, we score up and down to see coronary cut and left coronary artery take off. You see left coronary take off is quite low. Okay. Delta axis was 50. Perimembranous septal length is 2.9 millimeter. This is copanal views. This is femoral exercise, right and left. In the conclusion, heart team evaluation, low to intermediate risk, small aortic annulus. Clinical indication was severe symptomatic aortic stenosis. Procedural strategy was conscious sedation, transfemoral approach, and adverse sapien 3 device implantation. After that, we will discuss about which size, implantation technique, and strategy in the cath lab.
Okay, thank you. I think this case is the gradient is very, very high. Yeah. And the echo is the valve is a little bit open. Yeah. I would like to ask Dr. Nathawood because it's a very, very small annulus. So you still use S3.
Yeah, I think this is a good choice for the S3. I think based on the CT measurement, and I think as I mentioned, we have to look for ppm, and this is patient's BSA is only 1.3, so you will have no ppm on this patient, and the anatomy is small, and you have low coronary height. I think even though she's 88, we don't plan for future tau in tau v, but future coronary access is going to be very important. And I look at the calciums is mainly on the non-cast, and the SOV is big, and not much calcium on the left coronary leaflet. So I think you probably should be okay. Coronary obstruction risk going to be low. So for this case, my strategy, I probably just, because our gradient is very high, and calcium, I can see from the echo, our leaflet is still opening. So I probably just go ahead with the direct valve deployment and just a routine.
Because the echo, the leaflet is still open. Right. So the gradient is very high. So it's sometimes maybe it's a mismatch.
Mismatch in terms of?
The gradient is too high. then compare with the echo opening.
Oh, yeah. But I think we can do a routine invasive measurement to confirm. But I think when the gradient is very high, my concern is when you do pre-BAV, if the valve open and CVAR, patient might be collapsed, especially if they have my AR. So in some case, but if bicuspid, I will do routine BAV. But if in the general, I try not to do it unless I think I cannot cross with the valve. Because if you cannot cross with SAPIEN, you have to remove the whole system. But on this case, I think it's durable.
So you no need pre-dilatation. I will ask Dr. Kit, because you prefer accurate very much because this is because the Cori high is very low, so the accurate the prevalence of the Cori obstruction may be less. Yeah. So you choose the accurate or not, or just go with the ST.
I think this case for the accurate neo2 that have neo skirt, I think it's fine with the accurate neo2. A bit concerned about asymmetrical calcification on the leaflet. Maybe leave with my PBL or something. But for accurate neo2, I think it's fine. But for the SAPIEN, I think it's okay because as I agree with Dr. Nathavut, this case, Cori obstruction risk is a bit low because the YSOV and burden of the calcification in left cast is less. And benefit for the S3 for this case is about PBL. I think it will be perfect for very less PBL for the concentric LVH.
And Dr. Tasalak, I think you will select supraannular design.
If I have not a choice, I have the supraannular and with the prepare for the chimney stent. But I know that the chimney stent finally is not good result. If basilica can done is better.
Okay.
So
go ahead, Dr. Mann.
With the 20 mm S3, the skirt is only maybe 8 millimeter. So it's no way that the coronary going to get obstructed. And as Dr. Nathavut said, I think the leaflet on the left side is not calcified or have a calcium nodule. So I think this case, even with SAPIEN 3 number 20, we do not need coronary protection. When Dr. Support asked about the mismatch because there are small annulus, I think with the pre-procedure echo, usually now we not only measure gradient and valve area, but we also do DVI, which is a ratio between LVOT VTI and aortic valve VTI. And if the ratio is then 0.25, then, and because it's a single beat comparison, I think that's good enough. But I think agree that sometimes when you have a high gradient, you need to look for other causes that cause falsely high cardiac output, for example, anemia or ongoing infection and so forth. So I guess that could be something to think about. But I think this case, we already checked that the DVI ratio is less than 0.25. So I think it's a true high gradient. But I guess other valves that you mentioned, the supraannular design platform can be used too. I don't think there's any problem, but with the SAPIEN design, I don't think there would be a major problem in this case either. What do you think, Srichai?
I agree, and just to add some point, can you go back one slide, please? Okay, so for the concern of PTM, we already checked that this patient, because of small annuli, but small body surface area as well. So that in this case, we expect that we have like a 1.0 index EOA from the data. And for the coronary obstruction risk, can you go next slide, please? Next slide. Okay, and about the coronary obstruction list, because we use the Trimentio and we can stimulation with the valve, and as you can see on the slide, with the 20 sapien 3, we have plenty of room for coronary, as you see on upper right, about 5.5 mm for VTC, but actually is we cannot tell exactly because of maybe the valve maybe go shift for left side, right side or something, but in the middle is like a 5.5 is we have a plenty of room about the coronary obstruction risk. And the other thing that the panelists already mentioned, that the risk of coronary reaccess and redo TAP in TAP or something like that. In this case, if we use SAPIEN 20, the risk frame, as you can see on the upper side, the purple line, the risk frame might be just about the coronary ostium. But if we use the Evolute 23, the risk frame gonna be above the STJ. That cause some problem when we come back to do the valve in valve, or even though a coronary reaccess. But in this case, 88 years old, I don't think it does not matter. We can choose any kind of valve.
Yeah.
Okay. I think the echocardiogram show the hypertrophy of the septal as well. So maybe some gradient about LVOT as well, I think. So after implant valve, maybe you find some hypotension after implantation, maybe LV side, because this LV function is very good. Yeah. So maybe we need to concern about after implantation. Yeah. Okay, go ahead, Dr. Sichai.
Okay, so we are going to do pre-dilatation with 6-3.
Can you show the panelists
Oh,
where we
okay.
at now?
So the configuration, right?
Yeah.
Okay.
No, what have you done?
What we have done so far.
And we cannot hear you, Dr. Ng.
Okay.
Louder.
Because with the bone procai, we inserted the big sheet, 14 French sheets from Edward to the aorta, and we put the picture from the left radial artery to check aortogram. In this case, we plan to temporary pacing via the LVY pacing.
What's your thought on, what's your thought on left radial access for pigtail, Srichai? What do you think?
Actually, we have a lot of problem with the opposite side. So last case, we have a fistula from the opposite side of the main
the femoral, right?
Yeah, of the femoral. So for right now, I think we are moving to use every case with the radial approach for the secondary access.
Have you guys done that? Instead of another femoral access, use a radial instead?
Actually, I have keep for the sentinel. That's why I keep the right side for sentinel and.
For me, I think there's a pro and a con. I think getting pigtail from the radial is better because sometimes when we put it from the groin, the pigtail was trapped. But I think this is a smart way to do it. But I still prefer contralateral groin because I like to do exit angiogram to confirm that we don't cause any vascular damage.
That's a good point also. Yeah.
But I think it's use the contralateral groin to check the angiogram post femoral angiogram post closure groin. Yeah, to make sure that the flow is okay, no leak. Yeah.
Yeah, because I think I had an issue before because in small annuli, usually for Thai people, everything is small and also the groin.
Yeah. Yeah, like this case, 5 millimeter. Yeah.
Yes.
All right. So yeah, that's all good point. We decide to maybe I'll help Srichai a little bit because he's so we decide to pre-dilate as Dr. Support suggests or Dr. Dom suggests. We're gonna use 16 mm balloon for pre-dilatation before deploying the valve. And we use LVY pacing.
Yes.
Dr. Man, how big the balloon? 18?
16.
16, okay.
Yeah, we could also consider 18 as well, but we think it's better to use 16.
Yes. Okay, we just check pacing because we are pacing on the pace LV wire.
Yeah.
Okay. ไม่รู้อยู่ตรงไหนนะเนี่ย
โอเค
นี่คือนี่แกน glass นะฮะ
Since you're going to do a pre-dilatation, maybe we can do a balloon testing, inject the contrast to confirm that no coronary obstruction. But based on the CT, I think it should be no problem. But since we're here, we can do it.
Yeah, we plan not to inject if that's okay. We think we're just gonna dilate.
It's okay.
But,
That's okay.
Yeah. Okay, go ahead.
Okay, pacing on นะครับครับมาแล้วโอเคโอเคอินเฟนนะฮะ1 2 3โอเคจ้ะโอเค pacing off ครับ
That's a good expansion.
Yeah. It's with LVY pacing, we want to look to make sure there's no heart block before we remove the balloon, which is not. Then we can go ahead.
That's a good point, Ajaman. Yeah.
But pressure is okay. It's no wide pulse pressure. So I think probably no significant AR. So I think we can go with same speed. We see some case that when the gradient very high and very small LVOT and once significant AR, some patient collapse because of the suicide LV. So I think that one of the concern that to do or not to do a pre-dilatation.
For you, with this case, you go directly without pre-dilatation.
I would go directly.
Dr. Naratip?
Without pre-dilatation.
Pre-dilatation. And
No, no
you don't have
pre-dilatation.
much experience.
Yes.
You use the accurate, maybe almost always pre-dilatation, right?
She's not the accurate girl. She said.
Can I ask the panel, because if you have the, can I ask the panel, if you just FC, let's puncture one gloy and you check the gloy when you finish, how to check?
So usually before we do ultrasound sky puncture, and sometimes on the when we exit at the end, we will use the JR. And if not JR is not able to cross over, will be Lima and then direct injection. And we surprisingly sometimes, when as Dr. Naratip mentioned, because when the patient is small with small access, sometimes even though everything is okay, no bleeding, but we see some stenosis, and we have to go back and reballoon dilatation. And 88 patient, if you left with stenosis and ischemic limb to come back, I think that will be a serious problem.
So we in the small goy, we have quite a problem about the occlusion. Yeah, if we use two foci.
Time I do one.
So now Dr. Warren, now he's inventor. They use one foci for the small goy. Yeah.
We do the same.
If not close, then we add another one.
So Dr. Support means one pro-guy and one fellow, right?
I always.
Because last case I have the dissection, and they not have any symptom. Just finish every case. I have the cine, the puncture gloy. Yes, that's why I think every time that I can good access in the opposite side should be good.
Right. Especially if you have like a PAD, when you analyze from CT, I think that will be higher risk.
The last case I go into the TAVI case is a dissection from the common iliac to the femoral. So we have to repair the groin. Take time more than do the TAVI.
Exactly. We have the same experience with the small and significant PAD. I have one case that groin closure, and I cannot go antegrade.
Yeah.
And so I have to do like ultrasound guide and lithograde puncture because it's a complex spiral dissection.
Yeah.
I think this is in elderly people. It's important to just complete and check everything.
Okay. So are you ready, Dr. Man, to go in?
And now
not yet, not
they
yet.
are live valve.
we have
But pressure is good. So we have time.
Yeah.
We have internally aligned the valve in the
Okay.
descending aorta, and now we're gonna cross the arch and then cross the valve.
So the sapien
Yeah,
with the
going to-
design, the balloon and the valve is not aligned to keep the profile small. So once we get into the abdominal aorta, we have to align the valve into the balloon.
About the ultra, Sapien Ultra is you have experience in Sapien Ultra.
Not yet, but Nu said she was coming in.
And they not have the pusher, right? Because I hear from the many doctor about the like the my
We still
valve.
have the sapien 3.
The my valve is not the pusher. Is have the stuck of the stent somewhere.
It's
Because,
only, I think it's only change about the skirt height, but the delivery system is the same.
So now we go to LAO and then try to cross the aorta. I think this one you have to flex. Very nice.
แต่นี้นะหยุดกันเทสตรงนี้ดีกว่า Okay, we are going to test the test ขอเทสหน่อยนะติดเนาะติดโอเคได้ครับติดโอเคเรียบร้อยครับ
Capture is good.
off test
What is your co-panel view?
LAO 19 cranial 2
Okay.
which is this angulation.
Okay, good. So you can use this for cross the arc and
we
deploy
use
the
this
valve, so that's
already.
convenient.
Okay. So if we are ready, we are going in. Okay. Okay. That's right. Okay. โอ้ยนี่เลยนะไม่เป็นไร Okay,ได้แล้ว
Good.
Okay.
We need to de-sheet.
เช็คนะ8พอนะจ๊ะ8พอนะ
So we
Yeah,
use
we need
picture
to
as
do the.
marker. Just have a quick. Yeah, I think.
Are you
maybe a
plan to
little
de-sheet?
over. Yeah, we will.
Yeah, we need to de-sheet before
okay,
you
that's
position.
Yeah.
Don't forget
Okay,
that.
that's it.
Yeah.
Okay, good.
Yeah, you need to bring that to the second marker, the sheet.
Yeah. Yeah.
Then I usually like to do that and then just a position before.
Okay,
Okay, good.
Okay.
Okay.
And now we can magnify and positioning.
You happy with this, Ian?
I have to see it again.
Okay.
Because my mind is to de-sheet.
We show you again. 8นะ8โอเคนะ
Because now we move a little bit, then we see. So this is a little bit high.
Higher.
Yeah, a little bit
Yeah, then
high.
you just deploy like lucent area. I think.
I think it's this is Pidom, this is a nominal volume. So
Okay.
That take into account. We can go a touch lower, but actually probably okay as well. Have to be careful that the balloon and the valve is not completely opposed. You can see the tip of the balloon is a little deep. So actually we higher than we think. So maybe down a little bit is
Right,
going
I
to
would
be
think so.
a little safer, I think. And then I think we can just move down and then we're going to pace and then check. And then if it's good, we're going to go. Yeah.
And with UCLA, Dr. Oxoy, I think he will do like this. But this patient,
okay.
20 valve
this
and the
position is
depth
better.
80-20, I think you still.
Yeah, okay, good.
Better,
I think we're
okay.
good. Yeah.
Okay.
All right.
Are you happy, Dr. Natwood?
Yes. Yeah, just go
Okay.
slow.
Okay.
Go very slow. And then you can make some adjustment during the deployment.
ขึ้นนะตอนหนึ่งดึงวิกเทลนะครับผม
Usually when the sapien will be have like a ventricular shortening.
โอเคได้
I think that will be okay.
Okay, we're gonna go then.
เอาเก็บเทสก่อนฮะเอาแต่10ครับ
ดูว่าโอเคก่อน Yes
Pressing on 180 inject จ้าปิด
It's
โอ
good.
เคนะครับดึงพี่เกียวครับเฟรนะครับ slowly all the way up ครับ1,001 1,002 1,003ครับโอเค press off จ้าเดี๋ยวศูนย์แล้ว AV block ไหม
I think this is high deployment. So
โอเคไม่บล็อก
See
ไม่
how
บล็อก
high.
ไม่บล็อกไม่บล็อก
But that's good thing that we bring it down. a little.
Yeah. That's good. Okay. Can we put the pigtail down and take a
look?
Hemodynamic looks
You know,
good.
but the L cranial deployment angle is usually for shortening. So
Right,
once you go to the cusp overlap, usually it's not as high as we thought.
โอ้
Yeah,
ศูนย์เลยฮะ
Oh, too high.
Yep. Some leakage. Yeah. I see at the end I had to push.
Yeah, we may need
But,
another one. Let's come to RIO caudal.
Maybe
Get me another valve.
Dr. Man, you can pull back the pigtail a little bit. Yeah, to make sure
Yeah,
that.
no, I think we missed the non-cusp.
Right,
I think we need a second valve. Let's take this
take a
picture
look.
and then see.
10 นะ
I think the annulus on the. Okay, take a picture. Yep.
ฉีดครับ
Yeah.
Yeah, I think on that cusp.
It
Because I
looks-
think the plane also an issue. It's not really co-planar. It's shift a little bit. And at the end, I think when they're foreshortening, maybe we can push a little.
Let's do an echo. I think the valve is in a stable position. It's definitely high, as you all see.
Right.
But it looks stable. And let's see.
But one good thing, I think the calcium's on the non-cusp and where. So I
Yeah.
think they help anchoring that. And then we see the coronary on the left is okay, no obstruction. I think I agree with Dr. Mann. Maybe we can reaccess before decide to put the new valve, but maybe you can leave without the new. We can leave it.
Okay. So this is high, no doubt.
Additionally, it's not a radiolucent.
Oh.
Yeah, I think at the end now, I think it's coming up, so you have to push. But I think.
Yeah. I think part of it is the precast view is not
Exactly.
coaxial with the
Exactly.
valve. And, yeah, but we'll see. Let's look at the echo. I think that we should prepare for the transesophageal echo as well, since the patient is under general anesthesia. I don't think it's going to hurt to have a better look.
Yeah, you can see the PBL. Yeah.
Oh, conscious sedate. Oh, sorry. Okay, then TEE first.
So.
เป็นท่อหรือว่าพาราลี
So you put another one, Dr. Man.
We are deciding.
It's very hard to do post-dilatation because it's quite high. Yeah.
Yeah, it's going more foreshortening. I will leave it or do another valve.
Even though you have the hemodynamic like the LVEDP or diastolic blood pressure.
Yeah, I think that maybe help as well. I agree with Dr. Slak.
Can we show the echo on the screen so you guys can help us decide?
It can be like the under expansion because the calcium, or you think it's the.
No, I think the
Cannot.
it's not co-planar and it's lift up a little bit during the day. Sometimes we have to like keep constant and usually like when I do with Dr. Ratip when he is slowly inflate, I will have like a second before the final to push in the pull up.
Yes, because I think TAVR is a true operator procedure.
Right.
Yeah, a few things. I think
especially when we did TMVR together last time.
Right.
Yeah,
Right.
we did that.
Exactly.
Because I remember you guys said the position was good before we. No. I think there's two things. One is if the valve stable, and number two, if there's a paravalvular leak because the valve is too high. I think from what we can see, the valve position is stable. So because of the calcium, as Dr. Tassarak said, that it helps anchoring. We can go and run through the angiogram of the last picture. You can see that the middle of the TAVR had indented, and so we are quite okay with that, I think. But I think we missed some part of the annulus, and whether that will cause a late migration or not, it's hard to tell, but it looks pretty stable. If we're gonna do it, then we need to deploy lower, which can be done also.
So P-Man, do you think it is worth doing TEE at this point to get more information? I think it is a hard call to make.
Actually, you have the pigtail. Maybe bring the pigtail down to the valve and look at the LVDP, how high. But for me, I can see the calcium where it's high and calcium anchoring on it. So I'm thinking just to leave it. If it's hemodynamic, it's okay.
Actually, the leak is actually mainly because of the white from the echo that I can see. The para leak is minimum.
Right. I think so.
It's about long-term stability. I think leak is not an issue because the calcium.
Yeah, and she's 88. I agree. I'm thinking to just leave it if it's hemodynamic. It's okay.
I think the valve is stable. The question is, are we sure about the leak? How?
Yeah.
Right.
I think can you show the echocardiogram for the apical view?
And they do.
Yeah, because we're not going to post dilate anyway. So unflex it.
I think the apical view maybe show the PVL much better than the parasternal axis. Yeah.
Yeah. Is it? Yeah.
Do
you want to do TEE or to wait and see? Let's do the pigtail first, and then we'll see.
Yeah.
I think this is based on the non-position. Very stable.
And be careful when you pull up that that
The valve will go
Safari, because it's a very stiff wire. So I think you have to get the catheter and pull.
And I think it is very important that we never lose position of the wire or the pigtail that we're gonna put in, because there's a case that the valve embolized and flip, and then that's the very bad situation. As long as the valve remain in a good direction, then we are good. So
nice.
We're gonna have to be sure that we are really sure before we lose the position. You guys see the angiogram? Do you think it's stable?
Yeah.
I will show that.
Okay, look like LVDP is not that much. So I think
from this.
No, it depends on the angle. Let's move the angle to. This one looks good.
So I think I would be okay. Just leave it with this LVDP and giving put another valve coronary access. It's going to be challenging and it's okay. I think with only much gradient 80, right, and then we left with my paravalvular leakage. I think you'd see will be okay.
And definitely no pacemaker.
Exactly.
Okay.
And the diastolic blood pressure is 55, 56. I think it's okay.
Right.
Okay, we're gonna take a picture.
Look like a cross overlap อยู่ โอเค ซีนี้นะฮะอีกครับ 10 ท่าน
Yeah, it's okay.
Yes.
Looks good. It's
No,
100 and one and five.
Yeah, I
But
think it's
it's
good. But we cannot-
calcium's there. It's anchoring, so I think I will leave it.
Okay, let's measure the gradient.
Yeah.
It's a 20
Definitely.
mm valve.
But you cannot post dilate now.
No.
Yeah. The gradient is not bad, right? That means the flow.
No, this is a supraannular design because we put the valve above
Yeah,
zero,
so
right?
Gradient is very nice. Yeah.
We're gonna have a good gradient.
No gradient. Yeah.
Gradient.
Yeah.
Excellent
This
job.
is- Okay.
เรียนเท่าไหร่นะ
0.
Is a supraannular design by design.
11 11 maybe zero ใหม่หมดนะ
May I
Zero
ask
ใหม่หมดจ้ะ
Dr. Nathwood,
Zero อีกทีนะ
implantation, if we aim at the radiolucent line, we should use the cast overlap view instead of T-cast view, right?
I think for the balloon expandable, I think will be just the Copan. But I think we don't. I think, but for the self expandable, I think you do cast overlapping. But I guess maybe some advantage too. But usually because balloon expandable is very short. It's not like self expandable. So I think.
Okay. Dr. Man,
can we
I
look
think
at the,
you will live like this. Is right? Yeah. I think.
Dr. Srichai will decide.
I think it's,
I think we done.
you did a good job. Yeah.
No, I
Thank
think
you
it's
so much.
good.
Yeah. Yeah. So
Looks
give a
alright
big
to me.
hand for your team. Yeah.
And we are waiting for the debate. The debate.
Okay. So we have to take some intermission for Dr. Supa. Okay.
I would like, so sorry to interrupt a little bit, yeah, because some company may have to leave early, so I would like to take an opportunity to give my sincerely thank you for all the support to the company, and we have the certificate for your participants, so please welcome every company. Dr. Pai gonna ask, and yeah.
Okay. So the first company will be Venus and Nova Health.
เป็นแบ็คกราวด์หวานให้
The next will be Edwards.
ย้ายบริษัท
The next is Abbott Company. The next is Meditop Company.
เปลี่ยนได้หลายค่าได้16x ค่ะ
and Ocrotech. The next is Life Tech and Bioprime Millennium. SMT and Vascular Innovations. Next one is Philips. The next one is Innovations. The next one is Medtronic. The next one is IDS Med. The next one is Thermo. And Teleflex. And and the next, I think we have two more. Or so. The next is Medical Solution. And the last one is RX Company.
Okay, the next one is going to be the exciting session. It's a debate topic about when our patient needs TAVI valve for the first time in 2023. The first talk going to be the self-expandable TAVA is the way to go by Dr. Tassarak Hong Thong. Please, Dr. Tassarak.
Okay, it's not a long time because I will thank you, Dr. Narathip and Nathavut, because the first valve should be Edward, but the second valve should be me. Because I will show the data that what I believe, and I will tell that almost of my center use the self-expandable. The self-expanding tower is now in the market. They have many, but this only one is a supra valve. It's like the Evolute, accurate is nearly supravalve, and Navitor is like the Portico, but the next gen. And I think the benefit of the self-expandable system is one, is like the durability that I will show you. The second is like the TAVI in the surgical bioprocessing valve degeneration that is come maybe quite often because last 10 years, the doctor, the surgeon is mostly use the bioprosthetic, not the metallic. And for the patient who has the small annulus, that I will show you the data. And the aortic valve anatomy is a content of the chunk of the calcium. And it's happy for if I have the starter for the TAVI or have the fellow and want to learn with the some system is very easier that you have seen. The last case is very like I waiting for the exhale a lot. That it will be more easier for you if you have to start the recheatable device. First, the durability for the self-expandable device is like the low list that have the 3-year follow-up is a little is still the better more than the surgery. And this is a notion that is show that notion is like the most longest in the comparable about the surgical and tower that have the mostly of the case in the notion is like the core valve or self-expandable. The durability is a very long and it have to show that maybe a little bit slightly better about the durability for 8 years compared to the surgical valve. That if I have the 1 million for my life and this is the last million that I have, maybe I think what is the longest valve that I want to put in my heart. And this is a show for the 5 year for small annulus. Even though it's small, it has still better for the biodegradable valve deterioration. And if it's big, it still have the benefit for the core valve or self-expandable device. And this is maybe this is not significant, but if you see, if you have the Sapien for the 5 years compared to the transcatheter and surgical, the Sapien XT is the old one. Maybe we can looking for the new one for the Sapien 3. The Sapien XT is like the higher structural valve deterioration more than the surgical. That everyone is like the maybe we looking for the Sapien 3, not the Sapien XT. And this second, that I think the TAVI in the surgical bioprosthetic valve should be self-expandable. This study is come from the Netherlands. If you have the surgical bioprosthetic valve degeneration, the better about the cells, it show that 1 month and 1 year have the slightly the less of the complication about the mortality, stroke, and major bleeding compared to the balloon. Even though it's not significant, but they have the trend like this, maybe we have the more patient and more data for the long term. And this one is the first speaker talk about they had the randomized about the surgical bioprosthetic valve degeneration, and they have the little bit, maybe nearly 50 case and 50 for cell, and just follow up only 1 month. It can show that only 1 month we have the severe PPM is have less in the self-expandable. Even though the transvalvular gradient is not important anymore for that, but it's only 1 month. Maybe we wait for 1 year or 5 years. Maybe let's see. And this is a baseline trial. They have the 400 case and come from the Europe and America, and we can wait for the result. And this the third that I think the self-expandable device can do well is like in the small annulus. This show in if you have the self-expandable device like the Portico or Evolute, the severe PPM is less. And even though it's moderate, it's still less, more than the balloon expandable device that I will bring you to the correlation about this. This is a new definition of the severe PPM. This is a registry in the Sweden that they have corrected the case 10 years ago, and follow-up is the end of the study in the 2019. Definition of the severe PPM is divided into category. If BMI is smaller, it's like in Thai people, or is a big guy, it have the difference of the number. And they have the half of the patient is like the moderate. And the result is, if you have the moderate PPM, you have the all-cause mortality higher than no PPM. You have the chance of the heart failure hospitalization more than the no PPM, and you have the chance for the reintervention more than the no PPM, even though it's just moderate PPM. That is shown in the graph. The heart failure hospitalization is higher if you have the severe or moderate. And you have the chance for reintervention for the tower. It means that if you have the no PPM, is better. And the fourth, the chunk of the calcium. I will show you the case that even though it's just like the spot of the calcium, but in the annulus or alveoli, you have seen this. This is a calcium. It's not a lot, but it's just located in the important location. And you can see after we deploy the valve, we have the contrast outpouching. These cause the periannular hematoma. This case follow up CT in the first day and can discharge in the 1 week, but we have the something is happened here, you see, but it's not go to death, because if he dead, we not have the scene name for show to you. And the last thing is the resheathable. The resheathable is mean you can get the position if you want until you're happy. I have the experience unsheath or resheath and unsheath for the 20 times. That everyone is okay. I have the final in the 20 times for resheathable, but everyone is happy. And what is your concern? Why you not put the self-expandable device for the first? I know about that because you worry about the conductive disturbance, but now we have the cast overlap for coping the problem. You have concern about the coronary access. We have the commissural alignment to manage this one. And you can see the pacemaker rate is reduced from 20 to 11 if you follow for the protocol of the cast overlap technique. And these are only 9 if you have followed the cast protocol overlap that come from the GUBE last year. And you can get easier coronary access if you have followed about the commissural alignment to have turned the pot to the triococ. And this last data that I showed you about the meta-analysis, about the long term between the self-expandable and balloon expandable is all-cause mortality is the same. Stroke is the same. The PPM, I think we have, now we are going for manage to decrease the percent of the permanent pacemaker. About the AKI, even though you have the contrast, I think it's the same amount because you test a lot. For the last case you see in the live case that have the contrast a lot. A bleeding, I think the sheet of the inline sheet or the self-expandable may be not quite huge. And the major vascular complication is mean the self-expandable is do very well. And the device success, I think is the same. The PVL, I will accept that is more than the balloon expandable. And these are very striking for me. The mean gradient and the peak gradient is very, very, really significant, better in the self-expandable. And my conclusion, this self-expandable TAVI device is a better durability, better gradient, no adverse event, easier in valve, and easier in the coronary relaxation. And for me, I looking for the balloon as well, like the what is called, you are very strong, you are forceful, but for me, I am beautiful. And I have fly with the gentle and ceiling. This is my idea. You can choose what you want because it's a hero boat in your heart. Thank you.
Thank you so much, Dr. Hasak. The next is going to be the balloon expandable valve is better by Dr. Nathavut from Sirirat Hospital.
ขอต่อให้นิดสิ
Minute, do you have 8 minutes for your talk?
He asked for connection. So we will have like a friendly debate. So I have to fight with Elsa, so too bad.
I never thought I would hear the word beautiful from Dr. Tasalak. Contrast.
If I lose, but I have still beautiful.
Okay, thanks. Okay, thanks. So I think I will be look from the exercise. Why I think when our patient need a TAVI for first time in 2023, balloon expandable valve is better. So I think let's thinking Dr. Tatsalak, my Elsas have been told that the durability of the cell expandable is better. But I think we can show here. I just pull up the slide when she give a talk that when you look in the XT, which is not used anymore, maybe have some higher, less durability. But when you look at the S3 that we use at the moment, when you compare to Perimal Magna, which is a standard of the prosthetics valve, and you know that Perimal Magna can last for 10-15 years, and ST as good as Perimal Magna. So I think durability is no issue. Small annuli have been thorough talk. I think I'm agree if the patient have prosthetic mismatch, self-expandable maybe should be, but when we put the valve, we have the heart team evaluation, and if you put like appropriate size of the valve to patient body surface area, I think the outcome is no difference. And now, wise BAV that I have prepared, I think it's the first valve because of coronary access, because of conduction abnormality, future valve involved, and maybe versatile in complex anatomy. I think with the TAVI device at the current moment, you have some still have some gap of things that you have to improve. Paravalvular leakage, durability, coronary access. If you have like small STJs, small annulus, and you put the supraannular valve, I think coronary access is going to be very difficult. And also the pacemaker, as we know that compare between the balloon expandable and cell expandable, balloon expandable have the less pacemaker. So let me go one by one. So S3 have the good designs with the short frame, and they have the big frame that you can access on both coronary artery. And even though you try to cut overlap to align the valve, you can see from this data with absolute or accurate NEO, you still have 15% that maybe not truly overlap. S3 maybe have 30%, but it's very short frame, so there is no issue, is no problems. And this is confirmed from Align Access. Looking at the real world, 200 patients, and you can see with the S3, even though it's no overlap, you have the able to selective engage. But if you have the supraannular, if you align, if you're lucky to align, you have about 70% to selective engage. But you have maybe up to 25% that may be non-selective engage or not feasible. And if you not align, you're in trouble. And you can see how fast the S3 compared to cell expandable to reaccess. And if you use S3, when you angiogram, you do like the same. But if you have the supraannular, you have to think what the guiding and thing you have to use. And this is the case example in the case report. A patient have this, we do the case, and patient maybe come back with STEMI. And then they do try to do the PCI with the EBU, and then they end up the guide entrapment. And then with the entrapment, they cannot remove the catheter and cause the dissection of left main. So the patient end up catastrophe with die, with death. Another next issue is conduction abnormality. We know that the patient baseline with right bundle band block, depth of implantation, and use the self-expandable is a predictor for conduction abnormality. And when you have conduction abnormality, we have pacemaker, you have increase of mortality. And especially if you put the young people, I think that will be issue. So you can balance, try to higher depth of implantation, but then you will end up a block of the coronary access and may future in TAVI. And this is our study that we look at implantation depth compared to membranous septums. And if you exceed 0, that means that you deep more than membranous septums. So you can use this to tailor-made, but I think this also the benefit of the S3 because of you have the short frame, so you have like a minimum implantation and you still able to access the coronary artery. If you put the valve in the first time, and if you have to redo, if you have to expand compared to repeat TAVI, you can see the mortality is double with the expanded. And if you expand the extra supravalvular, supraannular device, it's going to be more difficult because of adhesion. So I think you have to do the bent-out compared to just the valve. So I think with the S3, now we do younger and younger people. So with the S3, you have more benefit for the future valve with valve. I will go through with the factor of coronary access and reduce TAVI. I think TAVI height leaflet above the coronary ostium, TAVI height leaflet of STJ. If the annulus is small, if you put the supraannular device, I think this is all the factor that you might not able to do that redo TAVI, and you have to go back for expanded, which is not good for the patient. And I have set 3 scenarios if you have to do the TAVI in TAVI. Once you put the first valve with the balloon expandable, then you put a second valve with balloon expandable, you can access on both. The second, if you put the cell expandable at the first time, as Dr. Tassalat Maelsas have been mentioned, and then you put the cell expandable again, if the annulus is small and leaflet height is below STJ, you have 78% that you cannot access coronary artery. But if you put the cell expandable at first, and then you put the balloon expandable, you may be able to access, but remember the scenario that if you leaflet plane is at the coronary, even though you put the sapien at the second time, you might not be able to access. So I think that's why the first valve is very important, and we don't want to reopen the patient. A balloon expandable also have some versatility in case like bicuspid, you have calciums. But if you use circle method, even though you have a lot of calciums, I think you're still able to do the case very well. And this is the, when you do the bicuspid, most of them is young patient. I think access of coronary artery is also important. So in conclusion, so I don't want to take much time. So when you need the first valve in 2023, I think coronary access is very important. Conduction abnormality, you can put the higher, but you will block coronary access and then block future valve with valve. So I think we have to think about the lifetime management, and I think balloon expandable is the way to go. Thank you.
Thank you, Dr. Nuth. Because we run out of time, we don't have the time for Q&A, but I just would like the audience to vote who's going to put the self-expandable valve for your patient at the first valve. Please show your hand, please. No one. And who's going to put the balloon expandable valve as your first choice? No. Okay. This session is closed. This is going to be, the next one going to be the education symposium. I would like to invite the next moderator, Dr. Pulish and Dr. Valalit.
So, good afternoon, everyone. So now we will begin the educational symposium, which we will have lunch during the symposium also. Okay, let me introduce myself first. My name is Dr. Pulish Suranchupakon from Central Shade Institute of Thailand, and on my right side.
And my name is Warit Rajwasari from King Chulalongkorn Memorial Hospital, Bangkok, Thailand.
First, allow me to introduce the first speaker of the session. We are honored to have Professor Bob Ma today. He was past President Sky and Chairman of ACC Intervention. Now he is Vice President and Chief Medical Officer in Korea and Structural Intervention at Medtronic, based in Boston. Okay, please.
Hello, can you hear me okay?
Yes, I can hear you.
Oh, perfect. And then the second thing I need to do is make sure you can see my slides okay, if that's all right. Let me just see. Now, can you see slides okay?
Yes, good.
Yeah, okay, good.
Yeah.
All right, well, we may be able to get through this after all. Well, so thank you for allowing me to join you today. I want to be there in person. That's all I'm going to tell you. It's been a long time since I got to Thailand, and I need to get back. I love it there. And to be in person is always so much better. But all I can do is be here at about 1:15 in the morning. It's just like doing STEMI call, about 1:15 in the morning. I was very intrigued with the last talk. I mean, I think as a clinician, I planted TAVRs until about 2 years ago before I came to Medtronic, and I was a splitter. I used both valves. I found both valves were incredibly important for specific anatomic subsets. I don't think that we all live in a one device world. We have to think about multiple devices. And I think that the designs are going to matter. And what I'm going to do over 15 minutes or so, and I think that maybe we can take some questions and answers after that, depending upon your time, is really going to be talking about how we have these multiple valves that we have from Abbott with Navitor and with Accurate Neo2 and with Genival Trilogy for aortic insufficiency and our supra-annular valve, all tall valves with tall frames. And then we've got the very important balloon expandable portfolio that's at S3 right now, but ultimately it would be at X4. They'll have commissure alignment and resilient tissue. So let's talk about what the value of these different valves might be. There's no question that for the last 15 years, we have believed that the Evolut design was built for durability. We thought that. We didn't have any data. We didn't really know how we were going to prove it to anybody, but it was built for durability. It's got long leaflets that are reverse canted. They're thin porcine pericardium. We have lower gradients, which I'll show you are going to be important. The inflow of the core valve is very strong. Evolut is very strong, so that it wraps around the calcium, doesn't cause things like annular rupture. And then we have a pericardial wrap to reduce paravalvular regurgitation. And the durability studies have been quite good. So that's how the valve was designed. It was designed for durability and be different. We've learned a lot about procedural technique in the last couple of years, a lot. We learned that with the predicate technique of the 3-cuss view, that we were planting our Evoluts too deep, and we had pacemaker rates of 15–18%. You've heard very briefly that cusp overlap has made a difference, and it has. We now understand the importance of commissure alignment for coronary access. We understand the importance of the cusp overlap technique to be able to get pacemaker rates that are low, and they're down under 8% in our US TVT registry. But this slide was shown just a couple minutes ago about Giuseppe Tarantini's very important Align Access study that said commissure alignment is everything for our core valve. And although that we look upon whether you're selectively in the coronary or get a diagnostic picture, Dr. Tarantini didn't take much time. It was a 10-minute limit for getting in, and no advanced techniques were used. But with that, 99% of the left coronary artery was visualized. Most of the time it was cannulated. And 98% of the time, the right coronary artery was visualized. Most of the time it was cannulated. So absolutely, commissural alignment is going to help us with coronary access. The case that was shown with the EBU catheter was a case from Morristown Memorial from Philip Genereux just previously. That's the only time I've heard that happen like that. That's the only time, because we now don't recommend using EBU with catheters. That was probably 8 years ago or so when that case was done. And we're very careful with how we do alignments right now and don't entrap catheters. So look, it takes a little bit longer. Everybody's a skilled interventionalist. Giuseppe Tarantini is a great clinician. 98% of the time, 97% of the time, he got pictures of vessels, which is important. And I think we're going to move towards coronary alignment, which will be even better over time. We have some new generations that we have here. I hope we're going to get it to you as quickly as possible. We've got it now in Japan and in New Zealand. It's called FX. It's a better delivery system. It's not quite as simple as line up the dot and inflate the balloon, but it's pretty close. And what we've learned from that is that 97% of the time we get commissural alignment, we get a much more symmetric delivery. And look at the rates of paravalvular regurgitation. You probably can't see them, but in this 86% of patients, 86% of patients had none or trace paravalvular regurgitation with this new valve because the deployment was so much better, easier, doesn't move, more symmetric. But we really got to come down to some fundamental issues, and I just want to address those very briefly. Is what does durability really mean? This slide's an important slide. I have never seen so far, maybe there's some out there, any data where S3 has been better than surgery. It comes out the same as surgery, maybe in some studies, the Partner 2A study, maybe a little bit higher than surgery, but I've never seen it better. This is a conglomeration of data sets that we've analyzed for the last 10 years. Notion, 8-year study, half the rate of structural valve deterioration. Surgery, in our 1,000 patients in the surgery arm, 1,000 patients in the TAVR arms, half the rate of structural valve deterioration. And look at those differences in small annuli. Again, SAPIEN has never shown to be better than surgery, to my knowledge. And so we'll say it's the same as surgery. But the core valve is not the same as surgery. It's very, very different. So then we went to a next stage. It's okay, fine. Structural valve deterioration is a rare thing, doesn't happen very often. What about bioprosthetic valve dysfunction? 4 components by our guidelines. Structural valve deterioration, non-structural valve deterioration, thrombosis, and endocarditis. That's it. That's the full gamut of bad things that can happen to heart valves. And so as a result of that, we said, well, wait a second. When does severe PPM happen? What happens early? When does thrombosis occur? It happens all the time. What about SVD? Well, it's late. So we put these all together and said, okay, let's compare then the rates of valve performance with Evolut and core valve compared to surgery. This is what we found, presented by Steve Jakobat at Late Breaking Clinical Trials. Bioprosthetic valve dysfunction was half the rate of surgery, but it started early. It made a big difference. At 30 days, you have PPM, and that only continued to separate. Not much difference between surgery and Evolut with respect to thrombus. Very different with the S3 results in Partner 3, where there was a 2.6% incidence of valve thrombosis with SAPIEN 3 and 0.7% with surgery. So whatever that is, 3 times higher rate of valve thrombosis with S3. So it's a big deal. And so whether it was a small valve or a large valve, this valve performance was just better consistently with the suprannular Evolut valve than it was with surgery. And these are the numbers, even in the large valves. This is the important slide right here. This is the important one. This is a relationship between the occurrence of bioprosthetic valve dysfunction and mortality, okay, and mortality. And there was about a 1.5 to 1.8 increase in mortality if you had bioprosthetic valve dysfunction. And remember, that's accentuated in the smaller annuli. Better than surgery, and we've never really seen S3 better than surgery for any of these analyses that I've seen. So this is the real deal. And of course, we're going to do the SMART trial to demonstrate this. Now, what happened in partner 3? So we have 2 low-risk trials. We have our Evolute low-risk trial and our partner 3 trial, 2 low-risk trials. And the left side is our Evolute 2 years. Look, those numbers in the blue are always lower numerically than the red, which is surgery. Look at what happens in partner 3, again, low-risk patients. It was lower at 1 year, but those curves came together at 2 years, and we're waiting for the 5-year data for TCT. So we said, what happens at 3 years, right? These curves are very, very active. And so we said, what happens at 3 years? Well, this is what happens with 3 years with all-cause mortality and disabling stroke. A 30% reduction in all-cause mortality and disabling stroke with CoreValve compared to surgery, or sorry, with Evolute compared to surgery in low-risk patients, where it's the most important. Let's see what partner 3 shows, right? Those curves were converging at 2 years. Ours considered to separate at 3 years. So let's just see. Does make a difference. Valve performance does make a difference for the patient over their lifetime. And the PPM is really what drove most of the differences that we saw. So I think that really what we know now is we talk about things. I want to show you one last slide here from our registry of CAS registry, intermediate risk patients. I want you to show you the rates of paravalvular regurgitation at 5 years, period analysis in those patients when the registry treated with Evolute. The none to trace was 72%, 73% at 1 and 2 years. At 5 years, the none to trace paravalvular regurgitation was nearly 90%. That tells you that that self-expanding valve is still expanding. Whatever residual regurgitation would gets better. And that's why you want to pick a self-expanding valve, because better valve performance, favorable remodeling of the valve over time, no recoil. And this is really what we need to do as we think about. Now, there was a statement earlier about how you treat this. It's a long, complicated issue. We've had lots of publications. Toby Rogers just presented at the ACC our results for our feasibility study. And we do believe that by positioning the Sapien in a failed core valve in the right position, that we can achieve coronary access with good case planning 80 to 90% of the time. And that's being able to do these simulation models. Don't have time to talk about it today, but we're certainly going to those simulation models as well. And of course, we talked about HALT. So I want to stop there. I just, maybe we can see if there's some discussion as we go, because we are really at an important point, right? Look, I understand that there's a very critical need for Sapien balloon expandable valves in the world. But there's also a need in the world for a self-expanding valve, particularly as we talked about the real issues for patients, which is durability. And these durability are starting to show up in 5 years. So if you treat a 75 or 80-year-old patient and they've got a good life expectancy at 5 to 10 years, stuff's going to happen and does happen and is happening. Now, with respect to durability, we got to think about lifetime management. I agree with that. And I got to say, the way we look at it is maybe we put the most durable valve in first. So that would be, Evolute by all accounts, and we've got a very good treatment plan moving forward if in some rare event that Evolute valve starts to fail. So let me just stop there and see if you guys have questions or thoughts or comments as we think about how we choose valves, because I think it is an important issue for everyone. Okay. Well, it sounds like you guys are a little bit behind on time, and it doesn't sound like there's too many questions or comments. I wish I was there with you guys. Maybe what I can do is I can sign off and I can let you guys get back on time. And I really thank you for the opportunity to be there. Hopefully, we'll have more data for you. These are 1,000 patient studies in each group that we've got, and we'll follow that. We've got more of this type of analyses that's going to come up in younger patients, hopefully at ESC and at TCT. So listen, I really appreciate the time tonight. Thank you. Thank you so much. And then maybe I can get to visit everybody soon. Thank you.
Thank you, Professor Popma. Sorry that we are delayed to answer your question, but may I have one short question? Because you,
of course.
You talk about the hall. So in your idea, what do you think about the screening CT after TAVI, or just echo 1 year is okay? Echo every year or CT every year?
Yeah, it is echo. We can do this with echo. So I think we can do this with echo. I don't think CTs to detect halt are going to be useful, because unless there's a clinical manifestation of the halt, like a change in gradient or a stroke or AI, there's not been much benefit to treat them with NOACs. So what I do, I still see patients, and I said what I do in my practice is I screen patients every year, and if I see a change in gradient, then I would act and give a NOAC to try to change that. If a patient has symptoms that are new or has a stroke, then an echo is a good way to start. We can always use TEE and CT to confirm, but really we get the best, the surveillance part of it. I think we pick it up by changing gradient. The criteria we use is a change in gradient more than 10 and a mean of over 20. That's the criteria we use for treatment.
Thank you very much for your fruitful lecture. Thank you for joining us today.
Thank you so much. Have a good day now. Thank you so much.
And next speaker is Dr. Krishna Mimuk from Rama Tripadi Hospital, Mahidol University, Thailand. He graduated from the Rama Tripadi Hospital and have the interest in the mitral cliff and graduate in the mitral cliff in the Sinai Hospital. Today, he will show live in the box the mitral cliff, please.
Thank you, Dr. Oris, for introduction, and I would like to thank the PSU team for invitation. My today's talk is the life in the box about the mitral cliff. This is a 70-year-old female. She had a history of endometrium cancer, stage 4B, status post chemotherapy for 8 cycles. Now it's on the stable disease. And she also has the triple vessel disease, status post the PCI of the LAD circumflex and RCA 2 years ago. Now the coronary angiogram show the good patency of the all stents. And also CKD stage 3. And now she has a history of the heart failure from prolapse of the anterior mitral valve leaflet and restriction of the posterior leaflet. And this is the screening TEE. You can see the ejection fraction is about the line low, and on the long axis view, you can see the prolapse of the anterior leaflet and also the restriction of the posterior leaflet that we call the mixed pathology. This is the new entity of mitral valve disease, not the primary and secondary only. Now we have the mixed type of the disease. On the color side, you can see the jet is an eccentric posterior directed jet. When we measure the ERO, it's 0.46. This is a severe TR. Because she has multiple comorbidities, we brought the patient to the heart team conference, and the SS score for the mitral valve repair is 4.2%. After heart team discussion, heart team recommendation for mitral valve edge to edge repair using the mitral clip device because of multiple comorbidities. If you look at the guideline from the ESC, now for primary mitral regurgitation, the mitral clip or edge to edge repair, any edge to edge repair considered as a 2B recommendation for the symptomatic patient with the fulfill echo criteria, and on the high surgical risk or inoperable by the heart team. This is the important role of the heart team to just the patient would be treated by which option. And for the secondary mitral regurgitation, the TIA should be considered as the selected symptomatic patient with high risk for surgery and fulfill criteria for increasing the chance of the responding to the treatment, as we call the COAP criteria. This is a class 2A recommendation. For this patient, the patient is a mixed type. I would use the secondary mitral regurgitation criteria. This is a 2A recommendation for MTR for this patient. Okay, I will show you the movie. Yeah. This is a bit fast. Okay. For the MTR, normally in our hospital, we did a 2 access. One is a jugular vein to do the right heart cath, and we did a right heart cath and also the measuring the cardiac output all cases. And another access is a groin, right femoral vein for putting the metal clip sheet. As you can see on the right upper panel, the PA pressure in this patient is a bit higher than normal. And after we did the right heart catheterization, we make the right groin puncture to access the right femoral vein. This has been done by our fellow and our junior. And after that, we put one proguy to do the pre-course, the vein. We don't do the 2 pre-course, we only 1 pre-course. This is the pre-course. And if you don't do the pre-course, you can do the figure of 8 after the procedure is 5 for 25 French sheet at the vein. For doing the pre-course to the vein, you don't pull so hard because the vein is not strong as the artery. You can just pull back a little bit. And after do the pre-course, we normally put the last French sheet, we put the 16 French sheet to dilate the vein already. If you don't put the 16 French sheet, you can do the serial dilatation before the putting the metal clip guide. And normally we put the 16 French sheet into the groin. This is the 16 French sheet. You can see the sheet up to IVC. After that, we put the transseptal sheet into the 16 French sheet. This is normally we use the SL1 sheet and BRK needle. And I normally make the curve like a 90 degree to pointing to the posterior part because for the transseptal puncture for the mitral clip, we would like to go at the mid septum and posterior. That we make the curve like a 90 degree curve. And normally we puncture the septum with stylet. We don't do the pressure measurement of the atrial pressure through the needle. We just keep the stylet inside the needle. And when the transseptal puncture, we use the echo as the most. First is a bicaval view. This is superior, this is inferior. We would like to be at the mid of the septum. And also on the right panel, this is a short axis view. This is the aorta. This means anterior. This means posterior. We would like to be at the mid and posterior. And if you got the location mid and posterior, you will ask the echo guide to measure the height of the transseptal point, because for the mitral clip, we would like to be at the 4 to 4.5 above the annulus. After that, if we satisfy with the location, we did the puncture. Normally, we use the stylet to puncture the septum. Because if you don't use the stylet, sometimes the needle is slip and not. And this is a stylet. And after we puncture with the stylet, we put in the whole system, and we put the sheet in while keeping the needle in, steady. Or this is This is a 3.8. You can see on the left lower panel, we push the sheet in, and now we put the sheet and remove the dilator. After that, we giving the heparin. Normally we put 80 to 100 unit per kilo, and measuring the ACT, keeping about more than 300. And in our hospital, we put the 2 Y into the left upper pulmonary vein. This is a soft Y, and after that we advance the sheet, and we put another Y, is a AMPAS super stiff Y. Why we put the 2 Ys in? Because we would like to measure the left atrial pressure continuously. When we put the 2 Y, we can put pigtail catheter and the guide catheter together. Now we have the 2 Y in just one septal puncture. Now we put the pigtail, 4-fen pigtail, for the left atrial pressure monitoring continuously. Now the yellow panel is the left atrial pressure. It was 20/7 and mean about 12. And after we put the sheet in, the sheet size is a 25-fen sheet into the same venotomy. And when we put the sheet up to the diaphragm, we make it neutral and pushing toward the septum. Now we look at the echo. Now the sheet go into the left atrium. We would like to be at the 2 cm into the left atrium. And after that, we put the clip. This is we use a XTW clip because leaflet length is okay and area is okay. We use a thicker and longer clip because we would like to got the maximum MR reduction effect. Now we're standing down using the echo and follow guide. We put the M knob, and after that we check the trajectory. After we check the trajectory is mean we would like to go at the center of the valve to the apex, not the dive to the medial or lateral. Now I think the trajectory is okay. After that, we check the valve perpendicularity, the clip perpendicularity by open up the clip. Now we're checking up the trajectory. And yeah, if the trajectory is okay, now we open up the waiting for, okay, I think now it's okay. The clip is going down at the mid of the valve and also the anterior posterior also. We can adjust every direction by pushing and pulling to go lateral or medial, and clock and counterclockwise to go anterior and posterior of the valve. I think this part is the most important. If we go down in the wrong way, medial or lateral dive, it may cause an entangle below the valve. Now we check, we are at the lesion. Now we're splitting the jet. I think this is a good spot to start with. And now we ask the echo guide to do the TEE and 3D TE. We open up the clip. And we would like to be at the perpendicular to the coaptation line. Now it's like at 2 p.m. and 8 p.m. We are counterclockwise to make it at 12 and 6. Now you can see the clip is slowly counterclock, and now it's perpendicular to the coaptation line. It's okay now. When you are at the perpendicular at the valve, now we're checking the gripper. Because the fourth generation of the metal clip, you can do the independent grasping. You have to know which one is the anterior, which one is posterior. Okay. Now we're checking the gripper. Now you see the posterior gripper and anterior gripper going down. And when we crossing the valve, we close to the 60 degree of the clip, and we go down and we carefully watching not to go medial or lateral when you go down. And when we go down to the valve, you open up the clip again and check the perpendicularity again. And I think this is a little bit clockwise. We make correction by counterclockwise. I think it's a good spot now. And we, Dr. Choi. Okay, now we are ready to grasping the valve. We close to a 120 degree of the clip and pull back slowly. You can see the anterior riblet and posterior riblet sitting at the clip very nicely. And if you see this, you can down the gripper. You can see the gripper side is mean the gripper up and down and closing and pushing forward a bit to release the tension. You can see the V-wave also down on the left atrial pressure. This is a beautiful of the measuring the atrial pressure throughout the procedure. This is the echo after grasping. We ask the echo guide to see one is the leaflet insertion, another one is the ratio MR. This is just mild or test MR. And after that, we're checking the gradient. The gradient should be less than 5 after clipping. And you can see the E wave now lower than A wave. This is impossible to be the CVMR. This is a good sign. The gradient was 3. That's okay. We would like to be at the lower than 5 millimeter mercury. And after that, we check the prevent 3D and phase to see the tissue breath. Okay. You can see the tissue bit and the valve open up into the double orifice valve very nicely, and you can see the bridge is very thick. It means you got a lot of tissue, and make sure you will not make the detachment in the future. And after that, we measure the left venous flow. It was a reverse before the procedure. 3D again. You can see the procedure when we stay down and go down and grasping the valve just only, I think it's 5 minutes, and we have to be careful on the transeptal, position the valve, position the clip above the valve, and post grasping echo measurement. On the 3D color, you can see the only trace MR left. And the next, we ask the echo guide to check the prevent. It was the reverse before the procedure. Now it's normal, S dominant. We're checking both sides, left prevent and right prevent. This is beautiful. With this procedure, we can measure the result immediately and real time. For the surgery, you have to stop the heart lung machine and recirculation of the blood and checking the outcome. But this you can see immediately and real time. You can see the improvement of the gradient, improvement of the prevent flow, and also the left atrial pressure. This is normal. I think if we see everything is good, we're ready to deploy. we move the C arm to see the clip arm. And this is a deployment step. We checking the lock line and remove the lock line. Now we are removing the lock line now by Dr. Mann. And after that, we check the lock function again. After that, we deploy the clip. It's a bit fast. I'm moving. Okay. Now we deploy the clip. And we're checking again if we satisfy the result. Now we're ready to remove the system out of the patient. You can see the blood pressure still low, 11. And after that, we check the right heart cath again and also measure the cardiac output after the procedure. And if we okay, we just put the wire into the left upper vein through the pigtail and we remove the sheath. Sometimes we need to close the septum because the right to left shunt in the patient with the long-standing pulmonary hypertension or tearing of the septum. We have a safety wire. We put the sheath and we close by the SD device. And after we remove the sheath, we close the coil by the pro guide. And as I said, if you don't do the pro guide, you can do a figure of 8 after the procedure instead, and it's worked very well. I think this is a finish of the case. I would like to show my slide. Okay, and I show you the video of the metal clip. This is a very, very beautiful procedure because you can see after the procedure is just test of my MR left with just one clip. This is a device time in this case just 24 minutes after puncture the septum until we remove the guide catheter and use contrast just 0 ml. We no need to use a contrast for this procedure. And patient no need to stay in the CCU, just stay at the inpatient ward and she can go home in the next morning. And now 6 months after the procedure, she is in the NYSA class 1 and no heart failure admission after the procedure. And I would like to talk about the current generation of the metal clip. Now we call the G4 metal clip. We have a 4-side clips. It's a narrow one we call NT and XT. The XT mean the narrow and longer, NT the narrow and shorter. W version is the thicker by the 50% from 4 mm to 6 mm. The thicker and longer we call the XTW. This is the biggest clip that we have. For the real world study of the G4 study, we call the Expand G4. This is the patient, about 1,000 patients. You can see for the G4 device, the implant rate is high up to 98%, and acute process success is 96%. And also device time is going down from the previous generation is 46 minutes to the 35 minutes. It's a very, very quick procedure. And the total procedure time from the puncture to groin close is about 27 minutes, just more than 1 hour a little bit. And the clip length is down from 1.5 to 1.4 because we have the bigger clip and the longer clip. We can treat the patient with a single clip more and more. And the efficacy for the MR reduction at the 30 days, you can see the 98% of the patient has a MR 2 plus or less at the follow-up, and 91% has a MR 1 plus or less at the follow-up at 30 days. This is quite impressive. And also, as an event is very low. The all-cause death in this patient, in this group of the patient, is 1.3% at 30 days, and the leaflet event, the SLDA, single leaflet device attachment, is just 1%. The last, I would like to show you the current status in the Thailand. Is now we are performing more than 160 cases, and And this is we have a lower number during the COVID era, but we are getting recover. Last year in Thailand, we performed 46 cases, and this year we performed 11 cases already just 3 months of the years. Okay, this is my talk. Thank you for your attention. I would love to take the question.
Thank you for a great talk. In the case you present, which type of clip do you use?
I use a XTW. That's because the leaflet length is long and the lesion at the mid of the valve. If you treat the lesion outside the middle part, like A1 P1, A3 PT, that is a shorter the leaflet length, and there are many chordal there. We usually use a shorter clip like a NT or NTW, but for the mid of the valve and the valve is okay, we can use, I think we use the biggest clip that we have, XTW.
And you said that you have the two mechanism of pathology, primary and secondary. One clip can do both.
Yes. If you look at the echo, if you use the shorter version of clip, sometimes you got difficulty to grasping both leaflets together, because when you pull back, you're touching the posterior leaflet first, because posterior leaflet is a restriction, but the anterior leaflet is higher because it prolapse. If you use the longer clip and bigger clip, you can get it in both clip arms very easy.
Great technique. Okay, thank you.
Thank you, Dr. Kista, so much. So due to lack of time, so maybe we will have a question after the session. So let me introduce the last speaker, Professor Yuan Feng from West China Hospital, Sichuan University. He's now the director Cath Lab in West China Hospital. He will talk about Dragonfly. Please, welcome.
Okay, thanks very much for your introduction. Since Dr. Feng is currently on the operating table, I will present this lecture on his behalf. And I will introduce the research update and case example of the Dragonfly TU device. I think there is no need to talk too much about the background. Mitral regurgitation is a highly prevalent disease among the elderly patients with prevalence about 7.3%. And we all know that there is a mitral regurgitation classification of the Carpentier nomenclature. And currently, the transcatheter mitral valve intervention techniques are developed in correspondence to those conventional surgical techniques, including replacement, annular repair, and leaflet repair. And also coronal repair is also possible with some transcatheter devices. But among them, at the current stage, transcatheter edge-to-edge repair is still the most mature technique with the mitral clip implant experience of over 150,000 cases. So Dragonfly is also a TU device which could be introduced via the transfemoral access, and the target patients include both degenerative and functional mitral regurgitation. And we can see on this slides of the size of the lip, and there are wide and long devices, and also there are less wide and shorter devices. And using the wide and long type as example, the width would be 6 millimeters, and the length of the whole device would be 18 millimeters. And the operators would be able to select appropriate device type according to the patient's anatomy and also the etiology. And one of the big difference as compared with MitraClip is that the Dragonfly device handles has some markers which the operators could use for markers when they rotate or adjust the deflection or flexion of the delivery sheath. And currently, the theme study for degenerative mitral regurgitation has already been completed, and I will show some preliminary data which were reported during the theme study. And in this theme study, 3 centers participated in it, and the patients were symptomatic 3+ or 4+ DMR or FMR, and the total number of patients included were 23 cases, and follow-up would be 1 year. And the mean age of the patients included in this theme study is 76 years old, and many of them has atrial fibrillation, and the effective regurgitant orifice area is 0.5 centimeters squared. And from this slide, we can see that after the procedure with Dragonfly, all of the patients achieved very satisfactory results with all of them being with no more than moderate mitral regurgitation. And also at 1 month follow-up, the results remained stable. And actually, the Dragonfly study has 2 arms, one DMR and one FMR study. And the DM study has completed enrollment, and currently the FMR arm is still recruiting patients, and the estimated number of patients being included would be 120 cases. So I will share with you one of our Dragonfly DMR case. That is 82-year-old male patient who presented with repeated chest distress. There is no angina, and on admission, he was on NYHA functional class 3. His past medical history include atrial fibrillation, hypertension, stroke, and prior PCI. Coronary angiogram showed no significant stenosis, and he was on medication before the procedure, including beta blocker and diuretics. And echo showed us clearly degenerative mitral regurgitation of Carpentier type 2, and the severity was graded as 4+, and the effective regurgitant orifice was 0.4 centimeters squared, and regurgitant volume was 64 milliliters. And LVEF was preserved, and left ventricular and diastolic diameter was 45 millimeters, and there was mild aortic regurgitation. And because of the age and the comorbidities, this patient had high surgical risk, and therefore TO was considered appropriate treatment for this patient. And from this echo images, we can see that this patient had A2 prolapse, and there was MRGF from the A2 region. And this was the septal puncture view. And the puncture height was 44 centimeters. And this height is appropriate for this device delivery. And on this image, we can show that the operators are trying to manipulate the device to achieve coaxiality with the mitral valve anatomy. And after confirming the orientation of the device, the operators then doing the trajectory. And with this step, we can also see that the device position is okay. And with this device, the operators would be able to clip one by one the two mitral leaflets. And this is one of the advantages of the Dragonfly. And when confirming that both anterior and posterior leaflets has been firmly grasped, the second operator will close the arms to grasp the anterior and posterior leaflets. And at this stage, we can see that the mitral regurgitation reduced significantly. And although there is still mild regurgitation, but we think that this is more than satisfactory, and could be the procedure could be stopped here. And also after the release of the device, pulmonary vein reversal disappeared, and also the residual regurgitation is minimal. And as we can see from the serial echo follow-up from pre-procedural to post-procedural images, we can see the changes or reduction of the mitral regurgitation, and also the regurgitation. The effectiveness remained stable at 1 month follow-up. And also, we have performed FMR cases with the Dragonfly devices for some patients with cardiomyopathy. And also, it also showed very encouraging results. And using this 50-year-old patient as an example, the mitral regurgitation decreased from 4+ before the procedure to mild after the procedure. So in summary, the transcatheter intervention for mitral regurgitation are relatively more complex procedure when compared with TARVI. However, at the current stage, it also showed very encouraging results. And the Dragonfly is the first transfemoral TEER device in China, and has shown promising results for the treatment of both degenerative and functional mitral regurgitation. And further studies are still ongoing to validate the effectiveness of the Dragonfly device in FMR and also tricuspid regurgitation patients. So that's all for the presentation. Thank you very much.
Thank you for your presentation. May I have some short question. So because it is the new device, so do you have a longest term follow-up for in the case that you using this device? I mean, that the first case that you do, how long was it now?
That was in 2021. So it has been almost 2 years.
So, and durability is good, and the MR is still low, right?
Yeah, according to our follow-up, the patient is feeling very well, and at the current stage, the mitral regurgitation is still 1 plus.
Thank you very much.
Okay, thank you very much.
Okay. And now at the end of the session. Thank you everyone for the attention.
So let me introduce the next moderator session, Dr. Man and Dr. Piya, for the next PPVI session. Thank you for joining our session.
So next session will be PPVI, and let me invited Ajahn Man, Ajahn Piya, and all panelists to the podium, please. Dr. Pimpak, Ajahn Jun, Dr. J. Jun Choi, Garrett Morgan, and Dr. Hideshi Tomita. Please come to the stage. Thank you.
Afternoon. Hello. Good afternoon again. So our next session will be on PPVI, and we're gonna have the live case. Let me introduce my co-moderator, Dr. Piya. He's our CBT surgeon from Ramatipadi. We also have Dr. Jun from Chulalongkorn Memorial Hospital. He's also our surgeon. Dr. Pimpak from Children's Hospital, and Dr. Tomita from Japan. I think we are still missing Gareth. That's all right, I guess. Okay. Is the cath lab ready?
Walk through life. Every day is a new beginning. Shine your light. It's a day and the world is waiting. Move along to the song, singing in your soul. Feel
Okay,
the beat, clap
in the
your hands,
meantime,
take
I would like to
control. All you need,
introduce
all you
Dr. Kanjalak Vithesonti from Pediatric Cardiac Surgery Foundation, Thailand, to present her presentation. And so, Dr. Kanjalak, please.
Good afternoon, everyone. So first of all, I would like to thank PSU to give me the opportunity to present, to share the case. Sorry. Okay, thank you for letting me share the case. And I'm not an interventionist, I'm just a pediatric cardiologist and taking care of the patient from newborn to adult. So I have no disclosure. So let me start with the case. This is a patient with a 16-year-old man with a tetralogy of Fallot, and he got the right modified toxic shunt at the age of 2 years old. And 1 year later, he got a total repair with a VSD closure, annular patch, and a monocast pulmonic valve. And at that time, the patient was followed up by the surgeon and no echo record after surgery. And this is a chest X-ray pre-operation and post-operation. the age of 5-year-old 2 years later after surgery. He's become edema and functional class change, and echo document at that time and cardiac cath record rates. He has severe tricuspid valve regurgitation with dilated tricuspid valve annulus and the severe pulmonary regurgitation with the LPA stenosis, and still have a residual PTA and reduce the LV ejection fraction. His chest X-ray at that time was a big heart, and he put on the surgical reoperation list, but I don't know why, but the reoperation will be 2 years later at his age of 7 years old. And at that time, he's 18 kilograms. And the second median sternotomy was done with fixed everything, the residual PTA, LPA enlargement, TV repair, and put the prosthetic, bioprosthetic valve with 25 millimeters. And then this is a chest X-ray after surgery. The second open heart. And after discharge, the heart still big but reduced size. And when we follow up for 1 year, still have like cardiomegaly. And then he lost follow-up. The last echo show he has like MITR, trivial pulmonary valve regurgitation, and fair RV function, and left ventricular ejection fraction is 49%. He lost follow-up for 9 years, and he showed at the OPD 9 years later when he was 16 years old, and this time he's like have a functional class change. The functional class is 3 to 4, and he has generalized edema and sign of congestive heart failure. And he brought the CMR report from one of the hospital in just only the report, and showed that the alveolar dilatation and severe pulmonary regurgitation and very, very big heart and very poor ejection fraction, and also have a myocardial scar. And the hospital just let him to follow up at the previous surgery hospital and come to OPD. At that time, he have sign of congestive heart failure, and blood pressure is low normal with a sinus tachycardia, and saturation is full, and RV heaving, and sign of congestive heart failure. And this is his chest X-ray this time. And the QRS duration is 210 milliseconds. His echo show he has a severe tricuspid valve regurgitation with dilated IVC, and severe pulmonary regurgitation with the pulmonary valve annular measurement at the time is 15 millimeters, and just small LPA, and no residual VSD, and the ejection fraction from measurement is 27%, but from the echo, I think it looks less, and TAPSI is 18. So I just would like to ask the panelists, what is your plan in the patient like this? I need a comment from surgeon and interventionist, and also the adult cardiologist.
Thank you very much, Dr. Kanyalak. And who would like to discuss first on the surgeon side? Dr. Chun? Okay. Yeah. Okay. What is your opinion? What is your plan for the treatment or intervention for this patient?
Please let me see the cardiac function again. So the latest, he has severe tricuspid regurgitation with pretty high pulmonary pressure, around 60 and 3 PR and PS. The pulmonary valve annulus is 15, are you sure? Because you said
That's from the echo measurement, but the valve is 25.
right. Okay. And also poor LVE ejection fraction. So, in summary, this patient has a poor cardiac function. I mean, both right and left ventricle, and severe tricuspid regurgitation. So in the surgery option, we have to do both pulmonary valve replacement and also the tricuspid valve repair, or even the tricuspid valve replacement. So it depends that you can how good you can repair it. And but the problem is the heart function, the ejection fraction is pretty poor. So in this situation, I think probably if you do you have any reason that the LV and RV function is so poor? Is there any reason, like last time, the last operation, you have some problem?
He got the problem of the ventricular function after first surgery, and he have like heart failure, and after the second surgery, he have like borderline LV function. But it's improved after second operation, and now it's like turned down.
Okay. And the heart is dilated or not?
Dilated.
So, is that any component of the DCM in this patient? Do you have any like biopsy or something?
No.
No. All right. So the plan, if you want to do the surgery, you may need to do another investigation.
The question is, the surgeons want to redo surgery for this patient or not? That's the question for you.
I think if you have more information, more investigation, probably we can try to do the surgery with some backup, like ECMO, and probably transplant later if the heart is not recovered.
Okay. From the translator standpoint, maybe I'll ask Garrett for his opinion. So I think for the PVR due to bioprosthesis failure, we can do valve-in-valve quite easily. I think the issue of this case would be the tricuspid regurgitation in the setting of poor RV. What do you think, or what would be your approach in terms of severe TR and biventricular failure? I mean, we can fix the PR with valve-in-valve quite easily, relatively easy, I think. What do you think?
I agree that I think the problem here is now that he's progressed to having severe biventricular failure, whether there's any benefit in trying to work with the valves. I mean, there's several things. His LV may well get worse after you implant the pulmonary valve, maybe, which might put him into an acutely unwell state. And also, my impression is that he's probably gone too far, and fixing the valves may not be of any benefit to him, may actually be dangerous. I think, again, easy to say in a US setting. In Colorado, I think he'd be referred for transplant assessment and would likely go towards transplant without any intervention. But you could make an argument to go and try. I don't know whether this level of TR would be improved significantly by replacing the pulmonary valve. I know that we can get the grade of TR improved, but this tricuspid valve looks like in really bad shape, and I'm not sure whether or not there's going to be much benefit. So I think I would refer him for transplant assessment, and if that was delayed or poo-pooed, then I would consider replacing the pulmonary valve and hope that his left ventricle didn't get worse afterwards, and see whether that improved the TR and you could get him moving forward. But I think his medium-term outcome is going to be a transplant.
One more thing. This case, I think it is complicated by the LPA stenosis. And what would you prefer to do, your approach?
Yeah, I'm not sure in the setting of single pulmonary artery stenosis. I'm not sure whether that's having a major impact on his ventricular status. I think it may be almost cosmetic to do anything to the left pulmonary artery at this point. And the other thing I would be worried about would be complicating his transplant by giving more difficulty to the surgeon who has to go in and take his heart out.
Dr. Chun, what would you approach to
for the LPA stenosis? Probably I just asked my cardiologist to dilate it before. Yeah, balloon or either balloon or balloon with stent.
Yeah, but then you'd have to be aware that it may not help things, and then when you go to do a transplant, you're going to have an LPA stent, which you may not want if you're going to go and do a transplant.
But normally the anastomosis of the transplantation will be at the MPA and not at the LPA.
Okay, before we go to the floor, Dr. Tomita, what would you do in Japan?
Because of severe limitation of the availability of transplant, rarely we go intervention or surgery before sent to a heart transplantation program. And I'm not sure how bad the LPA stenosis is, but if the problem is a severe PL, and I'm gonna do a valve in valve, and then consult other structure guy, how can they do a trick rip combined with PVL?
Dr. Liang?
You know, look at the ECG, you can see that the QRS complexes is like more than 200 milliseconds. I was wondering whether there's a role of resynchronization therapy just to get the ejection fraction a bit better before intervene further.
Good point as well. It's the right bundle, but very broad, so that might be benefit from CRT.
Yeah, can I just ask about that though? Because do you think in the setting of major structural abnormalities, whether you would wait until you fixed what you can before doing resynchronization, or would you do resynchronization now?
No, you look at the function, it's very, very poor. Just a slight mistake, the patient will collapse. And once the patient collapses, it's very difficult to salvage the patient. So I was wondering whether I can beef up the ejection fraction a little bit before we replace the valve. What do you think?
Yeah, I have the same feeling as Leong. But additionally, I would go to assess whether there's any significant occult arrhythmias, because in these kind of patients with torrential TL, huge LAs, there might be intermittent IARTs and stuff. So it reminds me of a patient that I've recently treated, but she is 74. It looks exactly the same. So we use guideline-directed medical therapy for the LV dysfunction, treat the arrhythmias, LV function improves, and the LV still looks terrible, torrential TL, and we put in a valve, but that's a native PL. We put in a valve, and the TL actually improved. But we have a backup plan with, after putting in the pulmonary valve, we wait for 3 months. If TL doesn't improve, then we go for tricuspid edge-to-edge repair. I think that's from a relatively resource-limited area. We don't really have a lot of heart transplant, donors available for heart transplant.
Yeah, that's a great point. Any other? Oh, Dr. Pimpak. Sorry.
What is your opinion?
What's your thought?
Your approach?
So I will approach quite similar to we'll go for valve in valve first and then wait and see that the degree of the TIs get decreased or not, and look at the function. But the thing is the LV function will not get improved after we have done all this anyway. So we'll make him to the list for transplant in the future.
You put in the device, CRT, upfront, on top of optimal medical therapy, or?
I don't have much explain about that, but I will fix the structure first and then see.
I wonder whether or not CRT AICD would be actually good for this patient after you put the tricuspid valve in, because he's at serious risk with all the things we've talked about of falling over with a ventricular arrhythmia. So I wonder whether CRT with an implantable defibrillator would be good. But I think in essence what we're doing is rearranging the deck chairs on the decks of the Titanic here. I think all the structural interventions, I don't think his left ventricle is going to improve and he's going to end up with chronic heart failure on a transplant list. But maybe delaying that for a few years is a good idea.
The predictor, if TR going to improve is very difficult. I mean, for this one, it's a functional TR. From our little experience is that if the atrium is very large, like TR from, atrial dilatation, it's quite difficult to improve, even though it's a functional TR. But if it's a ventricular side that is dilated, sometimes TR can be improved afterwards. And I think we are kind of start to explore the use of TriClip in this adult congenital cases, and I think it's probably doable. But at the same time, once you clip it, you cannot recross it, and you need to fix the pulmonic first and all that. But anyway,
Okay.
Any other
So
discussion?
I asked for help from Ajahn Man, Ajahn Bimpak, and Ajahn Worakan. So we decided to do the pulmonary valve to fix the pulmonary valve first. And we concerned about if we do something with a tricuspid valve rigor, the function of the right ventricle will be worse. And we also concerned about the left ventricular function. So we have consulted the surgeon for the ECMO backup and also IABP from the cardiologist. And so we admit the patient in ICU and treat with the heart failure medication and plan for the pulmonary valve involved and standby IABP. And at the time, the vital sign is like borderline, and our institute limited with the heart transplantation, so we just go on with the valve involved, and I'm not in detail with the valve, but I think it's a man put the Edward Sapien 3 26 millimeter in this patient, and after the procedure. Look at the chest X-ray, the heart still big, and in the follow-up, the chest X-ray is still big. But his clinical is very improved a lot, and the echo after the procedure is look a little bit better in the left ventricular function and the right ventricular function, but it's still terrible. so maybe need something for this patient, not just like let him go. And I think the tricuspid valve regurgitation is like a little bit less, but it's still a lot. So we still continue the medication for him, and he on IABP about 3 days with a stable hemodynamic. And finally, we can discharge patient from the hospital. And actually, we still discuss about tricuspid valve replacement and the device therapy. But for the device therapy, we're not sure it improved the left ventricular function. So we just like consider, and it's quite difficult to get the heart transplantation for this patient. But he's lived for about 1.5 years after the procedure. And actually, we plan to do something like transcatheter tricuspid valve for him. But he unfortunately have a I called to the family because he lost follow-up, and they said like he have a fever after COVID vaccination for 10 days and have like high fever and sudden death in that case, in that night. So I'm not sure it's because he have a low cardiac function or we have a complication from the vaccine. So, but just like have some not good result. But this is a example of the patient that not good the result, because every step when you're taking care of the patient with the tetris of follow, you have to make a decision for them whether the palliative intervention or total repair that you discussed a lot yesterday. So I just summarize in this PowerPoint, like if you want to put the patient on the palliative intervention, the patient still deal with the cyanosis and can get the complication from the cyanosis that you have to consider. But if you put the patient to repair too early, like in neonate, they need mostly they need the hypothermia and circulatory arrest. They also have a neurocognitive complication. But the optimal time for the surgery, the total repair in infant and early childhood is depend on I think it depends on the short-term outcome in that institute, and also it depends on the anatomy of the patient, but have to balance between the risk and benefit and optimal time. And if they survive to adolescent and the adults, they have to deal with the hemodynamic sequelae, with a residual lesion, valve dysfunction, or ventricular dysfunction, and have to consider that the patient will have re intervention again with maybe cardiac care or surgical. And finally, if the patient have like ventricular dysfunction and have to do a transplant, so you have also to prepare the patient, because if they have surgical intervention, they also have a higher risk for the transplantation. So for the pathology of follow, you cannot like make a decision just only that time. You have to think for the future also. So the main point, I think you already discussed in this patient, is like tricuspid valve management in pathology of follow and heart failure in pathology of follow. Just like summarize a little bit. So there's have a systemic review about the tricuspid valve intervention at the time of pulmonary valve replacement in about 700 patients with tricuspid valve intervention at the time of pulmonary valve replacement and only pulmonary valve replacement. It proved that the tricuspid valve grade is decreased in the tricuspid valve intervention and pulmonary valve replacement group, and decreased the tricuspid valve annulus. But there's no evidence of the difference between the mortality, readmission, or the RV function or IV dilatation. That means if pre-operation the patient have a severe TR, they might get benefit from the grading of tricuspid valve or the functional class, but for the mortality or the outcome maybe is not different. So it cannot like the tricuspid valve intervention maybe have to debate. And heart failure in the repair pathology of follow, about 14% of class 2 have the class 2 function, and the risk heart failure is more than the simple lesion, and sudden death is about 0.3% per year. So many causes can make the heart failure in this in pathology of follow, and this patient is one of the example. So you have to look to preserve the myocardium first, because if you not decision for the optimal time, it can affect the myocardium, and if you do too late for total repair or long-standing shunt, it also have the effect from the diastolic dysfunction and myocardium. And also the multiple surgery can affect the myocardium. And the sequelae from the surgical repair, like chronic volume and pressure load and residual lesion, and also affect the cardiac conduction abnormality. And when you have RV dysfunction, it's also interaction with the LV dysfunction and the coronary abnormalities. So if the patient have one or more factors, they can have like long-standing preclinical symptoms. They can like no symptoms for a long time until they have like decompensation. So when they have like right heart dilatation or dysfunction, they become increase the end-diastolic volume and increase the mass first to keep a normal stroke volume. But if they RV failure or they not compensate, they will increase the end-systolic volume and decrease ejection fraction and present with the overt heart failure. So for the pulmonary valve regurgitation effect, pulmonary valve replacement effect on the ventricular function. If the patient has decreased LV function, the LV will be improved after pulmonary valve replacement also, but the RV function will be not changed. So for the management in the repair territory of fellow with heart failure, we can manage by medication, device therapy, and surgery depends on the patient. So the etiology of fellow is not the curative congenital heart disease, it's like only reparative, repair, and needs long-term follow-up. Thank you.
Thank you
Okay,
very
thank
much, Dr. Kanyarak, for your extensive review and conclusion in terms of the from A to Z for the etiology of follow repair. Thank you very much. So we would like to move on to the next topic from Dr. Supalak Kanchana Uthai from Sirirat Hospital. She will present on the when do the patients need AICD rather than the PPVI. Dr. Supalak, please.
Good afternoon, everyone. This is Supalak, and I was assigned to speak on when do patients need AICD, not PPVI. I have no disclosure. Outline really quick. Free outline today includes what is SCD risk in tetralogy of low patients and who should get primary prevention of AICD implantation to trials for low patients. And can surgical PVR or PPVI help eliminating need of AICD or reduce SCD risk? Let's go through sudden death risk in tetralogy below patients. Previous published data by Dr. Curie and Canadian group show composite factors, including these factors, and the last two was a very strong factors related to appropriate shock, AICD shock in these patients. So including shunts, inducible VT, QRS duration greater than 180, ventriculotomy incision, and the last two I mentioned is non-sustained VT and the Holter monitor, and LVDP greater than 12. Systematic review from 2020 kind of reiterate those factors again, that they show risk factor including ventriculotomy again and low LVEF, and also include higher RV-EDV in this as a risk factor. However, in 2022, Britain group published data that made drawback as a prediction of the high risk and death in tetralogy below patient. They use CMR to derive LGE to predict high risk and death in these patients, along with these parameters. However, from this study, the previous parameters, including QRS duration, shunt, and ventriculotomy scar, became not significant. So after all, we felt that the data were retrospective and show some inconsistency. So how are we going to put all these factors together and say that which patient are at risk? I came across this HA statement that published in November 2022 that show, they put together all the risk factor, but they put some consideration into each risk factor. For example, if you have PVR at really old age, you definitely have really dilated and sick RV. And in this statement talking about QRS duration, it should not be used as isolated factor, as most recent data show that QRS duration less than 180 used to at risk of sudden death in these patients. But more, what I highlight in double stars here, that the fragmented QRS and ventricular dysfunction, including the CMR-derived LGE, are really interesting parameters these days, talking about, if these factor there, it definitely will predict high risk of sudden death in tetralogy below patient. The last one is EP study. It's more invasive, but it can be used when you have a lot of multi-factors that you worry that may pose that patient in the risk. So you will go through the more invasive procedure with EP study or cardiac cath. However, when you do a study, when the patient having really vulnerable stage, for example, they are really having really regurgitant of the pulmonic valve or TR, really dilated or heart failure, EP study may find not useful. Let's do some exercise. We have 16-year-old girl who underwent PVR. During childhood, she had total repair with transannular patch. 1 year later after PVR, she collapsed and was told that she was having CPR by bystanders. No reported on the rhythm on AED. It lasts for 10 minutes and she went into RSC. Underwent all the evaluation that's supposed to have echo, Holter's, ECG, stress test, cardiac cath, and EP study as well, because she posed a multi-risk factor. Her QRS duration was not that wide. She did not have fractionated QRS. Her Holter monitors show concerning of the ventricular ectopy and also multi-form of the ventricular ectopies. Definitely an EP study show concerning data that there's a very easily inducible non-sustained polymorphic VT with programmed ventricular stimulation and also unstable non-sustained monomorphic VT. So should she get AICD? This really easy to say yes, because she had post-cardiac event, unexplained syncope, and she also had multiple risk factors. She finally got AICD, was on a beta blocker still, and no episode for 7 years during follow-up period. So who should really get AICD as a primary prevention? Always consider a primary prevention. AICD will help prevent sudden death, but it comes with the price. There's risk there. Inappropriate shock reported up to 25%, and CIAD-related problems, including infection, lead malfunction, bleeding as high as more than 10%. So the guideline talking about you can put AICD as to an indication when kind of arbitrary, use your own judgment. If you have tetralogy fellow patient with multiple risk factor out here, so the previous published parameters and also including CMR derived scar from the derived scar as well. ESC guideline, pretty much the same as AHA guideline. From PACE's expert consensus from 2021, did not specifically say on the tetralogy flow patient, but did mention on putting AICD in overall in congenital heart disease patient if they are a survivor of cardiac arrest or they have EF less than 35% with history of sustained syncope or sustained VT or syncope. So come to the last question. Can surgical PVR reduce risk of sudden death in this tetralogy below patient? The answer is most previous study did not convince that PVR would decrease ventricular arrhythmia in tetralogy below patients. PVR may stabilize the QRS duration. Some study may suggest that doing intra-op cryoablation may reduce the VT post-PVR. However, very large study, almost 1,000 patients, and less than half of them had underwent PVR, showed that PVR did not associate with reduced rate of death or VT in this tetralogy fellow patient over a period of 5 years follow-up. Most recent data from French National Registry in the patient with tetralogy fellow that already had implantable ICD placement. They found that in their cohort, there's 26 patients that underwent PVR after they already had AICD. After they follow up about 4 years, they found significant decrease in burden of the shock from the ventricular arrhythmia after PVR. And also they found that a QRS fragmentation, not QRS duration, was the only independent predictor in multivariable analysis. And definitely in the group that had PVR before AICD, it's actually helped reduce overall ICD shock event. However, in this study, did not report inappropriate shock rate. But the fact is, if you are having RV really overloading, you're going to have progressive myocardial remodeling and fibrosis. That's going to increase the risk of SCD. So what about ventricular arrhythmia after you put percutaneous valve replacement? It's going to need long-term follow-up from now. I put up 2 studies in pediatric and congenital heart disease. 3 out of 21 patients, which is account for 14%, had ventricular arrhythmia after PPVR, all with underwent Melody valve. In this study showed that with this particular valve, the VT can occur really common in the first 24 hours after implantation. So comes to summary, when do patients need AICD, not PPVI? I think it's totally different story because AICD cannot solve hemodynamics issues, especially if you have severe PR, severe TR. SCD risk in tetralogy below patient undergoing PVR need to be addressed in parallel and very meticulously for us as electrophysiologists to select high-risk tetralogy below patient for primary AICD prevention, as we know there's a drawback for the adverse effect of the AICD. And AICD programming may help reduce inappropriate shock in this patient. I believe prompt and careful selection of PVR or PPVI can help modifying myocardial remodeling substrate for this tetralogy below patient. At last, I want to remind you again that these adult congenital heart disease patients going through suffering circle of life already. So it's our job to take care of mental health and quality of life issues and also let them help you to make decisions for their best interest or their best choice. And with this, I want to say thank you.
Thank you very much, Dr. Supalak. You're online with us? Yeah? Can you hear me?
Hello. Hi.
Okay. Good. Any questions from the panelists about...
I do. I mean, that was a great talk. Thank you so much. And I think your last slide, I almost think should have been your first slide, because I think some of the psychological issues around ICD are often underplayed, and I accuse our electrophysiologists of being a little bit callous sometimes from the point of view of their decision-making process. But I wonder how much that does play into your everyday practice from the point of view of the sort of the psychological impact of waiting for and getting an ICD, and how you bring that into your decision-making process.
Sure. Really great questions. I know we utilize the same guideline and we learn the same guideline, but personally, I use the fact and talk through risks and benefit of doing these invasive procedure with the patient. So after all, I am the person that not super pro on primary prevention in the tetralogy below myself, because I had experienced that I put AICD in one of tetralogy below patient and they ended up with severe TR afterward, and that made their right heart failure worse. So that kind of answered the question of Dr. Ganyalak patient, the last patient as well. We talk about AICD as a primary prevention, and we have to not to forget about tricuspid valve as well. And so that's something that plays into my consideration. So I tend to do it if I know that my information is really good. For example, that the patient that I put AICD that I showed, she did really well until now, because I know she's a good candidate to put AICD because of the inducible ventricular arrhythmia and EP study. So there's a lot of factors that, you know, put together and make decision, and also sit down and talk to the patient. A lot of teenager patients refuse to put implantation, and they know that they will accept the risk to die. Yeah, I know you have the same experience. Yeah.
Yeah, appreciate that commentary. I think that's really good to hear. And I think your thoughtfulness about the tricuspid valve, specifically in tetralogy of Fallot, being different in a patient who is a left ventricular primary prevention patient, I think is sometimes overlooked by EP teams. So it's really nice to hear you saying that. Thank you.
Another way of thinking, though, sudden death is a hard outcome. You cannot take back, okay? But I think if your outcome is heart failure admission, you can have a second chance. So I think selecting the right patient is very important because the impact of the end result means something, right? Because like our last case, we talk about if it's an arrhythmia, if you put an AICD in, maybe the patient is not going to die. So readmission, you have second, third, fourth chance. Sudden death, you're gone though. Okay, anyway, I think that's for a discussion, and that's why we need a
Can
heart
I
team.
give a comment on the last patient really quick on Dr.
Yeah,
Kanyalak patient?
sure.
So I think we have to be really careful in the last patient as well to put AICD at, we should discuss about the mode of death and on that patient, whether is that a PEA or ventricular arrhythmia. I think the recommendation kind of say we need to really discuss as a group and then consider really hard. So I guess putting ICD in that patient with severe TR, it's going to be something really have to consider really hard.
Yeah, that's good. So definitely not an easy decision. Let's go to the cath lab and see what Supa and the team is doing.
Sorry, maybe just quick question to Ajahn A before we go to the cath lab. Can you hear me?
Yeah,
yes.
We see you too.
Ajahn A, it's not about AICD, but it's about because we put some kind of self-expandable valve in that area, especially at a pulmonary position, and somehow that may involving the RVOT, especially something like venous P here, or the harmony valve, in the US, in European country in the future, or the Altera, something like that, or even Pulsar. So, in your opinion, is that safe enough for the patient? Do you need something to interrogate before we put the valve in? Something like, do you need like a routine EP study or anything that you recommend for us before we put the valve in? Please, would love to hear from you.
Yeah, so maybe I'm a little bit conservative. So I have to say the most common arrhythmia in tetralogy is not VT. It's more atrial arrhythmia. And in my personal experience, I only see ventricular tachycardia in double outlet right ventricle. So you are talking about reentrant type of VT that go around the patches. So those patients you're going to see in patients that did not undergo transannular patch patient. So it's mean valve sparing type of patient that you're going to see reentrant type of VT that need a line, creating a line from the valve to the patch before undergoing the percutaneous valve. So I would say I would go by clinical. I'm not sure that doing EP study will predict the clinical of the VT on that patient, that patient gonna have clinical VT in the future. So I'm not sure that I will be doing EP study in all the patients that going through the valve procedure. And especially if they underwent transannular patch, I think that's gonna take care pretty much of this type of VT because you have the scar line from the pulmonic valve down to the ventricle anyhow. Yeah. So I would say maybe not. Yeah.
Yeah, it's great. Okay. Okay, so we will go to the lab. Supa, are you ready? Can you hear us? We see you now.
Me? Yeah. I'm here with Ajahn Kirvikrom and Dr. Pontip, yeah, from Sirirat Hospital, and also Dan Levy.
And Dan was here.
Yeah.
Come on here.
Hello, Dan.
Yeah, the camera. Yes.
They use that one.
Okay. Yes, we have the interesting case. Yeah, we will let our fellow introduce you the case. Yes.
Thank you. The case of 13-year-old male, 74 kilogram and the height 167 centimeters. His known case repaired pathology of Fallot with moderate pulmonary regurgitation. He was total repair for 10 years ago. Underlying disease is D6PD deficiency. Today he is functional class 1 and asymptomatic.
I've got microphone, yeah. I'm on.
No current medication. The vital sign is normal, and the cardiovascular examination show RV heat and to and fro murmur grade 3 at left upper parasternal border. The chest X-ray show cardiomegaly. The MRI data show indicated for pulmonary valve implantation. The ECG show complete right bundle branch block with QS duration 158 milliseconds. The right femoral vein venogram show patent right femoral vein. In the MPA angiogram at IO cranial view show tubular shape RVOT with the aneurysmal at RVOT. The maximal diameter at the aneurysm is 42.4 millimeter. And the PA bifurcation level about 22 millimeter, and the length of
เลื่อนให้ใกล้เข้า
RVOT
มาหน่อย
24.5 millimeter. This is LAO cranial view, show no PA branch obstruction. And in lateral view, the waist is about 21 millimeters. The ASD balloon sizing 34 millimeter was used to do the balloon sizing of RVOT. Show the waist at the middle of the balloon. Measurement was 27.5 millimeter. Simultaneously, volume interrogation with selective coronary angiogram at LCA show good coronary flow without obstruction. So today we plan for pulmonary valve implantation.
You're looking for?
Okay, yes. For the first that I do the case, I think that we're gonna put the valve below the aneurysmal, but after discuss with Ajahn Kritikom, and also then we think better to put the valve above the aneurysm to avoid for the arrhythmia risk, maybe better. So, and we need to do the balloon sizing again. So today, first we do the MPA angiogram in the RAO cranial and also the lateral view, as you see here. And what we saw is the site is, yes, in the lateral and also.
Supa, can you make the angiogram big? We the live one big.
Okay.
Okay, great.
Okay.
Yes, this is the measurement for today. The valve analyzed, the waist size is around 20 millimeters. Oh, sorry, 18 millimeter, and 1 centimeter is around 20.
Okay, can we see the lateral view?
Yes. And this is the lateral view. The analyze also the same diameter is about 18 millimeter. Yes.
Probably less, yeah.
Yeah. So what do you think? Yeah, and also we a little bit worried about the coronary as well. Yeah.
But I think there are a couple points before we scrub in Dan and Fook and I, and also Dr. Supaporn look at the CT scan. Maybe we can move CTs a little bit. It's Fook around.
Yes, I am here.
So there are 3 millimeter gap between the left LAD. If you move it around a little bit, yep. See that there's a gap between the coronary. So we are this is one point that we are a little bit concerned. Now the intention is to plan doing the balloon expandable valve. So that means the compression is highly important when compared to the self expandable valve.
So that's first point. That's we are aware of that we have to be really testing this thing. Now, the second thing is that if you saw the first PowerPoint presentation, the measurements is actually below the native harmonic valve position actually. See that? So that means we don't think that's a good place to get into the valve. There's an aneurysm, and we might cut into some muscular part also that may create a substrate for arrhythmia in the future. So we are intended to do that at the pulmonic valve. The problem is that we find out that the pulmonic valve looks smaller than what we would have thought. I would say that something like 18 millimeter or so or less. I don't know, Dan or Fook, do you want to comment anything? So the smallest valve is 20 millimeter, but we normally did not put 20 millimeter in the native outflow valve. So it's either like to prefer 26 or 29, but this patient have only 18 millimeters. So balloon interrogation now is becoming very important.
So maybe we start with Fook first. Please, yeah.
Yes, thank you. Yeah, thanks for the summary. I think yeah, I'm here. Yeah.
So we start first while we are.
Can you hear Fook?
Yeah, we
can you
hear
hear me?
Fook. Yeah.
Maybe your microphone is muted.
Yeah.
Okay. So we wait until Fook look at the. So I think the interactive between operator and imaging specialist is highly important that we work together and try to discuss as much as detail as possible.
Yes. Thank you for the introduction. And I might just start with in the cath lab and also in general, we tend to use a combination between 2D and 3D images. 3D is good for a good overview. First of all, as to highlight the point that Dr. Crit has made earlier about choosing the wrong landing zone with the balloon sizing. So the actual landing zone was much higher than that. And in many of these pathologies, we must understand what is the native tissue and what is not. So this area, the aneurysmal area, was something that was patched before and become changing over time. However, all this tissue around here is native and so on, just upwards. And this CT is done in diastole. So in systole, areas like the pulmonary valve annulus unlikely to change very much because we know this is probably a valve preservation technique. You can see that the tissue is quite thick and the valve leaflet is really thick and it provides potentially an area of constriction. But however, we did some measurement here and it's only about 7 millimeters, so it might be a little bit short for that. And in systole, this area here, I'm expecting it to be bulging out further. And in fact, on some of the angiogram later, you will see that it highlights that point of the importance between systolic and diastolic difference in the measurements. And here, as you see that this area, as we said before, that the diameter is a little bit small. And given this tissue around here could be potentially pretty stiff. So that brings us to the next point that the limitation of non-invasive imaging is that we can't predict how much of this will be stressed out, and hence the thorough balloon testing will be needed. Just last but not least is the made a point about coronary artery course, and let me just go through this here. In phallopharyngology, because of the clockwise rotation of the ostium, so normally I'm just looking from the back here. So the normal ostium of the left coronary artery, something is here, but in phallopharyngology, it swings up to here. So you always have this little bit of slit-like angle because the coronary had to travel much further. So, you know, to assess the compression or distortion of the left coronary artery or the LAD branch is quite significant. It's not necessarily need to compress, but it can distort this and make this become a bit like potentially reduction. In this case, the coronary artery, when this also, as you can see here, we're looking at focus on a long axis of the MPA as coronary artery crossing over, is running more or less in oblique, more or less parallel with the landing zone. So the clearance has to be something from here all the way up to there. So one needs to pay more attention to that. And we measured about 3 millimeters, but this is again in diastole. When oversizing, all of these fibrous tissue around here potentially can stretch. As you can see there, I've just window this a little bit and it changes and it shows with potential the area of the soft tissue around here, which can be stretched out further. Yeah. Oh, I've got any.
So thanks, Puk. So that's very informative. You still gonna do balloon testing? Is gonna show us about balloon testing, right?
Yes, yes.
So
maybe I'll ask Dr. Grit or Dr. Dan. From what we see from a
Yeah.
CT, is it worth to do a balloon testing at all, or would you still do it regardless?
I was in favor of doing it, and I would do it if we could do it all over again. And as you can see, once we did the balloon testing, we're going to have some options here to show you.
So we started normally.
นี่บอลลูน
cement แล้วใช่ไหม
อันนี้น่าจะ
This is cement.
อันนี้ไม่ใช่
It
ค่ะ
also depends on what valves you have at your
PTSX.
disposal.
So we started with a low semi-compliance balloon. It's a PSUX, which go up to around 1 atmosphere. Normally, it's a 30 millimeter size. It's a maximum for the 29 Edwards valve. That means that if we see waste in the 30 millimeter balloon, so we had a good landing zone. But in this case, actually, it's on the other way around because it's too small. So when we started to use the semi-compliance, it actually did not push out much. It's only 18.2 millimeter in the AP and maybe 17.9 in the lateral. So that means that the landing zone was not really, it's too small.
Why don't you
to put a valve.
show that balloon?
Just inflate it, right? Just play, right?
Yeah.
So next step is that with this semi-compliance balloon, the strategy for this one, the landing zone is too small. So we are thinking about putting a better compliance balloon.
That's not the PTSX.
So this is
That's a ZMAD.
Yeah. This
so we
look like
started
a
with a 25 millimeter cement.
Do you want me to do it from the outside or
Yeah.
you can
Yeah.
outside?
Okay.
We started with 22 and 25 cement.
Let's
And
start with this then.
now my dilemma is that how far did you want to go for the sizings? Because we are afraid a little bit that we might actually tear the native pulmonary valve. So we start with 22 and 25. And I think this is a 22.
This is 22.
This is 22.
This is
Yeah.
first image.
Mhm.
Then
we go
sorry,
to
that there's a
25.
lot of
Can we go to
this
the-
one. Okay. This is the PTSX balloon.
That's a PTSX, right?
Yeah, and I don't think this was even unreasonable. So you see the waist on the PTSX is really tight. And my algorithm is if you use the PTSX and you get a waist of less than 23 or so, then you go to sizing with less compliant balloons like a bib or a ZMed. The PTSX balloon is really good at the big outflow tracts to see if you can put in a 29 usually, or sometimes a 26. But when you get tighter like this, your goal is more to see how much you can stretch it. So we went to ZMed balloons.
So
Then we go to the cement one.
Okay.
And what's
So
the
here's
waste you get
measurements.
from the PTSX? What's the?
It was really, really tight, man.
Very
It
tight.
was about
15, yeah. So,
You see that, right? About
okay,
16
Oh,
maximum.
very small. Okay.
6.
Small valve.
Yes.
Yeah, that was surprising to us
Yeah. Okay.
in a bad way.
But Dan, like you said, all you're really doing there is interrogating the outflow tract. You're not really stretching anything with that balloon. You're almost making a cast of the inside of the outflow tract rather than stretching anything. There's no pressure on that annulus with the PTS balloon at all.
Yeah, so that's the point. This is sort of a different type of RVOT sizing. So now we went more aggressive.
So do you want me to go to the cement first?
Yeah,
Then?
why don't we go to the cement? So our strategy next is to try to stretch that landing zone and see that how high that we can going without
What size is
doing
this,
anything.
Ajahn?
So we started with the 22 cement and up to around 2 atmosphere
So
and still not really moving that much, maybe 17 or 18.
Can I be rude enough to ask, did you measure the length of the balloon to make sure calibration was okay? And sorry, that might sound a little bit rude, but just to make sure that you're not underestimating it by using auto calibration, did you measure along the length of the balloon to make sure it was okay from a calibration point of view?
Gareth, thanks so much for that question from the rude American. But yeah, these guys are super diligent here, and they were measuring also. To see that how they measured their pigtail, they were measuring all sorts of things to make sure it was accurate.
That's a good
Okay, thanks,
point,
Dan.
Garrett. Well, anyway, we stop because it's still 18, so this is a 25.
25, yeah.
And we do it with 25 and slowly increasing and up to around 4 atmosphere, almost like a bursting atmosphere now. And this is it, right?
Yes.
We're still seeing that waste, and it's still no more than 20 millimeter. So our dilemma, what to do? How do we create this better landing zone? So we had two choices: either put 23, which might fit in there, but since above and below it's much larger than 23, so we run a lot of risk of embolize the valve, or pre-stent it and then put the valve in. So I have two options for the panel. Or maybe put some other valve.
Okay, maybe we'll start with Garrett.
And Dan knows what I would do here. And so the problem is this is a little bit dependent on your individual practice. So this is easy for me to say, but we would go ahead and just put a 23 directly in here because we almost never pre-stent anything. And I think you've got a nice stable waist. That balloon's not moving at all. It's predictable. You know where it's going to go. An Edwards balloon in a 23 will get you to between 5 and 6 atmospheres. So you'll bring it up to close to 23 millimeters. And I think that pre-stents, in my experience, again, maybe because of lack of technical skill, just get in the way and cause problems, particularly when you've got so much room above and below. The pre-stent's going to be, it's going to get in the way of all your delivery systems. So I would just go directly with the 23 Sapien onto that waist.
Any thoughts from the panelists? 23 Edwards would be Magna 25 if you're going to put a bioprocesses. Set aside if you don't think there's going to be coronary obstruction, which I haven't seen, we check it. That might be an option, 23, but it's somewhat smaller than we tends to put it in the pulmonic position, right? But
yeah, I agree. I think so my policy is not to put a 20 millimeter Sapien in because I haven't, and again, there's no science here, but I haven't found the hemodynamics of a 20 millimeter Sapien very good in the pulmonary position. I think with a 23, you can go back in 5 or 10 years' time and napkin ring the stent and get another 23 in, etc. So I think you're not disabling the patient much by using a 23. A 20 I would not go for. I think if you hadn't got this result with a balloon, then I probably would say either go for a Melody or an operation.
Garrett, I forgot to give you one important information. The gradient across this small valve is around 20. If you were to have this information, you still think that it's a good idea to get 23 in?
Yeah, I think you've probably got rid of it though with what you've done, unless if you can do a very careful interrogation with a multi-track catheter or something over the wire, unless the narrowing is at that muscular os, which is further down. So I think it's maybe important to make sure that you don't have obstruction at the other annulus or the other little ring further down towards the muscle, because then you'll end up not improving things. But I doubt that's the case looking at your CT scan, but that's probably important to check.
And we also have the surgeon on the panelist.
We'd love to hear opinion from surgeons too.
Yeah.
What do you think?
If we put the
Actually, we're gonna call them into the room an hour ago already.
Because 23 is a high risk for emboli as well. So
that's our concern, that it might be embolized because above and below it's much higher. Dr. Priya and Dr. Chun, can you please tell us what do you think?
Okay, Dr. Chun, what do you think? Or make some comment.
Ask me, I will tell you to send the patient to us.
Okay.
What would you do differently than us?
Well, I can take care of that aneurysm.
Okay.
And how about your opinion, Ajahn Tia?
And I can make it a lot bigger, so I can put like 25 or 27 valve in that, and then next time you can do a better transcatheter.
Wow.
Yeah, I agree with Dr. Chun. Yeah.
Yeah, one of the questions that we don't ask enough is, can you post-dilate the SAPIEN S3? And actually, if you get a 23 millimeter SAPIEN S3, that valve frame, that stent, will actually dilate quite a bit. So I agree with Gareth. The 20 is probably not the right thing to be putting in people's RVOTs, but the 23 SAPIEN S3 actually post-dilates quite a bit. So with high pressure balloons, it's a reasonable long-term option. A 20 is not.
Dr. Tomita,
Let's look.
your comment?
Yeah, I agree with Gareth, and I actually wrote the paper on pre-stenting for SAPIEN S3s, didn't we, Gareth? And I never
Beautiful.
pre-stent.
It was a very beautiful paper.
Honestly speaking,
it was-
SAPIEN 3
it was-
is not approved
it was an-
for native RVOT in Japan. So they quite limited experience, but maybe a 23 SAPIEN is a good option for this patient.
Have you done the balloon testing for coronary compromise with the? Oh, so this is the one. So there's no coronary compromise.
No, we want to show you that. So that's
okay.
a really good segue.
Yeah.
So let's show that. Let's show this angiogram here, and tell us what you guys think of this corner.
Okay. This is the one, I think, right?
Yeah. What do you think?
I mean, the concern is the LAD, isn't it? Seems like the flow of the right is a little quicker. I would maybe move more cranial to look, but it looked like there's some concern of the LAD flow. LAD flow is slower, I think. Do you have another view? Oh yeah.
What else could we do here to check that? Oh, there you go.
Okay, that's kind of lateral view.
Yep.
Okay.
Switching
So
the
now
view.
selective injection of the coronaries.
No, this is the first one that
So we did the first
pediatric
one.
done, so it's too deep a little bit.
So we engage
Yeah.
it. Might be a bit too deep.
Let me ask Garrett. So, or you guys. There's a compromise of the LVD flow, but the west is higher than that position. Do you think it's anything?
I don't think it's. Yeah, I don't think it's an issue. I don't think the balloon's causing impingement in the coronary here. I don't think there's any distortion compared to the other root injections. I don't think it's in play. And again, this is not a calcified area. I think you're going to get pretty uniform expansion in every direction. I don't think the coronary is going to come into play here, although I think it's absolutely the right thing to do to check it the way you have, but I would be reassured by this imaging.
What do you guys think?
So we had our adult folk to redo it again just to make sure. We are a bit concerned at the beginning. We moved here.
Yeah, Mann picked that up right away. The flow in the LAD was much more sluggish than the flow in the right coronary. So we felt obligated to prove it wasn't an issue. But with a series of these selectives, you'll see we felt confident that the coronary was free and clear.
So this is the later. I think the flow look reasonable now.
Well, the
I need a
balloon's
better
not up.
engagement of the left main.
Yes, with the help of Ajahn Thanawat, yeah.
And I think you're doing absolutely the right thing to be so careful, but I think looking through the angiograms as you've gone, I think it's pointing in the right direction, but I think you've got to be very careful. And even from the point of view of the tension this might put on the left main stem, exacerbating that angulated takeoff, I think all those things come into play here, but I think this level of interrogation and thoughtfulness is really important in these cases. And the other thing, I think it's very easy for me to sit here and be a smartass and say, oh, well, you would just put a 23 in. But that's because that's our practice. We do that all the time. There's a lot of stuff that you guys do that I would be terrified of and I would not take on. You know, perimembranous VSD practice that you have and stuff that I would be, you know, in a terrible fluster. So I think it's really important that you do whatever you think is fitting for your regular practice and don't take risks that you feel are outside your regular scope. So this has really got to be it's something that's in your comfort level that you're comfortable doing rather than just listening to me sitting here comfortably drinking coffee and telling you what to do.
So at the end, after the coronary artery issue clear up, so we left with the same two options, putting the 23 now or pre-stenting it. There are several debatable.
Play the final angiogram just so they can see the anatomy again.
We had a last angiograph after we do a lot of balloon dilatation, just to make sure that we're not creating any dissection or any bleeding. Looks reasonably the same. So my point is that if I were to do it in my lab, I would try to do the pre-stent and maybe up to 24 or 26, and then see that we can get a better secure location of a 23 or 26 valve according to the stent. So that's my part. I think Dan has offering the same like Garrett. Getting a 23 in or not?
You know, when I looked at this again, I just think you're going around a turn there. You know, it's such a, you know, there's just a good chance that the pre-stent might cause more obstruction than it's worth. The advantage of pre-stenting a case like this is you can really nail the 23, get it right where you want it. It's only 18 millimeters in height once it's fully dilated, and you got to get the covered portion on it, which is more like 8 millimeters. So you do really have to nail it. So, you know, but looking at how the stent would sit in there, I actually think it might be more harm than good. And I would, unfortunately, I agree with Gareth. I'd probably just go ahead and put the 23 in there straight away. But, you know, it's a matter of your comfort zone and your surgical backup because it is a much trickier thing to land in there.
All right, I think, so what have you guys decided? We are kind of running out of time and we still had one more lecture from Dan.
Okay.
Because
so we have let our boss say.
Chipa,
Yes?
may I ask Ajahn Piya and Ajahn Chun a bit about that expansile aneurysm. So if you see this without any issue on valve regurgitation, what will you do, Ajahn? Will you leave it like that, or will you just right away go to do surgery to reduce that aneurysm, which is expansile?
I think that the drawback of leaving the aneurysm untouched or intact is the thrombotic phenomenon, and is caused. I haven't seen some progressive dilatation of the aneurysm because it is quite low pressure, and the patch usually is quite tough. And I haven't seen any rupture, but I have seen some emboli or thrombus.
So this we can live that like more than years, right? 10 years, maybe down the line without any problem, right?
It depends on if you found that you found some thrombus inside the aneurysm. You have to go back and get rid of it. Yeah. Otherwise, I don't touch it.
Okay, thank you.
What do you think about it?
I think it's expanding, but I agree that we never see the rupture, but also I never see the clot inside. I mean probably it can be the source of the thrombosis, but actually when we open up these kind of the aneurysm, we didn't see any clot inside. So if we don't have to do anything, I mean we are not going in, then I think we can follow up this aneurysm.
Yeah, the only thing that, again, it's a bit more subtle is what it does to the flow dynamics and how much energy loss you're getting at that aneurysm, but then that's all a little bit subtle, and, you know, might not play into the decision making, but there's no doubt that that's going to give you a lack of directed forward flow through the pulmonary valve because you're losing energy into a pulsatile aneurysm. But I agree that I don't think it's going to rupture, and I think the clot risk is very unlikely because it's filling and emptying so briskly. But I just wonder if you analyze this with 4D flow, how much energy loss you'd get into that. But that's probably a little bit subtle.
All right. Okay.
Okay,
So
yeah. Yes, because we don't have the stent, the CP stent, we don't have them on the shelves. And also, Ajahn Jun and Ajahn Piya didn't allow us to put the 23. Yeah. So we think we just
We'll
done. Yeah.
postpone for this part, and we'll discuss the risk with the patient again. And so there are several options: putting the native, and maybe some risk of embolization, or putting the stent, and still maybe compromise the way we're moving the commander system up. And we will discuss again.
Okay.
But we'll follow Dr. Supaporn say that we'll maybe follow next CSI.
Yeah, maybe
something
this
like
case,
that.
please
All right.
follow up on the CSI Asia Pacific on the October. Yeah, we will follow up you the
Maybe
result
the
of this
second part.
patient. Yeah, okay. So, yeah, for the safety of the patient, so we terminate, yeah, this case. Yeah, thank you very
All
much.
right.
Yeah.
Thank you for the discussion.
Yeah.
Thank you. So let me introduce the next speaker, Dr. Dan Levite. He's from Mattel Children's Hospital, UCLA. He's going to give us a talk on pre-assessment of patient with RVOT dysfunction. What is the optimal strategy? Please, Dan.
All right, thank you very much, Man and Dr. Morgan. I actually thought they did a great job with the pre-assessment in this case, and we'll get into that a little bit. There's a lot of ways to tackle this. These are my disclosures in the United States. I'm equally biased by Edwards and Medtronic, but I need some consultation outside of the U.S. So basically, I'm going to go through my sort of algorithm for more the large patched RVOT patients, which is the majority of the patients that we deal with. There's a lot of different approaches to imaging. It really does have to be in both systole and diastole. And, I'll take you through sort of, the journey that I follow on these patients. And I don't like this diagram. Everybody hates it. But, basically, simply put, you're trying to do a bunch of stuff. Well, number one, you're trying to decide if you need a pulmonary valve. Secondly, you want to decide, what imaging is going to get you there the quickest, and then decide on which valve. And really, this all starts with the echo. So when I'm seeing patients in the clinic and looking at their echoes, I get a real sense, based on just the history and the physical exam and the echo, if they're going to meet criterion for a pulmonary valve, or if it's sort of a questionable thing and you need to do things like RV volumes and RV to LV ratios. So the next few slides I can actually skip a little bit because we already had lectures on these. But I think the real point that I'd like to make through these slides is we really have thought long and hard about guidelines for surgical pulmonary valve replacements. And my personal opinion is that a lot of these valves, especially the self-expanding platforms, Venus P valve, Med Zenith, Harmony, Altera, Pulsed valve, are so new, and we just don't have the data on the long-term outcomes to be able to say, well, we should change our guidelines. So I think for now, if we're going to put a transcatheter valve in a patient, it also should be somebody that you would put a surgical valve into, because, as we saw from our last talk, one of the things that we're trying to do is prevent arrhythmias. I mean, it's a big thing we're trying to do by putting pulmonary valves in, and we don't know that some of these valves aren't going to increase our arrhythmias. So I'll skip all this because we've already heard all about it. But I think the point is that we really still have to follow the guidelines for surgery. Make sure the patients we're putting valves into in the cath lab are also patients that you would put valves into surgically. Probably not everybody agrees with that, but that's how I work. And really understand the data that the guidelines are based on as we start interpreting the results and really the medium and long-term results of all the new families of pulmonary valves that we have. So know the guidelines, and then based on my history and echo, I will do different imaging, okay? So it's important for me to make the disclaimer that in the United States, the way that we screen for, are you a candidate for Harmony or are you a candidate for Altera is at this point only by ECG-gated CT scans. Hopefully in the future it'll be MRI scans. So when I'm looking at these patients, I'm saying, okay, well, do you need a valve? Okay, yes, you do. And then, if I'm sure you need a valve, I'm going to go straight to a CT scan. I'll skip the MRI entirely. There's no reason to put patients through that if it's already a patient that is symptomatic and has an RV the size of Africa on by echo. If I'm questioning it, then I might do an MRI specifically for volumes. So that's sort of, how I approach which imaging study to get. This will be different depending on what area you're in. Of course, venous ped, you do your screening by MRI, so you don't have that conundrum. You can go straight to MRI scan, and then based on your MRI scan, go straight to the cath lab. In the United States, we are still struggling trying to screen our Harmony on Altera candidates by MRI. So the second point, and I feel like cardiologists here in Thailand are much more in tune with, the pluses and minuses and how the different scans work. But it's really important to have an understanding of what data you're getting from the different scans. For instance, on your left here, you see non-ECG gated data by MRI, and on the right, you have an SSFP imaging, which is ECG gated. So, the second thing is, it's really important to have a protocol as you're doing cross-sectional imaging on these patients, whether it's by MRI or by CT scan, that allows you to get, cardiac cycle specific data. I want to know what the heart looks like in systole and in diastole. That's really easy to do by CT scan. It's, not a big deal. But by MRI, it's really good to have a protocol. And if you have a protocol, then hopefully someday we'll get to the point at which we can really start screening all of our patients by MRI, not just CT, which is what we're doing now in the United States. And then, of course, the next question is, okay, what valve are you going to do? And sometimes that's a matter of balloon interrogation, but a lot of times you can figure it out, beforehand by looking at your cross-sectional imaging. So this is the sort of thing that we did with the case that you just saw for, about an hour or so before we started the case over here in the cath lab, which is really just looking in, we didn't have both phases of the cardiac cycle, which may have, hurt us a little bit. But what I'll do with any of the patients that I have a CT scan on is really look, and I do this myself, and I do it by multiplanar reconstruction, at each level in the RVOT, and I say, okay, what's the perimeter average diameter? What's the long axis? What's the short axis? Is this a place I could lay in a balloon inflatable valve? Is the whole thing just too big for, in our case, it's Sapien, and do we need to look at Harmony or Altera? We then will send the CT scans to either Edwards for Altera or Medtronic for Harmony, and they do these elegant reconstructions. And I call this TAVR world, because now we're entering TAVR world, because we basically are like the TAVR docs. We go, okay, we're going to put the valve there. We're going to use these camera angles, and we go to the cath lab, we do an angiogram, we put the valve in. A lot of these Harmony Altera cases are now very quick for us because we have everything planned out in advance. We did all this with the last case that you saw. We really looked at the simulated views that you saw Fook kind of rotating it around, and he predicted what would be the best camera angle. So we know what camera angles we're going to have. We look at the outline of the RVOT in systole and diastole and try to see where our valve's going to fit best. And really what we're doing is we're looking at different segments of the RVOT and looking at the perimeter average diameters in systole and diastole and comparing those to the diameters of our valve. And what we've kind of come up with as the best graphical way to do this is this thing, which is called a perimeter plot. So basically what you're looking at here is the red is going to be, the red's going to be systole, and the blue is going to be diastole. Systole, the RVOT is always a little bit longer and bigger distally. Diastole, you're always going to have a slightly shorter RVOT, and usually it's a little bit bigger proximally. And then you can overlay the frame of whether if it's a harmony valve or Altera valve or whatever else you want to put into the RVOT, and you can say, okay, it looks like we're going to have good interference distally, good interference proximally. It's going to seal well down here, and it really allows you to help predict in a very quick manner exactly where you're going to put the valve and whether or not it's going to be stable there. So again, what we do here is we just send these, reports in, and we get these elegant reports back from the companies. They obviously come with the simulated fluoroscopic views. This is an example of a similar plot that Edwards does. Edwards gives you one plot for systole, one plot for diastole. Medtronic puts them all in the same thing. And then if we're still unsure, we can do 3D prints. We do this a lot less now. When we first started doing Harmony and Altera, we found it really helpful to do 3D prints. And again, we do the prints both in systole and in diastole and put the valve constructs, in this case it's Altera, into the 3D prints to see where it's going to fit. Some sites still do this religiously. Most sites just go off the CT scan. But in questionable cases, this can help. And of course, you can get really fancy and do it under fluoroscopic imaging. Again, this was in our early phases of Altera. We don't do this much anymore, but it can be helpful. So as we're looking at these scans, we've started sort of grouping different types of RVOTs, and I can tell that people here in Thailand are doing the same thing. We're always worried about the pyramid RVOT, and you can get much more pyramidal in diastole than you are in systole. Some of these RVOTs are reverse pyramids, or what Matt Gillespie has termed a choke point. Oftentimes this is at the valve annulus or supraannular. Some RVOTs have this septum in between the left and right PA that limit how high you can put a self-expanding construct. And of course, we're always looking at length. Length is always good. So as I'm evaluating these CT scans myself, and I think as I've been around doctors in Thailand the past few days, the Thai doctors I'm seeing are much better than this actually than the United States doctors. We just send our CT scans to the companies, but I call this kind of the DIY or do-it-yourself approach. So when I look at these CT scans, the first thing I'm doing is I'm measuring the length. How much length do I have in systole? How much length do I have in diastole? And you can put these self-expanding constructs all the way up to the top of the RVOT here. So you're looking at length, and this is just sort of a comparison of my measurements to the measurements that Medtronic makes for their Harmony analysis, just showing that this is a pretty simple thing to do. You don't actually need to always rely on the companies to do this. So as we're doing this, I'm really screening these RVOTs for both, okay, is there a place I can put a balloon expandable valve like a Sapien? And how would a Harmony valve look? How would an Altera construct look? And we're then measuring these sort of multiplanar reconstructions at every level of the RVOT. And again, I'm just sort of comparing what I do to what Medtronic does in this case. And then whether it's an Altera or a Sapien valve, I'm basically saying, okay, if I put a Harmony here, for instance, what's the distal part of a Harmony valve? Well, okay, that's about 43 millimeters. What's my RVOT up here? And I just sort of put the RVOTs into 3 different segments, and I make my own kind of DIY perimeter plot. So, I think a lot of this stuff that we're relying on the companies to do for us in the United States is actually stuff that we can do ourselves. And at least when you start out doing these self-expanding constructs, no matter what valve it is, we should be doing it ourselves. And so this is the final this is basically the procedure in a patient. Altera is 2 steps, Harmony is 1 step. You go in, you take a picture, where you're going to put the valve, and you put it there. It's really important to memorize the sort of dimensions of each of these valves. And it's also important to not lose sight of the forest for the trees. So perimeter plots are a really good start to how to evaluate these RVOTs, but there's a lot more to it in terms of curves and, are you going to oversize the RVOTs? So a lot of this is really a learning cycle for us. And it's important to remember we're really just on the start of this journey. Both the Altera and the Harmony valve in the US were approved with very small trials. So we continually reevaluate our clinical experience as these valves are now commercializable, because we're at about 500 implants total with Harmony and Altera. So we're still really learning and continuing to sort of evaluate how to best put in these valves and how to prepare best for the cases. Thank you very much.
Thank you very much, Dr. Levy. Is there any question or comments from the audience, please?
Should we just welcome back Shaq and Jae Young, who've been out playing golf all day while the rest of us have been working? So thanks for showing up, guys.
How did Shaq shoot him?
What's that? Anyway, thank you very much, Dan. That is a very great talk. I think we landed a little late, so we're gonna finish this session now. And thanks all the panelists, and we'll adjourn in about 15 minutes. Thank you.
Thank you.
like to invite the next session moderator, Dr. Pontep from King Chulalongkorn Hospital, and all panelists on the stage.
Hello. Okay. I think we should be ready. You always look like chairman. Oh, now Jonas, right? He's a chairman now. Very nice. I already do this to them. Helping us. Should we start now, or how do we do this? Good afternoon. I think it's around 3 o'clock, and I'm very glad for the die-hard fan that everybody here is in the meeting room. And I think we will start with the live case that starts at 3 o'clock in the afternoon. Is the CAT lab ready for the live case? And the CAT lab hears us now. Otherwise, we'll start with introductions. My name is Chris. I'm from Sirat Hospital. My co-moderator is Dr. Pontep, who actually need no introductions. And we have Dr. Pia, who's our chief surgeon from the Rama Tipadi, Joku Wang, who is a past president of the Asia Pacific Pediatric Cardiology Society from Taiwan, and Jonas, who's now a president of the APPCS. And welcome all the panel. Are we ready from the CAT lab? I saw Dr. Pipe. I think he's ready. Can you move your table now?
We cannot move the table, but we can move the fluoroscope.
Okay, good.
Okay now.
So we can continue with the case. Can you tell us about the case a little bit?
Okay, so at first I will introduce my team first. In my left hand side is Dr. Elena. She comes from the Maldives. And on my right hand side is Dr. Chutima from Ramatibadi Hospital and Dr. Sanrat from Chulalongkorn University. And over there, team is Dr. Kanyalak and Dr. Nawapon. And around here is nurse team and anesthesiologist team. So let's move to my fellow. We'll introduce my case.
Good afternoon, everybody. So the next case is 11 years old girl. Her body weight is 26.1 kilograms. Her height is 135 centimeters. She presented with dyspnea on exertion for 3 months. Her functional class is class 2. And here shows the current medication. Her vital sign is normal, and her cardiovascular examination show active precordium, RV heave, displete ejection murmur grade 2 at left upper parasternal border, and wine fit split S2. Her chest X-ray show right atrial enlargement, right ventricular enlargement, increased coronary blood flow, and her EKG show right axis deviation and incomplete right bundle branch block. The TTE is here. In subcostal view show the secondum SD diameter of 21 millimeters, the SVC rims of 12 millimeters, the IVC rim of 14 millimeters. Dilated RA and RV are also seen. In four-chamber view, the ASD diameter is 22 millimeter, the posterior rim is 10 millimeters, the AV valve rim is 11 millimeters. And also in parasternal short axis view, the ASD diameter is 22 millimeters, the posterior rim is 10 millimeter, and there is no AS rim. So in this case, we plan to use the M-Plaster ASD occluder. Thank you.
Okay, so let's move to the live echo. Everyone, can you change to the echo, please?พี่โอครับช่วยเปลี่ยนข้างล่างนี่เป็นภาพเอ็กโคหน่อยครับ Thank you so much. Thank you. Okay.
This is the TE. The RA-RV dilatation. Normal tricuspid valve, no TR, no FR. The AV is about 9 millimeter. ASD in this view show 19 millimeters. The posterior rim show 9 millimeters. The total septum in this view is around 39 millimeters. At 60 degree, the ASD show 21 millimeters. The posterior rim show 8 millimeters. Minimal aortic valve rim around 3 millimeters. The VC-IVC limb show 7 millimeters. SD in this view around 20 millimeters. There's minimal floppy IVC limb. The pulmonary vein is normal. And this will show total septum around 43 millimeters.
Thank you, Dr. Navapan. So now we facing off the large ASD. The size was around 20 to 22 millimeter with adequate limb. So at first we do the right and left heart cath for measure the KPQS and the PVR. It showed that the KPQS was around 2.0 and the PVRI around 2 wood unit meter square. So this patient had indicated to ASD kosher. Can I ask the panelists that for the case like it, what size of the wire that you suggest us to do?อาจารย์ครับ
Question is that we got 20 millimeter, 22
yes.
millimeter, right? And the septum is 45, right? My first thing would like to discuss that, do we still do balloon sizing at all for a kid this young, or we just take it as what it is? Joku, Jonas, what do you do?
In our lab, we don't do balloon sizing. We just usually, depending on the flimsiness of the rims, we add about 2 to 6 millimeters depending on how it is. So I think in this case, you can get away of not doing the balloon sizing. And I would, for a 20 to 22, put a 26 millimeter ASD occluder, try to use the right upper pulmonary vein approach since there's a deficiency again in the retroaortic rim.
Mm-hmm. Joe Koo, what do you think?
I don't do balloon sizing, and I usually add 20 to 25% more than the largest diameter major on TE images.
So you will pick 26 also?
Yes, yes.
I'm not quite sure. What do you think? Yes, Jae-yong.
So nowadays, do you hear me?
Yep.
Yeah.
Very
Nowadays,
well.
many operators don't do the balloon sizing, but I'm still in the balloon sizing side. So I would like to ask, why don't you balloon size? But because I think that the septal compliance is different patient to patient. In the most of the cases, the compliance is similar. So out of 100 cases, 90% 90 patients would be the device size would be the same. But maybe 10% we may choose the smaller size or a larger size. The patient should have the device in their heart for the rest of their life. So I would like to put the accurate size as much as possible. So while in the initial experience, there may be some complications such as a balloon tearing the septum by the balloon or something like that. But if we put 10 more minutes, the patient would be possibly benefit for the lifetime. So I still do the balloon size. So I don't think the older operators should balloon size, but I'm still doing. So I would like to.
So correct me if I'm wrong, Jae-yong. So if we do balloon sizing, and it's happened to be 22 millimeter as what we see, what is your selection?
22.
So you do exactly 22?
No, not oversized.
Not oversized,
Yeah,
not even 1 millimeter. This is what it is.
Yeah, just 22 or even 20. If the rims are very stable, then we could some room to undersize.
I saw Shaq moving microphone. he must have a very good golf day today.
We've had great fun. I was just going to disagree with Jay on principle. If you do balloon sizing and you get 22 waist, you've still got an absent aortic rim, and that potentially can lead to a possible problem. And so even with a 22 waist, I would probably go up 2 millimeters at least, and so go for a 24 device. But here, I think it's a good weight child, 11 years old, I think it was. So either 24 or 26 would be fine.
So your strategy is to spray around the aorta, right? So, but we don't know about the exact mechanism of erosion.
Yeah, well, we've been talking about it for 18 or 20 years, and we haven't found out the exact mechanism, so that means we're not going to.
Okay, so there are some postulated mechanism of erosion, but still the oversizing may be one of the very important risk factors. So I think at the underside, if you undersize, there could be some less risk of some friction, the fixed friction around the aorta. So nobody knows. So maybe he can put some more comment. He is usually oversized to prevent the erosion.
Jay, the exact mechanism is unknown. Oversizing may be a factor, and it's a statistical analysis one. And I've been oversizing pretty much every single case since I've been doing ASDs, and I haven't had one erosion. So there must be some other factor.
Yeah, so I also, for my experience, the more than 3,000 ways, more than the 3,000 ways closures, I haven't had a single erosion case. So I usually undersize. So nobody knows. So I think in this case, maybe there is erosion could be some issue, but usually the balloon sizing may not harmful, I believe. So there are two tracks. Not sizing is a trend, and that is the right way to go. I don't think so.
So Pipe, we've been absolutely useless to give you any advice because there's one group saying...
Thank you, panelists.
Yeah, there's one group saying don't oversize or don't balloon size, and the other don't just balloon size. So it's useless help to you, if you like.
Okay, so for me, because I'm learned from Dr. Supha, so here I think that the balloon sizing is not, from my experience, balloon sizing, sometimes we should use the experience to foresize the defects. For me, I cannot much experience for it, so I cannot use the balloon. I think that I maybe not use the balloon sizing in this case. And I think that balloon sizing can be helped in the fenestrated ASD something if you want to size the two defects of the ASD. So in this case, for me that I had the problem is about the defects. I choose the device size around the 26. That if I calculate with the height, is the ratio is around 0.19. I'm not sure that, do you think that is have a problem with me?
Can you explain to us again on your ratio rationale?
Because in some paper about the device in the small baby, we measure the device size ratio with the height of the patient. If the ratio is over 0.18, if we have the problem of some heart block or some erosion. So in this case, when I measure the ratio of the patient, it's
Right.
go to the 1.19 or 0.19 to 0.2 something.
Pipe, we should ask Jae Young.
Okay.
I'm gonna say one thing. In the CSI, the Frankfurt, maybe 5 or 10 years ago, posters showed us the very nice T image. In Frankfurt, the T image is very excellent. And the size was about 12 or something like that. And asked all the panelists, and maybe 70% of the panelists and the audience, they said don't balloon size. And he balloon sized. It was a 24 or something like that. Sometimes we have such a patient. What would happen when they put the 12 millimeter device? It embolizes. At least, maybe if you are a good operator, then embolize doesn't matter. You can take it out, take it out and balloon size, and then to put the right size of the device.
But Jae Young, you've avoided Pipe's question, which was about the ratio.
Ratio is the size to device ratio. Usually 20% is enough, 15 to 20%. During the initial experience, there are some publications, the 20%, 25% are adequate for oversizing. But I, again, would like to emphasize that all the patients have different compliance, different anatomy, and also sometimes some hidden defect, especially with patients with the Boldier, so-called Boldier aorta. You may miss some real defect size because of some bulging of a sinus portion or some other tissues. So maybe I'm not balloon size all the patients, but more than 2/3 of patients are balloon size.
Fook has something.
So you're suggesting that we should do going back to square one, which is have good imaging at the beginning, and then rely on either the TOE or TE versus the balloon sizing. Does that?
Yeah. One important factor is that the operators who doesn't have some enough experience, they have more tendency to not to balloon size. So they just maybe they worry about some complication from the balloon size, such as the septal tearing or something like that, and then they make a more frequent device embolization and make more complications. So,
that means, Jae-Yong, that you're not experienced.
Maybe, but the operators like you and Shaq, I think balloon sizing is not necessary, but if there is some flange rim and some different morphology, then you could balloon size only on those patients. But in initial experience, I recommended to balloon size all the patients.
Can I ask you something, Jay? Does 3D TEE make you favor, or does it matter to you?
3D TEE is very helpful. The morphology and the spatial relationship with the cardiac tissues, very important and very good imaging modality, but it doesn't tell us about some compliance of the septum. So if you have, even the very experienced the operators may miss some tricky the morphology. So I think balloon sizing is another backup way to confirm about some adequate size of the device. I believe so.
So, thank you, everyone. I think that now we have two things for the balloon sizing. So, I think balloon sizing is depend on the doctor or something.
Yeah, Jay, sorry, it's my fault. I teach my students not to balloon sizing anymore. Yeah, it's my fault. Yeah. So because I have the bad experience with the balloon sizing, I do agree. What we want from sizing or not sizing is the side that precise. Yeah. So I think even you use the balloon sizing, if you don't do it in the right way, it will not give you the true measurement of the size. Yeah.
I'm happy with the 26 millimeter device in this patient.
Again, please.
Happy with
again, please, Jay.
Yeah, 24 or 26 millimeter device, both of the device size would be fit to the patient very well.
Yeah, all right.
Yeah. I think for because this patient, the size is around 20 to 22. Yeah. So if it's a circular shape, I think 2 to 4 millimeter larger than the defect diameter would be the reasonable size, which is not too big. Yeah.
Super, do you have a ratio for the? Do you have a ratio for the weight?
Yes, I have a ratio. Then it's my rationale. That's why pi is emphasized for all your guys. Yeah, because if the ratio is 0.18 or more than that, it's at a high risk of the embolizations, which we have to concern, especially in the children. So that's what I teach them. He is a good colleague. He is good staff. Yeah. So that's why he quite a lot of concern on that. So I agree that 26 might be at risk for the heart block rather than other issue. And for the better for deployment and avoid of the embolization, I think 26 is much better than 24, especially for the junior. That's may difficult to use another technique or something like that. I prefer all your guys to use 26. Yes. Okay. And yes, we concerned of the heart block. We will carefully look at the ECG. If any heart block, we will change to 24 with maybe the balloon assist or something. Yeah.
Luke, could I ask
Okay, so
about...
please go ahead. Yeah.
Okay, so for now we have the
Yeah,
One
allow me
second.
to use-
Super, yeah, super. Cool, yeah. Just want to ask, since you're using unplugged device, are you more towards 24 or 28 out of the 26? Because the 26 is always the most stiff device.
Oh.
Yeah. So I'm just asking whether are you going to be like 24 be much nicer because of 26 is the most stiff device? Erosion check?
Yeah, that was my point as well. And it's the most commonly reported with erosion as well. So I think I agree completely. And I think I would, unless you have to use a 26, I would use a 24 or a 28 because the 28's less stiff than the 26. So I think I would try the 24 and do it carefully rather than go to a 26.
So you're all,
for exactly those reasons.
you're all superstitious then,
called-
because
it's called
26,
evidence. It's called
26
evidence.
is much keel. 26 is 2 times 13, isn't it?
I'm not sure what to do.
All right, Pipe. I think
Okay,
you should
okay.
tell us what you want to do.
Thank you everyone for help us to choose the device. For me, so that I have the conclusion is I will use the 26. So with the Ampasser device, as you can see that at first that I learned about the Ampasser now is have the new delivery cable. This is the TVCO. As you can see, is have the allow 11 centimeter that is very flexible. That will help us to put the device to the ASD and easier to evaluate after we put the device in. So we use the size of the 26 with the TVCO. I think it's okay. So
Pipe, can you tell us what's the benefit of this new cable compared to the old one, the new TVCO?
As you can see, this one have the very flexible. At the 3 centimeter first is very flexible, and 2 centimeter is very flexible, and after that it's flexible too, but it's lesser than the tip of it, and then 9. Sorry about that. So and another is the same. So when you put the device, if it's big to the defect, it have some pressure on it, and it's difficult for the TEE guy to access the device, is this well to the defect or not. But TVCO is decrease the pressure that it push the cable tension to the device, so make the device in the normal position that make the TE guy to do it easier to evaluate for you. Something like that.
I think I was about to say that Treviso removes the bad reputation of a 26.
Okay, thank you. So now we loading the device inside.
What size sheet that you put on now?
I use the 10 millimeter sheet, 10 fence long sheet. And I use the left upper Fourier techniques first for deploy this ASC device.
Super.
Yes.
I don't want Pipe to change anything, but with absent aortic rims, I pretty much always deliver the device through a right upper pulmonary vein approach. But obviously, Pipe, don't listen to me.
I listen to you.
He doesn't listen to me as well. Yeah.
I cover one of your ear.
Yeah.
I try this way first, and then if I have the problem, we have the second plan.
Supa, you look like a mother there watching your kid perform on stage.
You do? Yes. Just cross one. Just have the marker.
Yeah.
Your sheath is in the left
Yeah, I
upper.
didn't move because I can reach the marker almost.
Now with shaky.
Yeah.
Can we also see the TEE also? Is it possible to see both angio and TEE?
Oh, the
There's no TE there.
มีสายเข้ามาในภาพครับ
Yep. Now here we go. Oh, we still did not see. Can we do a picture in picture or something? So. I understand. Well, I want to ask them politely. Check.
Just while they get that organized, the other thing is we talk about the right pulmonary vein approach, but actually you're not really getting into the right pulmonary vein, you're just deploying the device and placing it close to the origin of the right pulmonary vein to get the orientation right, which is different from putting the sheath in the right pulmonary vein and deploying the left disc up there. So it's probably a bit safer in small children to just be towards it.
Pull down a little bit. Okay, pull you.
I still go into the right upper pulmonary vein with the sheath, yeah.
Wish to do.
Are there any chance that we're seeing TEE now?
Hang on a sec. We are working on that.
All right, Elena, we go to the right now.
Yes.
I was told that TEE
advise-
are not ready, right? There's some problem with the machine or something.
ผมว่าฟูดาวได้ไหมครับเนี่ย
Be kept.
วิสผมจะพยายามหมุนให้ครับ This one okay ดาว allow here big cable
Yeah.
go back the sheet back the sheet more open big cable go back.
Yeah.
It's still
It's still. Yeah.
pick up okay so I can help you okay.
Five, you guys have a TEE picture, right? But we did not have it. So I'm confused. It's like you had TEE, but it just cannot be displayed. But you saw it, right?
Yeah. They're looking at the TE. I think that's why they retrieve it.
Yeah. That's what I did.
Dan Levy has offered to he's offered to act out the TE using dance moves, if that would help.
So you're saying, Shaq, you would have started in the right upper pulmonary vein to begin with instead of like pulling and then twisting, yeah?
Yeah, if the aortic rim's absent, you get a better alignment the first time and you don't mess around multiple turns.
If that is the case, Jack, you pretty much have to do like a much small ballooning in the right upper pulmonary vein instead of almost fully opened?
Yeah, no.
Yeah.
There we are. Now we see.
There we are now. Okay,
Yeah.
good.
Go back.
So I deliver the
prolapsing.
whole disc in the pulmonary vein, and it's stuck there, and you then pull back the sheath and deliver the right atrial disc in the right atrium. And when you then push the device
Yeah.
forwards, it bounces and aligns with the septum better.
Open.
Yeah.
Two.
Two.
Okay.
Already prolapse to the RA to recover.
We have early capture for you. Yes.
So now we can see both angio and also the echo.
Yes, now from the NGO look like the angulation of device is good, but from the TE we see the leakage as the SVC rim. So I will adjust a bit of the device again. Yes. Okay.
You want to try? Oh.
Hi.
Can I?
Yeah, you.
For me?
Okay.
Sorry, man.
They cheer for them. Yeah.
Yeah. Don't give up. Go to the
Yeah.
right upper pulmonary vein.
Well, that's the question is, do people feel safe just putting the delivery system into the right upper pulmonary vein without a wire?
I would,
Is that
after
okay?
trying several attempts, I would then follow what Chuck was saying to deliver first the sheet to the right upper pulmonary vein. Instead of you like trying to torque it towards the right.
So I think
Yeah, okay.
the left atrium doesn't look that big, so sometimes it's not very easy to change the direction. Maybe we just take everything out a little bit and just stick it in the right upper
They have
vein.
to probably retrieve the entirety disc and then just position the sheet to the right upper pulmonary
The left
vein.
atrium looks too small because the device is too big.
Jae Yong, what do you think?
First of all, the T probe should be advanced a little bit more. We are just looking SVC rather than the
little bit deeper.
The defect. And I think it is the atrial loop is very fragile structure, so it is a little bit carries a risk. So make us something like some small flower bud like a shape of the device, and clockwise rotation may direct the catheter tip to the right upper pulmonary vein. Then, even though you don't put everything inside the right upper pulmonary vein, you can make some the transverse shape of the disc. Then just fix the delivery cable and redraw the delivery sheath, not pushing the delivery cable. Then it automatically find the right position, then push. If the device is left atrial disc is caught inside the right upper pulmonary vein, then develop the right disc at the right atrium, then push. It is the Bharat always explain the right upper pulmonary vein is not to pull, push, then it automatically disengage the left atrial disc to the LA.
เดี๋ยวคิวนะแต่น่าจะผมน่าจะบิดได้เป็นน็อตนะ
Just to surprise Jae Yong, I agree with him.
คิวเป็น
Nice body.
เรียบ
Would others do a balloon assist technique in this one? Would you?
I think
Yes,
they still can try to do the right upper pulmonary vein. I don't, to be honest, I have not seen that they really curve it to the right pulmonary vein as of now.
คิวไม่ยอมแล้วเข้าไปแล้ว
Not sure you guys do this, but sometimes I do a lot of pre-bend on the sheet because the sheet is very good. It's very talkable.
ลองช่วยหมุน
Sometimes it can point a bit more direct to the posterior.
ออสเตรเลียจะเป็นยังไงน่าจะเป็นเลย
Okay. Looks better now. Looks a bit.
ดูแล้วไปเลยเสียไหม
getting to the right, isn't it?
Yes.
Mm-hmm.
They try to getting to the right, yeah.
Maybe you can do the echo, decrease the angle a little bit and move to the right, so sort of guide them that they are pointing to the right.
You might have got it there. It looks that looks a bit better, did it not? Because I thought that looked better where she had it.
Yep.
Okay.
Joku, help us. What should we do?
In this case, I prefer change the device to Seraflex.
Joku, you're not really helping us.
Although the relationship between Taiwan and China is not good, but I prefer to use Seraflex in this case.
I think device such as a Seraflex or Ocultech device, you get another method is they develop both discs in LA. Then when you pull,
Guys, looks, they almost get it. Guys, one second.
Okay.
Yeah!
I think the magic word was Seraflex.
Okay.
All right, if we not succeed, talk about Seraflex. So explain to us what you did, so we can learn from you.
I'm not sure what I do. Okay.
but one concern is that the device shape is not as usual. So push a little bit and push, pull, and it may form the original shape.
I think what happened is the left disc had a cobra malformation when it came out, which actually got them into the right position. So I think because it had been pulled back and forth several times, the nitinol got a bit twisted. And when the left disc came out, it came out at an angle, which allowed them to deploy. But yeah, I think that's what happened, but it worked out nicely.
Okay, so that I try to cross is I follow the Dr. Supha voice. He told me to go to the back and line up a polyven. And we see the echo follow that the left edge is in the plane of the interseptum or not. And when it go to the septum, I just rapidly pull back the long shape to open the like this, something like that. So now.
Was that caught on fluoro? Was it saved the way that you were opening? Looks like it was in the LA, not in the right upper pulmonary vein area.
It was a left atrial appendage deployment.
Yeah, it was. It looked like it was in the LA appendage.
Get cut somewhere, and then just reverse the disc to the proper position.
As you see in the echo, the device is well seated. They grab the AV valve limb and the posterior rim also, and minimal device leakage.
Hook, what do you think about mitral valve, the disc?
It's encroaching to it, but there's no mitral regurgitation. Yeah. Some views, when you go slightly more superior, then it looks less touching.
Ooh, it's a long way away from the mitral valve.
Yes.
So you guys doing wiggling or not?
I didn't do the wiggling. Just now, checked by the echo. I think it's okay. But that we see that is have the flow to the device maybe come from the. I a little bit oversized and make the device is not what the waveform of it. Or you suggest us to do the wiggling?
No, we're not suggest you to do 24.
No.
26 is okay now.
I think on the fluoro, you can see how the cable, the Treviso cable, is a little bit bent, making it more parallel to the septum. There's not much tension being exerted.
It looks like a little bit more bulky than usual. So all of you are accepting this, this kind of morphology after the device placement? I think it's a little bit more bulky than usual.
It's perfect, Jae Young.
Okay.
So, guys, did something
maybe-
happen on the golf course today? Do you want to tell us? Was there an issue? Is there a problem?
Maybe it flattened as time goes by.
Yep.
But sometimes flattening means the expansion of a disc to the radially, then it may invade into the cardiac tissue. So that is my concern. And the additive explanation of Joko's comment about the Seraflex is that if a LA size is enough, then you can develop both discs in LA and put it back slowly. Then both discs make some parallel to the septum. Then retrieve only the LA disc with some tension and develop the LA disc again. Then it takes the perfect position. So either Occlutech or the Seraflex, we can do that. But Treviso, I don't know. I haven't done that.
In this view, in bicable view, the device grabs the SVC and IVC rim with minimal central leakage. And back to parashot axis, the device has no pinching at the aortic valve. Grab the posterior rim. We are happy now to release.
Oh, really? Okay. So now I will release the device. Everyone is okay, right?
I think the position looks perfect.
Okay. Good, thank you.
So I think the position looks good. I think you can, everybody agree, let it loose.
Then it up is important. Can you hear me? Hello?
Yep. Already released it, okay.
Then it up, can you hear me?
Yes, I can hear you well.
Yes, question to Jae Young. So in retrospect, do you think 24 or 26 is better without balloon sizing?
I couldn't hear because of the howlings.
They said either 24 or 26 is better. That's a Waragan question.
Yeah, I think so.
24 is okay or 26
Maybe
is better?
24 it doesn't make any problem in this patient. If the device is usually after the device placement, my patient, most of the patient has some flattened, more flat configuration than this case.
So, Jae Young, would you take this device out?
No.
No.
No, I know that it made the remodeling of the device occurs after device placement. But this is, I think, quite acceptable. The very good device position and good sizing. But if it is a little bit more bulkier than this, then I would change the device into some smaller one.
Good, congratulations. Give a big hand to Pipe and team. I think we should move for the lecture now. I think the live case is not ready, right?
Thank you, อาจารย์ครับ ขอบคุณทุกคนมากครับ
So we are now moving from ASD to VSD. And first lecture is Dr. Ankavipa from Chulalongkorn. She's going to give a talk on the anatomy and also the 3D imaging. Please.
Thank you, Dr. Kritikom. Okay, so first of all, I'd like to thank you again, the organizer of PSU, for inviting me to this conference. My name is Pam. So I'm Angkavipa Sabrungrung. I'm one of the pediatric cardiologists, and I'm the imager. I'm not an interventionist. So I'm doing cardiac MRI and the 3D printing. My hospital is in Bangkok, in Thailand. I have no disclosure for the talk. So now, today I'm going to give a brief overview about the normal septum first before I go to the VSD, location nomenclature. And then I'm going to talk a little bit about the 3D imaging for VSD visualization. So in normal intraventricular septums, as you all know, it's sigmoid configuration, so it's not a straight wall, and usually concave towards the right ventricle. So when you look at the image, which is on the right side, that is the cine taken from the MRI. In the axial view, you can see that the septum make the concave to the right ventricle and make the crescent shape of the RV. And on the lower right panel, that is the short axis view, so it's a crescent of the right ventricle. So we usually name the defects of the ventricular septums from the right ventricular view. So you have to know the normal structure in the right ventricle. So the first one that I want to introduce to you is the Y-shaped structure. This muscle strap is called trabecula septomarginalis. So it's cradled to the outflow tract, and then the lower limb of it is called septal band, and it's connected with the moderator band, and it's all connect all along the way towards the free wall, which is the anterior papillary muscles. Another part of the septum, which is the thinnest part, is the membranous septum. So the membranous part has two parts. The one above the tricuspid valve, that is what we call AV component of the membranous septum. That is where the right atrium is touching the left ventricle. But the lower part of them is the membranous part in lower. The lower part of them is called the interventricular part. It is divide the right ventricle and the left ventricle. And this is another important structures. Surgeons use it for the landmark. We call it median papillary muscle of Lancesis. It is present around 80% of the normal people, and the rest of them usually replaced by fibrous cord. And the most important structure is the conducting system. As you all know, it's connected from the triangle of Koch and run along the inferior border of the membranous septum, and it's go around the trabecula septomarginalis toward the moderator band, that is the right bundle branch. So I'm going to give you the name of the VSD, which I'm going to talk about only simple punch-out lesion. I'm not going to touch about the malalignment of the septum because it's like a different topic. So this is the landmark for the VSD, which is papillary muscle of Lancesis. So when you draw a line from the septums towards the Y-shaped structures, if the defect is behind the line, behind the septal leaflet of the tricuspid valve, that is perimembranous defect. And if the defect is above those lines, we call it outlet VSD. And if the defect is below that line, we call it inlet VSD. And if those defects is around 100% by the muscular structures, that we call muscular VSD. I'm going to talk a little bit about the perimembranous VSD because you are going to do the intervention on this type of defect. The perimembranous VSD locate behind those lines that I told you, and it creates the continuity of the tricuspid valve and the aorta. And this is the location of the defect. And the important structure which run at the inferior border of the perimembranous defect is the conducting system. So make sure that when you are doing the closure, whether it's the device or the surgical VSD closure, this is the location that you have to be careful. So this is the perimembranous VSD. So another thing that you have to keep in mind is that VSD shape change a lot when throughout the cardiac cycle, and it usually elliptical geometry rather than the perfect round circle. And there is an area variation around 30% throughout cardiac cycle, and during diastole, that is the largest dimension of the VSD. So why do you need 3D imaging? Usually, as I told you, it's not perfect round circle, so it provides the perfect shape of the VSD. It can provide you the number, size, and location of the VSD, and also the adjacent structures to it, which include the AV valve, semilunar valve, and 3D imaging can help you to see the alignment of the atrial septum and interventricular septum to see whether there's any malalignment or not. And it can help interventionists to plan the closure of the VSD and also simulate the surgical view. So there are a lot of 3D imaging modalities available. So for the VSD closure in the cath lab, I think 3D echoes is enough. But for the complex VSD closure, sometimes you need CTs or MRI, and then you can create the 3D segmentation. So this is how to create the VSD view using 3D echo. So you just acquire the full volume from full chamber view and crop the front until you see the right ventricle and the left ventricle. And then you crop the right side, crop the left side, and then rotate to the septal view and increase it, fill the front. So then you get the full view of the septums. That's how you acquire the VSD with echo, 3D echo. So I think this is enough for the simple VSD closure in the cath lab. But if you have a complex structures, you may need the 3D segmentation or 3D simulation. So what is the preferred data set that the 3D printing specialists need? So you need the way you acquire it, we need what we call isotropic voxels, which mean that the cube that you acquire the pictures in X, Y, Z dimension should be the same, so then you can recreate it to any plane that you like. And we prefer the thinnest slice, which if possible, it should be less than 1.2 millimeter without slice gap. And of course, we need ECG trigger because we know that cardiac motion never stops. So it's better if you acquire in only certain cardiac cycle. And we usually need diastolic phase to create the ventricular model because you know that it is the largest dimension of the VSD. And another important thing is the good contrast opacification of both ventricle. So what do I mean by that? The isotropic voxels, this is the example of different voxel size. The first on the left is the anisotropic voxels, which means X, Y, and Z dimension is not the same. So when you create a 3D image, it's gonna look like polygon. But if you have the isotropic voxels, it's gonna be a smooth transition from wall to wall. And this is why contrast opacification is important. As you can see in this running image, this is poor contrast opacification in the left ventricle. So you can see that there is no clear border between the septums and between the blood pool. So it's very hard for us to do the 3D imaging. So compared to the right-hand side, this is the example of better contrast opacification. It's not the best, but it's still a little better because you can see that there is distinguished border between the blood pool and the septums. So this is how we can create the accurate ventricular models. So for the one who is not familiar with the imaging, so if you acquire the image in isovoxels, you can do this, what we call a multiplanar reconstruction. So you can recreate any image in any direction of interest. So if you want to visualize the end-phase view of the VSD, you can just make the two planes parallel to the septums, and then I'll use one plane in the axial view, create the four chamber like on the middle panels, and then rotate it on the left panel, which is the short axis view, parallel to the septum, and you can see that this is the end-phase view of the VSD on the right side. And if you want to see the VSD in the mid-ventricular chamber, you all know that it's sigmoid shape, so make sure that you are parallel to the septum at that area, so you can create this end-phase view of the muscular VSD. But sometimes this is very hard to see and to imagine. So digital 3D reconstruction may help you to create the view of the VSD. It will help you to plan the complex VSD closure. So we can simulate the surgical view or simulate the end-phase view of the VSD. And with this digital 3D reconstruction, you can clearly see the pathway where we're gonna patch the VSD. Like this is the dextrocardia with the LV on the right-hand side, and you will need to recreate the tunnels from this VSD to the aorta, which is on the left-hand side here. So we can simulate the VSD patch, or if you want, like in this case, if you do the patch here, there will be some obstruction to the inflow on the left, which is the tricuspid valve, but it should be fine. So this is the beauty of the digital 3D reconstruction. And you can also simulate it on screen with virtual reality. And we still have something called augmented reality too, but this is virtual reality. The beauty of this is that you can expand the models as big as you like. You can walk through the VSD. You can see many holes in any angle that you like. Some drawback of this technique is that if you have some motion sickness, it's not going to be the good choice for you. So there is another technology which is called augmented reality, which will merge those 3D models into the like background that you are seeing here. So in summary, if you want to do some intervention in the VSD, you just have to be familiar with the normal intraventricular symptoms, and you have to keep in mind that VSD have dynamic shape. So if you want to create those 3D reconstructing models, it's better to be in the largest dimension, which is in diastolic phase. So in 3D imaging usually helps in VSD closure planning, but if you want to do the simple defects closure, 3D transesophageal echo is usually enough, but if it's a complex VSD closure, sometimes we need those 3D reconstruction. And that's all for my talk. I'll be happy to answer any question. Thank you.
Thank you, Pam, for your excellent talk. Okay. Is there any question?
I enjoyed talk very much, and I'm wondering if the doubly committed VSD with prolapse of the aortic valve, can you plan the procedure using 3D reconstruction before the intervention? Because a prolapse will make the VSD smaller, but actually when we want to close the defect, we cannot rely on the jet width or the measurement from 2D only. So can you tell us 3D image before the procedure is helpful?
So thank you for the question. And I think if we want to see the valve prolapse or some structure which is moving a lot, 3D echo may help to create those 3D view of the VSD. But unfortunately, at the current time, I don't think that 3D echoes can make a perfect model for the surgeon to simulate the true models for surgical practice. But one way to do that is we just acquire the 3D echoes, and then we acquire another like CT or MR image, and then we can recreate the valve plane for the surgeon, so then they know where is the possible valve plane in that area, so then they can do the trying to do the VSD patch closure. That's what I think.
It's a really good talk and very comprehensive, and just highlights the points of using multimodal imaging into the complex structure, which is lots of moving anatomy and soft tissue, and as well as pliable things like valve tissue in there. So would you say that in your practice that you would encourage people to apply using more 3D echoes in the daily practice than before? Because I think there's a clear room for that to be improved in a high volume center, busy center, and then mastering the 3D echo techniques with backup of good 2Ds images, and get your team to understand both modalities. I think that's going to be a very, very great investment in the long run. I think 3D printing does have its limitation, and all the simulation techniques are very useful for learning at the beginning. But when we go into like daily practice, that itself has certain limitation. Yeah. Would you say that like you like to invest more in 3D echoes than other things?
I think for a simple VSD, maybe 3D echo is enough. For those complex VSD, probably you need more dedicated imaging. Maybe not the 3D models. You can just simulate it on screen and then make sure that you understand those whole before you go into the patient doing some intervention or surgery.
For anyone who's inspired in imaging, want to learn the start, I'd like to share my experience as well as yours, is that initially I learned echo first, but then 3D knowledge is best learned from CT and MRI. And then when you reverse engineer doing the cuts that echo would produce, it makes so much more sense what's surrounding, and it gives you a really clear spatial relationship, and you can guide your team as to what is what in terms of orientation. It's like driving.
Okay, I think the cath lab is ready now for the second case. Okay, we will move to the second case, live case. Can you hear me from the cath lab? I can see you, but I cannot hear you now. Hello, cath lab.
Hello, can you hear us now?
We can hear you now.
Hi. Okay.
Okay.
Hello.
We can hear you now. Can you hear me?
Oh, okay. So welcome back to our last case today. I'm Belle, and I'm with Dr. Nantawan from Chiang Mai and Chatini from Hat Yai Hospital, and also Naresh from Pakistan. And today we have interesting case. Let our fellow present about the case first.
So the last case of today start with the 2-year-old boy. His body weight is 15 kilograms and his height is 95 centimeters. It's a case of perimembranous VSD. He presented with asymptomatic murmur since newborn. He currently on furosemide, and his physical examination shows normal vital signs with pansystolic murmur grade 2 at left lower parasternal border. His chest X-ray show myocardiomyopathy, mildly increased volume blood flow. The EKG show left axis deviation and no chamber enlargement. The TTE was done is show perimembranous VSD in tunnel shape. The LV entry diameter is 5.8 millimeters. The LV exit is 3.3 millimeters, and the VSD length is 5.2 millimeters. The infrasternal short axis will also show the LV entry 7 millimeters and LV exit 3.5 millimeters. And also see my LA enlargement and LV enlargement, and there's no AR. So in this case, we plan to use the device as Kona MF occluder. Thank you.
Okay, thank you. So now, let Dr. Nakarin and Lily, could you please show us the TE today?
Okay, the TE is not good than transthoracic echo. So let's see together. For chamber, we'll see the VSD, maturation. They have some tricuspid valve, tricuspid pouch. The LV axis size around for this one is around 5 millimeters, and RV axis size around 3.5 millimeters. The length around maybe 9 millimeters. By chamber view, we can see the VSD flow, but it's hard to see exactly the whole of the VSD. There is mild to moderate TR. And we can see TR. or exit view. You can see the VSD. In the true LVOT, we can see the defect, but we have to tilt the echo. Then we can see the VSD, but the flow is very scattered flow, and the site we can measure exactly the site. So I think the VSD experiment VSD, we exit around 7 millimeters. We exit site, I think maybe more than 2, and the exit site around 3.5. So let's Dr. Bill to perform angiogram later to see the exactly whole.
Thank you, Dr. Nakarin. So, Naresh, could you please show us about our gram today?
Yeah. Thank you very much, Dr. Sopa and organizer, for allowed me to be here in your cath lab. In this patient, the LVO angiogram in LAO cranial and left lateral view, we can see the unusual type of VSD with LV entry of around 4.4 millimeter in LAO cranial view and exit of 3.7.
We don't see the angiograms.
Oh, okay. Wait a minute. Can you please show the angiogram?
Can I just clarify on the echo? Does the tricuspid valve leaflet form the roof of the VSA?
Right, maybe that.
Exactly.
Yes. So you can see the angiogram now?
You can see the angiogram now.
Ah, okay. Thank you.
So in angiogram, they'll still image LAO cranial view. The LV entry is 4.4 millimeter and RV exit of 3.7 millimeter. The length of VSD is 3.5 millimeter. While in left lateral view, the LV entry is 4.5 millimeter and the RV exit is 3.3 millimeter, and the total length of VSD is 3.8 millimeter. So there on echo, previously on transthoracic echo, there was, it looked like 2 exit, but in angio, there is a single exit. And obviously there is a volume overloaded LV, LV is dilated. So we are planning for the VSD device, needs your suggestion, which approach and which device we should do.
Okay, let Dr. Chatini tell us about the hemodynamic data first.
Okay.
The
Hemodynamic
QPQS
data
is 1.8, yeah.
of this
And the
patient's PA
PVR
pressure is
is
about 30% of
0.8,
systemic
yeah.
pressure, and QPQS is 1.5.
So no issue about the
and
significance of
PVRI
the shunt,
about
and also low
0.5 and
pulmonary vascular.
Bill,
Yeah.
can you ask one of the ladies to speak rather than 2?
Wow. Again, please.
We were hearing 2 ladies speaking at the same time.
Oh, you didn't hear?
We were hearing 2 voices.
Speaking simultaneously.
Okay.
Okay.
Maybe in that room is quite loud. So the QPQS is 1.8 and the PVR is 2. So it is a significant shunt and low the pulmonary vascular resistance.
Yeah.
Okay, now, what's your suggestion about this case?
Can I just ask a couple of questions on the 2D echo, Supa?
Yeah.
First is, how far is the VSD from the aortic valve? And then second is, in that ventricular septal aneurysm or tricuspid valve tissue aneurysm, does a tricuspid valve form the roof or the upper part of the VSA? Oh, it stopped.
From the angio, look like the VSD is too close to the aortic valve. Dr. Nakarin, please show from the TE live whether what is the length from the top of the VSD to the aortic valve. But for the tricuspid, is an aneurysm, but it's not exactly the part of the
valve,
the hole.
Septality.
Yeah. Okay. So in the long axis one to everybody in the audience.
Supa, from the echo, you cannot see the aortic rim in this case, right?
Yes.
Dr. Jacqueline, please show them again. Yeah.
It's not the catheter in the hole.
For me, I
Can-
think
can
that
you-
the VSD, this VSD has no aortic rim, and from the aneurysmal VSD,
It's just next to the aortic valve, so no aortic rim.
can you feel when you see the VSD and the aortic cut? Yeah. Aneurysm anyway.
Okay.
So, okay, Jonas, in your opinion,
Well, there's no aortic rim, but you have some pouch. Theoretically, you have a ventricular septal aneurysmal pouch that probably that will move that occluder away from the aortic valve anyway. So,
but I think for the LV opening, I think it's really small. So in this case, I think if we plan to use the device closure, I think at least the LV opening should be inside the aneurysmal, away from the aortic rim already, right?
right.
So I think the LV disc should not be large. For me, I think 6 to 8 millimeter for the LV disc.
For MF4, I choose to use 4.6. 4.6.
4.6 is the how much is the aortic disc, LV disc?
10
millimeter.
10 millimeter. Yeah.
Okay, minus pass by to both sides. Okay, Jonas.
Yeah,
what
I
do you
think I would either use a 7.5 or a 6.4 for this one.
Okay.
Okay.
Any comment from the floor?
So I will.
Please check. Give me some comment.
All right, I was waiting for Jae Yong to say something before I...
He disappeared already.
Yeah. No, I think, well, it looks like you've already crossed the defect, haven't you, retrogradely? So as long as you're comfortable with the aortic rim, then 4.6 is worth attempting first, I think.
But check, go back to the approach first. Actually, we would like to ask whether you guys want to go for the retrograde or antegrade approach. So that's the thing that we would like to ask.
I think
Also,
I think retrograde is fine because you might be able to push the LV disc in a more controlled manner. Whereas from the RV approach, you'll have to try and pull it in, and it might be unpredictable.
Thank you. And Jonas,
I think the other issue, the tricuspid
Yeah.
valve regurg. So usually they say if you have an issue with the tricuspid valve, then it's better to go retrograde, and then you can try to pull the disc away from the tricuspid valve. If there's even an issue, that tricuspid regurgitation might be. So retrograde makes you able to control, versus an antegrade wherein you open the LV disc and now you're left with a big RV disc near the tricuspid valve.
For me, I
But
think
Jonas, Jonas, any concern if you go retrograde about aortic valve, because you mentioned, and also we may think that this may be just no aortic rim. Is that okay with you in retrograde approach?
That is actually the downside, though, of having a deficient aortic rim. Now it's hard to, because you also want to have a better placement just away from the aortic valve, and so you probably have more control if you're coming antegradely. So now I'm getting confused what to use, antegrade or retrograde. I mean, there's an issue about the absence of the aortic rim, so you want to make sure that you're far away from that because you want to put the device close or inside the pouch. So maybe we can try the antegrade approach, but just being mindful that the RV disc also has to be clear and not entangled in the tricuspid valve apparatus.
I think for me, I will
okay.
approach by antegrade and deploy the left ventricular disc first, but not fully deploy because 10 millimeter you cannot pull it inside into the ampulla of the VSD. So I think we better have deploy the LV disc and pull it inside the tunnel and fully deploy the LV disc in the tunnel. So it will away from the aortic cusp. And for the tricuspid valve, I think if we slowly deploy the LV disc, the tricuspid valve will move away when we completely deploy the LV disc.
Okay, allow me to share something. And now the TE that recorded before we putting the sheet. If you see in this view, we didn't see any VSD. So I think for this patient, the hole is close to the tricuspid rather than the aortic valve. Yeah, whether in the NGO it look like the hole is beneath the aortic valve. So to me, my concern is a tricuspid valve, yeah, rather than the aortic valve in this patient. So I agree with Bill and Naresh that maybe retrograde to check for the tricuspid valve first. Yeah.
And
Yeah.
Supra, one question, and how can you deploy the left ventricular disc away from the aortic cusp? Because you cannot control the LV disc inside the tunnel. You cannot push the LV disc inside the VSD tunnel when you deploy the tricuspid valve first. And for the Kona VSD, I think the right ventricular disc connect with the body of the device by a knob, right?
Yeah.
So it will move. It will freely move, and I think the LV disc cannot be pushed inside the VSD tunnel, and it will tap on the aortic cusp.
The drawback.
Okay, you can try.
the yeah, okay, yeah, let them try. Yeah, okay.
Yeah. So at first, our team plan to do retrograde as your discussion that we quite worry about the tricuspid
Supra, we have
valve.
one question. Okay.
It's not really a question, really. It's a comment. So one of the things that I always that comes to my mind is that if there's deficient of aortic rim and there's a sac, sometimes I use AVP rather than a corner. So just want to find out what do you think about that. The thing about the AVP is that you can use AVP2, and then if the lesion is a small windsock, you can even use AVP4. You don't have a left ventricle disc, which doesn't disrupt the function of the aortic valve.
I think it's another good suggestion, but you talk about AVP 2 or 4.
You can choose 2 or 4, but 2 you just basically I will choose the body of the plug as big as the sac. So as long as the exit is half the size of the body of the plug, it should be all right.
Leon, you want that because you don't have to worry about this interfering both in the tricuspid and in the aortic side.
Yeah, I'm not so worried about the tricuspid. You look at the parasternal log axis at the modified view, you tend to see there's not much rim at the aortic end. So this is one of the concerns.
Leon, what ratio do you use between the body of the
As long as
device
it's 2
and
times the exit, it should be all right.
any particular ratio number?
2 times.
Yes, very good suggestion, Leon. And if you use the plug, what size that you're gonna use in this patient? Which number?
I was fiddling with my phone just now. I didn't realize what's exit. What's the size of exit again, please?
Size of the exit is around
3.5.
6.5, right?
Exit. 3 millimeter in left lateral view and 3.5 in LAO view. RV exit.
Like,
What
You mean LV, right?
the exit?
Something
the
around
RV,
4.
RVN.
Something around 4.
RV.
RV.
Yes.
RV around
maximum
3.5
4.
to 4. Yeah.
So look at the body of the sac is about 7 to 8 millimeters. If the exit is about 4, then it use at 8.
Oh, this is 6 now. With the sheath in.
Yeah, with the left side around 6. Yes. So which number?
But I don't think the exit is 6, as big as 6. I would use about 8 or even 10.
And retrograde or antigrade?
I tend to use retrograde. Yeah, retrograde.
Okay.
Okay.
Okay. Okay, let them try the MSO first. Yeah.
Okay.
Yeah.
Okay, so our plan is to select the 7.5 MFO device and try on retrograde approach first and see what happens.
Okay, go ahead. Yeah.
Okay, so could you open the device 7.5? Oh, already. Okay, so as you can see the corner MF, can you see it? The benefit of this device is that you can connect both of the side, so you can deploy
Bill,
and what?
Bill,
chat.
we
Yeah.
can see your back, but not the device.
Okay, let them change the video.
Because Bill's face is much
can you
better
see
than
my
device.
face now?
7.5, okay.
Yeah. Okay,
And
so
for the 7.5, how about the size of the LV disc? Is 10 or 12? 12?
12 ค่ะ12ค่ะอาจารย์
Okay, thank you.
Thank you. So you can connect both of the side. So you
you see
can
your back
deploy
again,
antigravely or retrogradely. And for 7.5.
Can you show me when you, okay.
And for 7.5, the disc of LV and RV is the same at 12 millimeter. And the length of this device is only 4 millimeter. So if we plan to deploy retrogradely, you have to connect the LV side to the cable. Okay. Already locked? Yeah. Check again. Yeah.
And what size of the loading system? I mean that 5 French or...
Yeah, 5 French for 7.5, yeah. Okay.
And you will use the long sheet 5 French, or you can have an alternate to like a gliding catheter. I'm not sure. Chat, do you know the 5 French can be used like a gliding catheter, 6 French or 7 French or not?
Yeah, but I can't remember the weight of the child. I think I would use a sheath rather than a guiding catheter, yeah.
They have their own long sheet for MFO. So we use the long sheet 5 French from the Kona MF company. Oh. Okay. Okay, now the device was introduced to the long sheet into the RV Apex. And we will deploy the RV
So,
disk
Bale,
first. Yeah.
do you keep this same AP projection as it is, or do you go back to what you showed?
Thank you.
Thank you.
พี่ต้อมคะระวังหัวค่ะ โอเครู้ไหนค่ะ Okay, now Dr. Nantavan already deployed RVDs fully and then pull it back slowly to the VSD. Okay, then you have to push the body into push the cable more. Okay, okay, it's okay. So now we already deploy both of the sides and we check for the echo.
Position of echo is seem look good. Exit view, the device just touch the electric valve, but still no AR, no residue, just central shut. Yes.
Oh, sorry.
The device look fit to the device, look to the hole.
I'm sure it's okay, but can you have a look at the tricuspid valve as well?
Okay. Move to the four chamber view. The TR, no more TR. I think it is decreased from previously. Okay.
Is
it okay, I think?
So from the TE, the dry cuspid valve look has the same level of regurgitation as previous. And for the residual shunt, I think still have some residual shunt, but Dr. Suphas tell me that she cannot hear any murmur. And for the LV disc, it looks attached to the LV side.
So,
but for the
super.
Yeah.
So
Yes.
you make a decision, irrespective of residual color flow, you make a decision on your auscultation. Is that correct?
Yes. Yes. Yeah, and the LEDs look well attached to the LV side. So in terms of the device, I think it looks well. How do you think?
But you did it so fast that for the slow learners in the audience, nobody even noticed you doing the thing. I was almost going to ask you to do it again so I could catch up with the way you were doing it. But did you deploy it by feel or on echo? Quite seriously, do you pull back and feel tension and then deploy the left, or were you really looking at the echo?
Dr. Nantawan, mainly she look at the fluoro first, and then look at the, we also look at the echo sometime to see the LV is attached to the LV site already or not. If it already attached, then she deploy the body and the LV disc after that. Yeah.
Gareth.
So use both.
Gareth, usually you're guided by echo because you can't feel much. The device is so soft that you can
Yeah, I
hardly
mean,
feel it.
it was honestly, it was a compliment. It was only because it was done so fast.
Yeah.
I would still have been sweating over which device to pick, and they got the thing deployed. So it's just a testament to how skilled they are with these devices.
Yes, they
because
are.
I would still have been panicking in the back too.
Okay. Let Dr. Supha
I will
listen to the
you
murmur again.
but I swear that I didn't heard any murmur.
You should get somebody like me or Dan to have a listen because our hearing's not very good.
Through the sheet, yes.
Yeah, I didn't hear any murmur.
We can do the pulmonary artery angio and in the liver phase like Sevard.
The ADO2 or MFO which have no patch inside.
I think it takes some time, but it looks from the echo. This is Varkan, by the way. It looks like a central leak. I mean, to me, and if you have like a chance to get a good LV angio properly, that'll be the best option, right? But with the retrograde approach in small child, sometimes we don't want to have another arterial access.
You don't
That's
do
wrong.
if you're doing a retrograde, you don't routinely puncture two arteries.
Yeah, I mean, if the echo is a good eyes for us, we probably will not. But you know, as we did a case with Robin too, retrograde approach, but that patient is quite a big patient. So with that, I think better to have another access, access to get proper angio.
Warwick, what
But
about just
for
doing
this-
an angiogram through
yes.
the sheath?
Yeah, so this is what I'm thinking, because if you use a guiding catheter, the good thing is you can connect to the wire adapter and you can get a proper angio. But with the LifeTech sheath, sometimes the valve is okay, but maybe not strong enough to hold the contrast, to get a proper imaging. So we will try to show that for you. But let's see if there's any bubble or anything that snake in through the valve or not. If not, then we'll try to give you an angio through the sheath.
Super.
Yes.
They did a much better job of this than you normally would.
Yeah.
Don't listen to him, Super. He's just grumpy because he got beaten at golf this morning.
ช่วยไหมไปตัดอันนี้ได้มาโอเคต้อมคะซินนี่ค่ะหลบก่อนโอเค one two three okay
What do you guys think?
Okay, I think you can go to detach the.
I want to ask everybody this kind of, maybe in my opinion, there is some significant the residual shunt at this moment. So I'm very much worried about some hemorrhages. So with in Korea, we only have the cocoon device. So before they changed the fabric attachment, we experienced so frequent the hemolysis from the coconut PSU occluder. But after they change it, the hemolysis is very rare. But from my experience with coconut device, usually I don't accept this amount of the radiation. So what about this device? I don't know.
So can I ask, and I know I suggested doing an angiogram through the sheath, but here you've got the sheath right
Yeah,
against
of course,
the device.
through the device at
So
the moment.
is this misleading? Should we take the sheath
Yeah,
back over the delivery cable into
Yeah,
the
yeah.
aorta and do the angiogram there? Would that be more true?
Yeah, so that's the reason why I'm not comfortable with this retrograde approach. So another catheter to show the clear delineation of the device as well as the radiation, amount of radiation would be much more comfortable. So I don't know, but this device may be different.
But I think they still not detach the cable yet. But I think after they detach the cable, I think the LVDs will
And my concern
in
is
a
that
more good position.
yeah, but after detachment, if they find something wrong, then it's too late. So that's my concern.
I think because of 5/7, there is no patch inside. So residual shunt before we detach is quite common, right? So I for this case, I will go to detach.
Yeah, as in the AVP2. Yeah, the AVP2 has no fabric inside, but because it is the more tightly woven. So
Yeah, but this because this is very soft and the wire is very thin. So I think a lot of reduction after MFO closure if we follow up at the first month, but at 3 months follow up, then the residual sum become very small, and 6 months no more.
Okay, thank you.
And so far, Jay, in our experience, even there's shunt through the device in this 6475 wherein there's no cloth, we have not seen hemolysis.
And just for clarification, Njoku, which size has the patch? Is it 8.6 or
810.
yeah?
810.
810.
9.7. I think from 9.7 they're patch.
Actually, I'm more interested in seeing how the relationship between the disc, the LV disc, and the aortic valve, whether you can pull the sheath out a bit and do a hand injection through the sheath.
Usually I make a push deeper in the LV, then make hand injection.
Yeah.
Then see how far is it from the LV valve to the disc. Then, of course, there are a lot of residual shunt, but you can go detach after you made the angio.
Where is I'd like
Guys,
to
allow me to say something. So after we, well, maybe I may a little bit not too old, but I can well, when we listen to the murmur, so I can hear some kind of maybe grade 2 murmur, I would say. 1 or 2 maybe. and one thing that we may discuss previously, that either 5.7 or 6.8, right? For this particular hole. And the disc, both of them similar size of the disc, like 12 millimeters. So if I can say, I would.
You're thinking of
prefer-
upsizing it?
Yeah, just one size, 6.8. Super, if you allow me.
Because you're seeing significant shunt through the VSD?
I swear that I didn't hear any murmur.
You
However, or to my work, yeah.
Yes.
However, I'm also worried about as we still see some flow from also the echo and also from the angio, so reluctant me a little bit. However, if we change to ASIC, I don't think it changed too much because ASIC also don't have the patch inside. So what we worry about hemolysis not abolished by the ASIC. So if we worry about the hemolysis, I may go for maybe 9.7. Yeah.
I think that all of the device are inside the VSD ampulla already, just except the RVDs that go outside the VSD formula ampulla. So I think the effect of the device inside including the LVDs inside. I think in this case, LVDs is inside the VSD tunnel. And I think with the size of LVDs 12, I think the occlusion result is not bad. But I think let's go with the leakage. But for me, I think not much hemolysis, or even tomorrow, no hemolysis.
The other thing with this, you know, the cable is pulling up the LV disc and the device is a little bit horizontal. Usually we try to push it, the cable, to make the disc sort of like parallel to the septum before release. And usually once you release, there's better alignment and you see less of a shunt.
Do you think if that TOE is live, that it's less than a few minutes ago?
PE is now live ตอนนี้ไลฟ์ไหมคะตอนนี้ Echo ไลฟ์ไหมคะ
Live.
Yeah, it's live. Check.
Do you think the shunt is through the device or there's a shunt on the side, along the side of the...
Mostly from through the shunt, through the device.
I'm afraid we're all being very unhelpful to you, so you have to decide.
I think it's okay. We can release. The last touch will be the one who's going to release it.
Yeah, you have my support too. Release and endure.
We love you.
Me too.
Have you tried pushing the cable downwards?
Yeah, I think they push already, Chuck.
Okay.
But again, because the cable, even it's small, but somehow it's a bit rigid. So that's why you may not get a proper coaxially aligned with the defect. Naresh, what do you think? Should we release?
I think we can release it because little bit intra-device flow. When we release it, align well with septum and it will abolish.
Yeah, so actually I think so, but I cannot completely say that because I'm not quite sure. So that's why, yeah, we can release, but I cannot say completely that would be like disappear.
Warwickton, you're sitting on the fence.
Yeah. So if okay, let's
Dr. Radityo has been waiting for 2 hours now for his lecture.
Yeah. Otherwise, well, to me, if this is my child, I prefer to put a bigger one. That's my thought.
Okay, so we're gonna change to 97.
Is it
too big? Okay, I think maybe you guys back to the lecture first, and we're gonna have
let us decide and listen again.
discussing. Yeah,
Maybe younger people
and
can
then we'll
come
back
and
to
listen.
all your guys. Yeah.
Okay, talk among yourselves
everyone.
like family.
Okay, we will move to the next lecture by Dr. Ladio Prakoso, in the topic of tip and trick for non-fluoroscopic septal closure from Indonesia. Please.
Thank you, Mr. Chairman. First of all, I would like to thank the PSU CSHD meeting organizer who allow me to share about the zero fluoroscopy septal occluder device closure. Can you see my slides? Yeah. Okay.
Yes, we can see your slide.
Yeah. I would like to apologize not coming to Hatay in person because of another offline meeting in Indonesia, and I have to attend. So the trend is changing, starting from the surgery to the transcatheter closure, and usually the transcatheter closure using the imaging technique called the fluoroscopy, but it's all about the dose. The dose makes the poison, and the radiation at high dose can cause many side effects, especially for us, the operator and also the cath lab team. So what if we can do without the fluoroscopy? And this is the publication showed that because of the even low dose of radiation, by the reduction of the frame rate, avoidance of lateral view, sign acquisition, and limitation of the fluoroscopic time by avoiding unnecessary maneuvers. And we can use echocardiographic guidance as much as possible. Or we just only use the echocardiography to do the transcatheter intervention. This is in our hospital milestones about the zero fluoroscopy technique. It started from July 2018. It started with the second MAC closure, followed the PDA closure, sinus vascular closure, and VSD closure, and so on. This is our initial experience. We forced to perform the zero fluoroscopy technique in a very high risk pregnant women with pulmonary hypertension who are not suitable to surgical maneuver. And more patients are intervened with zero fluoroscopy guidance in our centers, starting from the other ASD, PDA, and VSD. And we also make an intervention on the complex VSD from the multiple muscular ventricular VSD with the pulmonary hypertension. We can also close with the zero fluoroscopy technique. And this is our latest data about the zero fluoroscopy experience in Harapan Kita Hospital. And the most successful maneuver is in ASD closure, is around 97%, and followed by the PDA is 84%, and the last is the VSD. Why the VSD has a very low success rate compared to ASD and the PDA? Because of the complexity on the anatomy and also the maneuver of the catheter. And nowadays the zero fluoroscopy technique is also performed by our colleagues in across Indonesia, starting from Medan and the West Indonesia, mostly the ASD, Padang, Malang, Denpasar, and Makassar, and others in Cipto Hospital also. They perform the transvenous pacing with the zero fluoroscopy technique. I will share you about our first experience, our initial experience, how to close the ASD. I think the ASD closure is very, very easy doing by zero fluoroscopy. And when you use the fluoroscopy, you cannot identify the intracardiac structures easily, but with TE, you can see the intracardiac structure. And the problem is how to convert our mind from the fluoroscopy image to the TE. And I think it's just experience and need some exercise, but I think it's very possible. And another our experience for the complex ASD. This is our last case with a very large ASD in 30 years old female with deficient the REMS thing. It's complex cases, but can be also still used by zero fluoroscopy way by using the balloon assisted technique, and can successfully put. And how about in small children, since our cath lab are not provided by TE for neonates, so for small children, a baby less than 10 kilograms, we use TTE only procedures. And you can see, since in the small child, we can have a very good imaging. So you can use first identify the REMS, and you can measure the ASD clearly, and then do the intervention. And our topics about the VSD. Nowadays, in our center, we never use the angiography for all the VSD or PDA intervention. So we rely on the TEE or TTE measurement, since it's a very clear anatomy. But but it's very seldom, yeah. If the windows is not good, we still use the angiograph. But it's less than 5% we use the angiogram. The bad windows also usually found in the PDA, an adult with a PDA. For instance, this case, the perimembranous VSD. So we can first identify where's the VSD, and then the shape of the VSD, and we decided, is there a retrograde transarterial approach or antegrade transvenous? Since we have the double disc device, we can easily use the retrograde approach, as Dr. Bell and colleague is doing the live cases. And the tips in zero fluoroscopy is usually performed by using retrograde. That's the simplest journey. The second one, how about the antegrade? It's quite tricky. Why? Because it's quite hard to put the catheter from the right atrium to the right ventricle and goes to the left ventricle via the VSD. We usually do the retrograde maneuver from the main pulmonary artery, goes to the right ventricle, and make a small turn to the VSD. And once it's cross to the left ventricle, it's very easy to put the device. And this is the transthoracal echo only VSD closure for small babies less than 10 kgs. You can see once the catheter goes to the aortic ascending and then goes to the left ventricle, it's maneuver goes to the right ventricle via the VSD. Once cross, is easy to put the device. And subaortic VSD. The issue of just the VSD just beneath the aortic valves is about the large device in a corner. It's a high pressure device. When you put in the subaortic part, you have to easily measure, is it as an occlusion of the LVOT, or will disturb the right coronary cups? So in our center, we usually use the reverse technique when we put the low pressure disc on the left ventricle and the high pressure disc on the right ventricle. But careful, we have to measure also for the tricuspid involvement. Sometimes the high pressure disc disturbing the septal part of the chordae. What's the tips and tricks? You have to measure and have a push and pull maneuver using the TE when you deploy the high pressure disc beneath below the tricuspid valves. And how about the doubly committed subarterial? Nah, that's the much trickiest. So the position of the subarterial doubly committed VSD is quite different with the subaortic VSD. So we have to move a little bit to the posterior part, and then in some cases we need crossing not by using the classical Judkin right guiding, but we use the left internal memory diagnostic catheter. Once we can put in the front of the VSD, we usually use the hydrophilic wire to go to the right ventricle, and then it goes to the pulmonary artery. Once the hydrophilic wire goes to the main pulmonary artery, we change to the guiding catheter, and then the next is very easy. We seldom use the original sheath for MF corner to do the zero flow space, since quite difficult to move, and we use the guiding Judkin right guiding catheter. We use usually 3.5/5 French guiding Judkin right catheter. And this for the muscular VSD. First of all, we have to identify where is the VSD, and if there's the positions is near the apical portion. So we started to puncture from the internal jugular, right internal jugular vein, and then make crossing via the VSD. Once it's crossed, it's very easy to put. And the challenge of the zero fluoroscopy technique, you can see here. First, the visualization of the tip wire is quite difficult, and it requires well-trained echocardiographer. And you can see here, our Marshaller is presenting her data about the echocardiographic guidance in the European Echo meeting. And you know, we need 2 pilots in cath lab. We need first well-trained echocardiographer, and we need the interventional cardiologist. And the most important is a frequent communications between the operator and the Marshaller. So they have to be independent for the decision. And maybe in the near future, we could perform zero fluoroscopy technique as our routine, not just only in septal defect, but even in fatal patients suspected with critical congenital heart disease. So before I end my lecture, is take home message: the side effect of fluoroscopy is cumulative. Maybe now it's fine, but in the later, especially for us, the operator and cath lab crew, the interventionist should rely on echocardiographic guidance whenever possible to limit unnecessary angiographic, to keep the radiation doses as low as possible to this radiation-sensitive population. Frequent communication between operator and Marshaller are very essential for successful outcome. Thank you very much.
Thank you for excellent and interesting lecture. Any question, Jonas? You have some question?
Radityo, very impressive cases. I have two questions. What instance would you, while you're doing the non-fluoroscopic procedure, revert to fluoroscopy? What are some of the instances that you have to go back? You do this in the cath lab, right? Not, yeah, it's in the cath lab as well, right? But so what instances have you reverted back to fluoroscopy? And the second question is, I saw in your subpulmonic or doubly committed VSD, I saw that the disc was touching the aortic valve in the subpulmonic. Have you had no issues with aortic regurgitation over time? Thank you.
Thank you very much, Jonas. Good question. In the early portion of the zero fluoroscopy technique, the Marshaller is still confusing and do not provide a very nice picture. But so at that time we convert to fluoroscopy technique. For instance, we missed the catheter. Where's the catheter? We cannot track the catheter at the time. But now our Marshaller is very keen, and then they can identify where's the catheter. And for instance, in very complex procedures like an interatrial septostomy in adults with the pulmonary hypertension, we seldom get the loss of the catheter tracking. So at that time, after maneuver, we lost the tracking. We performed the fluoroscopy. But in septal defect closure, we never converted. Only in the early periods. And the second one about the doubly committed subarterial. This is very interesting cases here. So before the double disc, especially MFO coming in our hospital, we don't close the doubly committed subarterial VSD. But since the corner MF available in our cath lab, and we started to put the device in. I saw Dr. Tin and our friends using the MF corner for the doubly committed subarterial, and the issue of the touching is happened, but the follow up about nearly 4 years in Indonesia, Harapan Kita's experience, there's no deterioration of the regurgitation, or the position and the right coronary cusp condition is still the same. Maybe in the next 10 years or 20 years, we don't know. But nowadays is fine. It's also happened in the pulmonary portion. Thank you very much.
Hello, Radityo. Yeah, happy fasting and selamat berpuasa. Yeah.
Thank you.
Yeah. Yeah. So Radityo, I just wonder. Now you are more into non-fluoroscopy. So, do you kind of patients that we put into your ICL, your cath lab, do you kind of predetermine this patient you are going to fluoro, or you're not going to fluoro at all? Or if you're going to try, is there a limit of your time that you're going to step on the fluoroscopy? Maybe after 1 hour, I feel the non-fluoroscopy, I'm going to step on the pedal. Is there a kind of what is your algorithm like?
Yeah, thank you, Young. So it's very interesting. When I start with the zero fluoroscopy, I don't have a low what do you call confidence. I have a low confidence for having zero fluoroscopy at the time. But now for the ASD, I never touch the pedal now. except the marshaller cannot give a good image. So I convert usually after I see the marshaller. Where's the catheter? Okay, I wait for the 10 minutes. Where's the catheter? Can you show me the catheter? Oh, I lost the track. Okay. I use the fluoroscopy, but it's operator dependent. The second one, we still have a quite possibility of having a fluoro, converting to fluoro is in VSD. So in VSD with the high takeoff, you know, the sometimes the angle of the VSD is less than 90 degrees. So at the time, once I changed the catheter into the left intermemory, and we wait maybe 15 minutes, we cannot cross the VSD, and we convert to fluoroscopy. But in PDA and ASD, mostly we don't convert.
Thank you.
Thank you.
Okay, thank you very much, Dr. Radio Procoso. I think we ran out of time. We have to move to the next lecture by Dr. Tin from Vietnam. Dr. Tin already left. We have the record lecture. The topic of which device for which morphology.
Good afternoon, everybody. First of all, I would like to express my thanks to Superbone and organizer for inviting me to join the meeting and share my experience about VSD closer. I express my congratulations to the great and successful meeting of the PSU. My talk today is which device for which morphology of VSD closer. In my practice for VSD closer, I base on the new classification for BMVSD from the Siva Kumar. I think it's very useful for all of us for select the device. According to the classification, there are 4 types of the BMVSD from above to below. Type A is the VSD close to the aorta, and type B a little bit lower, type C close to tracheal speech valve, and type D is the inlet extension. Let me start with the type A of BMVSD. The defect very close to the aortic valve. It means no aortic rim. On echo, you can see the defects very close to aorta, and on angio also very close, but the defect may be small or moderate size. But sometimes the defect is large or moderate size. It makes more difficult for device closer because we need to use a bigger device without any aortic rim. And the first generation of the Amblaster VSD device closer, they try to make the eccentric device, and they hope that the device fits well in the defect and also no impinge to the aortic valve. I started in VSD closer with this device. I got a very good result. And on echo, you can see the device fits very well inside the defect and no problem with aortic valve. Everything looks good except the hot block with the type device. And from that, I changed my practice with the use another device. I tried to use a softer and flexible device such as ADU2, but the main thing is to keep the left side disc of the device underneath and parallel with the aortic valve, and so I can close the defect, but I also avoid the impinge to the aortic valve. The PFM coil also the good device for this type of the VSD. You can see the device fits inside the VSD and move together with the aortic valve due to it's very flexible and soft. In some more complex cases, the defects extend to the outlet VSD, and we can use the ideal tool with very flexible and soft, and you can see how the device can fix the defect well without new onset aorta regurgitation. And on echo, you can see the defect a little bit large, but ideal tool can fix well the defect and also no aortic regurgitation. It can improve the aortic prolapse also. And for type A of PMVSD, don't try to use ideal one with the retention disc is so steep, and you can see the steep retention disc in the left side of the ideal one can make the new onset AR. Let's move to the type B of the PMVSD. Type B PMVSD, there are some aortic rim, the muscular rim, and so it's good enough for device closure. We can choose many kinds of the device for closing the defect. And you can see many kinds of device can get a good result. Ideal one looks very good. Ideal two, the Core, the MFO, and also the Occlutech device. And due to the aortic rim is good enough and device looks very beautiful. In my practice, I prefer to use single disc device rather than the double disc device for type P of BMVSD because a single disc device can lead protrusion into the RV and so can reduce the risk of the trapeze valve entangling. And also the clamping force on the conduction system is less than the double disc device. Let's move to the type C BMVSD. The type C BMVSD have some aneurysm, and so the aneurysm have some advantages, such as the device can sit inside the aneurysm. It's far from the aortic valve and conduction system also. But some disadvantages also, such as the tricuspid valve problem, where they put the device into a high risk for the tricuspid valve regurgitation. The aneurysm sometimes is very complicated. We cannot understand clearly the morphology of the defect, and we cannot understand how many opening exist in the right ventricle. And sometimes we need to push the long sheet through the defect and do LV angiography to confirm the morphology. In some cases, the aneurysm very complicated with the left ventricle and right atrium shunting. The defect can create a shunt from the LV through the aneurysm to the RA, and it shows the TR a lot. But after putting the device, TR maybe disappear. In this case, the tricuspid valve involvement too much into the aneurysm, and pay attention when we put the device can make or worsening the aortic the tricuspid valve regurgitation. Regarding the device selection for type C of the BMVSD, we can choose many kinds of devices, such as a BFM coil, the Occlutech device, and ideal one also, if we intend to do the anti-crack approach, because we don't want to use a double disc device in this type of the BSD. But some cases with the trapezius valve entangling too much into the involvement to the aneurysm, we prefer to do the retrograde approach, and so you can use the double disc device such as the IDU 2 or MFO. Here you can see the device can go inside the aneurysm. The coil, the IDU 1 or the IDU 2 or the Occlutech device, everything just put inside the aneurysm, and so far from conduction system and so far from aortic valve. The problem for closing type C of PMVSD is the residual shunt due to the multiple opening axis, but no problem. We just put the second device retrograde without releasing the first device, and we can release later if the totally closer. And the second problem for closing type C of BMVSD is the tricuspid valve entangling. You can see the put the device and device protrude too much in the RV, and so you can see TR a lot. And let's move to the type D of BMVSD, is an inlet extension VSD. The defect is very close to the tricuspid valve and almost no the endocardial cushion. And the main problem in this type of the VSD is the possibility of device closure. In my practice, if I see the TR very trivial or almost no TR, I think the aneurysm is strong enough for keeping the device. I can try to close by device. But when I see TR a lot, it means the aneurysm is not so strong, and the roof of the defect is the septal leaflet of the tricuspid valve, and so it's not suitable for device closure. Regarding to the device selection for type D of the BMPSD, with a moderate hole, ideal one, I think the best one because it needs the size of a little bit bigger and leads to tricuspid valve entangling. For smaller hole, ideal 2 coil or MFO with retrograde approach, I think the best option for this type of PSD. And let me show you the case I did for inlet extension. The case is the opening axis is far from the tricuspid valve and small, and you can see no tricuspid valve regurgitation. And I think the defect is suitable for device closure. And I use the BFM coil. You can see the very good result, and you see no residual action, no tricuspid valve entangling. And for my conclusion, until now, no ideal device and also no ideal patient, no ideal morphology for PSD closure. And so we should understand morphology is very important for device selection. And we should prove that the procedure for VSD closure is not really difficult and procedure is very safe. Thank you very much for listening.
Okay, I think we have to go to the cat lab now because we run out of time. Dr. Supaporn and Bell, are you ready? Tell me what you have done. Can you hear me?
It is not clear. It's not clear. Can you hear us?
Yes, clearly, but can you hear me?
Yes, but it's quite.
We can hear you, but very, very soft sound. Yeah, like the murmur.
Wow.
Grade 1 or grade 2?
Grade 1 for me. Yeah.
Okay,
Is
can
it
you
better?
see?
Yeah, it's much better now. It's
Okay.
grade 2 now.
Now, you better tell us
Yeah,
what
grade
you
3
have
now.
done.
Yeah,
Grade 3.
yes.
Like a Venus hum.
Okay. Can you see the scene? Okay.
Like you change.
So after we have a hard discussion, after we left you.
But it's a fish cine. It's not moving.
Not play. Yeah. So we decide to deploy because Dr. Supha confirmed that she doesn't hear any murmur.
And because Supa is younger than me, so so my ear is not good enough.
Yeah, but okay. After we deploy, this is the LV angiogram, and we can still see the flow through the VSD shunt, but the device will attach, and the flow is not that much, and I think it's the flow through the device. So we're quite happy with this. So Dr. Nakarin, could you please show the echo?
Okay, move to the echo scene.
Echo big, please.
Echo. Okay.
Yes.
With a long axis view, the device still okay. The shunt, I think, is a central leak, but decreased from previously. Still no AR. And in the four chamber view, the device still okay. In central leak, and that's my TR, no more TR.
Okay.
So I'm happy with that.
Supa, this is Joko. I suggest that you make a hand injection angio at the aortic root to see the
aortic root.
I agree. Yeah, I would like to see also.
This is the aortic root. Yeah.
She read your mind.
Yes.
Super, sorry. Is it the same device or did you change it? Same.
It's the same
yeah,
device.
it's the same.
Yeah. It's the same device. Look like the device position change a bit. Yeah. More well aligned with the ventricular septum. However, we still see some flow. We try to look whether it's from another hole or not, but we didn't see from the echo and also from the angio. Yeah, so maybe from the central shunt. Yeah. So what's your next plan, Bill? Yeah.
From the
Hi.
angiogram, Supha, I think in pen A, I think the LVD is away from the aortic cast, but I'm not sure about pen B. What do you think about the disc and aortic cast? Can you solely
will show.
display the movie?
Yeah. Oh,
A little bit, right?
yeah, a little bit.
Oh,
The LEDs,
but in
some,
this frame is not a little bit. It look much. Okay, maybe the LVD is not too hard. I think it may not create the aortic regurgitation in the future. And
Yeah, I
because
think one of the
and I think because of there is like the connection between the device body and the RVD is like a knob. So there is like some movement that not against the movement of the heart. I mean that the LVDs can move along with the heart beat, along with the heart contraction.
Yeah, so one of the Ajahn Hamid would like to say that one of the a good thing about the MF4 is the softness, and then also as Ajahn mentioned that the fulcrum of this device is actually between the RV disc and also the body. So so that's why even if somehow we cannot avoid touching the aortic valve, but there's a place that the valve device can interact freely. So we did have the data at least more than 5 years, put the device in like this, for the subpulmonary VSD, sorry, for the pulmonary VSD, AR did not progress. That's one thing. And 1 year follow up for the subpulmonary VSD, we have also good result using MF4, right? So likely that this could be okay without problem with the aortic regurgitation. But yes, and as you can see, that maybe there's some residual shunt, but also we need to keep an eye on the hemolysis, as everyone keeps saying, but very unlikely to have for this, hopefully. And anything else Supha would like to say?
Yeah. I think for this patient, we have to keep an eye on the hemolysis. We will give the hydration. We will not give the aspirin, and we will do low the heart rate. Yeah, and carefully look for the hemolysis. Yes, and I will have to check my ear. Yes.
Thank you very
any
much.
Suggestion? Yeah, any suggestion?
Thank you very much.
or-
Excellent job.
Okay,
Yes.
thank you for all of us. Yeah. Okay.
Yes,
all of
but before we leave you, just on behalf of the person who be not completely in the team, but I would like to give this opportunity to from the audience and all the panelists, big round of applause to the team here, please. We've been working very hard to make this happen, because from day, I don't know how many days, but the day before this, they also come to rehearse and practice and everything, prepare anything, not just them, but also all the teams around. And yesterday was very challenging case, as you can see, and also today, even if the last case, we also have a lot of discussion going on. So this could not happen without support from these ladies and also their team. And of course, big round of applause to her.
Good job, Superwoman.
Okay, I think
we set up a cardiac intervention in Nepal.